Check one, two.
Bev, you want to make me a co-host?
Check one, two. Check one, two.
Thank you.
What's she wearing? She wore that the last ribbon cutting. Little girl, you look tired. Little Erin, last picture that she posted, she had that same outfit on. Your hair doesn't look like you did it today. Stupid things like that is what happens to me in space. I had the superintendent of schools make a comment publicly, said, I have a hard time accepting the fact that somebody my daughter's age is my boss. This is a touchy subject, not because I am whining or complaining. I'm thankful for it because I've had the opportunity to grow, to know what to expect, to know what people are going to say, to be able to preempt a lot of what I know is already coming. But things that
Check one, two. Check one, two. Check 1 2, 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 check 1 2.
Good afternoon, everyone. Welcome to our public hearing today. We are going to recess for just a few moments to wait for the other leaders to gather here with us. So thank you for your patience. Hopefully we'll get started in about 5 minutes. Thank you. All right, everyone, welcome back. We are ready to get started today. And before we do, I'll just offer an opportunity for opening remarks. Senator Anwar.
Thank you so much, Madam Co-Chair. We have important bills that we are going to be hearing the public, their views on them. And so we look forward to learning firsthand from the community members and the people who are going to speak. So looking forward to a good conversations today. Thank you, Madam Chair, back to you.
Thank you very much. Rep. Claridis Detria.
Thank you, Madam Chair. Welcome, everybody. Looking forward to hearing some great conversation from our 7 or 8 bills that we have today. Thank you, Madam Chair.
Thank you very much. And I will note that there are a number of other meetings happening, as is often the case. Today also happens to be Public Health Day and Appropriations. A number of the members of this committee, not surprisingly, also serve on the Public Health Subcommittee for Appropriations. So you may not see some of the usual faces here. And so I just wanted to make sure people were aware of that, and we will be catching one another up, and people will be listening in later to the recordings. So with that, I'm going to turn it back over to Senator Anwar.
Thank you, Madam Co-Chair. So we will learn from our first speaker for today. It's Mr. Darwin Fisher. Mr. Fisher, welcome. You're on. You may want to unmute yourself. Go ahead. Yes.
Good afternoon, Co-Chair Senator Anwar, Representative McCarthy Bahe, and distinguished members.
Wait one second, Mr. Fisher. We are having some technical difficulty. We do not hear you. Give us a second. It's not you this time. It's us this time.
Okay.
And your time is still being watched.
Thank you. We ready?
No, not yet. Just give us a second.
Oh, good.
Some of us can hear you. We want everyone to hear you. So
Thank you.
pausing the clock right now. Checking again. Can you say something?
Oh, hello.
No, still not. So give us a second.
Absolutely.
Try again.
Hi, my name is Darwin. Hello.
Almost there, but not quite there yet.
Getting there. That's hopeful.
Oh.
Mm.
Can you try again, please?
I will absolutely try again, so thank you.
Give us a second. Now we can hear you, but the quality of the sound has a little more adjustment. So bear with us for a second. We
Certainly.
want to hear you crisp and clear. So bear with
Very
us.
good. Very good.
We're testing our mic. Maybe Senator Rahman, if you want to unmute yourself and say something, we just want to look at the sound system. Or Representative Cabros de Gra. Anyone of?
Mr. Chairman, it looks good there.
Okay, thank you so
It
much.
looks good.
So we will have to be in recess. We are rebooting some of our systems because of the sound difficulties we are having. So Mr. Fisher, so sorry you had to wait for a little bit. We'll just have you wait for a little bit more. And we're so looking forward to hearing your testimony, but we are going to be in recess for a few minutes.
Very
So
good.
we'll be in recess. Thank you. Check. Just want to keep everybody in the loop. We are in the process of fixing the sound system. We are having some technical difficulties. We are in recess. Just wanted everybody to be aware. We are just trying to fix the issues that we are having with the people who are remote, and also somewhat for the people in this room as well. So once we fix that, we should be back on track. We're looking at various options. One of those options is to reboot the system. Another option is to even perhaps change the room. So we'll keep you posted. Somebody will be in to bring you some refreshments meanwhile.
Testing one, two. Okay.
Check. Yes. Right. Okay, we'll go ahead and reconvene our meeting. Thank you everyone for your patience. We apologize for the inconvenience. I know our first speaker is here as well, but we'll start with Mr. Darwin Fisher. So Mr. Fisher, you're on. Welcome. Thank you for your patience with us.
Thank you for having me. Senator Anwar, Representative McCarthy Vahe, distinguished members of the Public Health Committee. My name is Darwin Fisher, and I'm very grateful for this opportunity to testify in full support of Bill 1285, the act to establish an overdose prevention pilot. Now, the reason I'm talking to you here today is that I have 15 years experience actually working at a supervised consumption site. I was the manager of Insight for about 10 years and also worked in other capacities. I was there through the week. I was there on weekends. I was there during the day. I was there at night. I know whereof I speak. And I want to tell you that these places are absolutely nothing to be afraid of. When we opened Insight, there was a lot of worry and fear about what it would do to the community. It was studied and shown to have absolutely no impact on crime in the community. What it did provide was crucial and pragmatic health care for a very vulnerable population. It was shown to reduce overdose fatalities in the local area, reduce HIV transmission. We did thousands of wound care and drug testing and HIV testing. We did hundreds of referrals every year to drug treatment. So it was wholly beneficial for the people that used it. And more importantly, it created a sense of community and humanized this very vulnerable population. I would talk to lots of people around drug treatment, around all sorts of healthcare issues, but we also talked a lot about baseball, about movies, about politics and things like that. And that's important because that creates the space where vulnerable people will actually ask for help. And Insight was shown to be incredible at providing that care for people. It was also shown to have absolutely no impact on crime in the area. So don't worry, the sky is not going to fall if you open one of these places up. The earth is not going to open up. What you will have is a responsible community member providing pragmatic care for a vulnerable population and not working alone, but we work in tandem with the local police department, with social services, with mental health services, with other community members. So it's a partnership rather than a standalone service. It's a service that does not negatively affect the neighborhood. Far from it. It is a benefit for the community and a crucial benefit for a very vulnerable population that right now does not easily access any sort of care or fellowship. So I urge you to go forward with this bill. And I also want to say that you have the expertise in Connecticut to run this place superbly. I've worked with Liz Evans from Liberation Programs for many years in Vancouver, and she is an absolute powerhouse of pragmatic and compassionate care. So you've got the people in Connecticut who can run this place. It is absolutely nothing to be afraid of, and it will be a huge benefit, not only for people who use drugs, but for the community. Thank you for your time. I urge you to go forward on Bill 1285. Thank you.
Thank you so much for your testimony, Mr. Fisher. So I understand you've been doing this work since 2003. Is that
Yes.
correct?
Yes.
And we are quite a few years behind in the state of Connecticut. Could you? I'm going to ask you specific questions because the sound system still is having some challenges. But if you would repeat the fact that, to your knowledge, how many people have died from that facility being there, in the facility that is?
Easy answer, 0. There has never been a fatality in a supervised drug consumption site. That is the very point of it. And it makes sense because people die from overdoses because there's no one around to respond to them. If they're using with healthcare nearby, the chances of fatality drop to 0. We were very attentive always to people's health status when they were on site. So when we saw that someone wasn't breathing well or looked a little bit cyanotic or were pale, they got instant attention. They got oxygen, they got Narcan, they got what was needed. So as a life-saving measure, it's very basic and very pragmatic and totally effective. It's the other benefits that are very interesting as well. Access to treatment, access to employment, access to housing, access to shelter. The greater picture is also very important.
So if I heard you correct, there are more people who die in Connecticut in one day than the ones who died at the OPC in 22 years in Canada.
Correct.
Let that sink in for people who are listening. I'm repeating this because I think your sound is not coming as clear as it should.
I see.
And that's in a manner somewhat representative of the sound of the people who are working in this arena is not coming as clearly to the rest of the state. But so I'll repeat this, that more people die in Connecticut in one day than the people who have died in overdose prevention center in 22 years in Canada.
Just to restate, no one has ever died in a supervised consumption facility.
Thank you so much. And another question was, how many people would go for rehab? I think that's one of the, obviously, we know that if people die, they don't go for rehab. So we know that. But of the people who are survived and in the last 22 years, what is the percentage that have gone? I think I have heard in New York, it's been in the 50% range or more. And over there in your initial studies, that was in the 30% or so range. Is it increased? How is that working out?
Senator, my experience, I don't have the exact percentage or numbers there. What I can say is that working on a day-to-day basis, we would have lineups for people looking to get into treatment every single morning. It was my job for years to adjudicate that lineup because we had a treatment center above Insight, and there were other treatment centers in Vancouver we would refer to. But I can tell you, absolutely from experience, if you create the environment where people are respected and treated like human beings, the demand for those services is naturally very strong.
Thank you so much. And how is the city and the community that you're in treating you with all that's happened? Are they they're supportive? Do they realize the cost or challenges to the EMS system and beyond?
Yes.
And the law enforcement?
Yes. There is so much healthcare that goes on at Insight that is what we will call upstream healthcare, i.e. it prevents people, it helps people not to need to access emergency rooms, which is very expensive and not a great way to access healthcare in many cases. So the costs of prevention were noted and valued and very important. And we were recognized not only by the larger community, by the province, but also, again, by the police department, by the emergency services, and by the social services as being an important partner in healthcare. Not a standalone service, but an important part of that care chain.
Thank you. I'm sorry I'm asking so many questions because you have far more experience than we do. We have 0 days of experience and you have 22 years of experience.
Right.
Can you tell me about how the law enforcement is looking at this in your...
Incredibly supportive. We had a great relationship with the Vancouver Police Department. We talked with them a lot about what the site did so that they understood what was going on, and then we met with them regularly. In fact, they were incredibly supportive. They support harm reduction in general and Insight in particular. More to the point, we actually, with the VPD, Insight would co-tour, and we would bring people from police departments across the country to the site and tour them and explain how harm reduction worked in the community and how it worked alongside law enforcement. Not in opposition, but alongside law enforcement.
Sure. Thank you so much. I want to just look at my colleagues if they have any questions. Yes, Representative Claire Distreet.
Thank you, Mr. Chair. Thank you for being here with us today. You had said, did you mention how many harm reduction centers were available in Canada?
I did not, and though I could probably look it up on Google if I had the time, there are a lot of overdose prevention sites throughout Canada, yes.
And so did your statement say that no one's died in any of your overdose prevention centers in Canada?
To my knowledge, as I sit here, there's never been a fatality in a drug overdose site. Now, it's entirely possible that that may happen due to the fact that the drug supply is completely poisoned at this point. But the basic pragmatic approach of having healthcare witnessing drug ingestion means that if there are any adverse effects, the response will be immediate. And that in itself is the basic point behind supervised drug consumption sites. So the math is easy on that.
Thank you for your answer. Thank you, Mr. Chair.
Thank you. Representative Reddington Hughes.
Hi. Oh, thank you for joining us today. My question has to do with, this being a bridge to treatment that would direct the addicts to help in recovery. Because once the addicts are really taking away the drugs that they're on, the underlying problems are the things that really need to be dealt with. So how do you do that?
Time, love, and care. I worked at Insight not for a week, not for a day, but for over a decade. So I got a chance to see how people move, and it's individual. But the most profound experience I had was seeing people who were in incredibly straitened circumstances on the street and seeing, with access to insight, with access to relationships, with access to care, seeing how year by year they would improve their lives and move towards wellness. And by the time I was, after 10 years there, I was often working alongside people who had leveraged their wellness to the point where I'm now working alongside them as co-professionals. So every path to change is different, but the whole point is to not give up on people, to always be there for people and treat people as humans, no matter what the circumstance is, and to always be ready for another try at wellness. There's no other alternative to that.
Thank you.
Thank you. Representative Dauphiny.
Thank you, Mr. Chair, and thank you for being here to testify today. I think certainly there's a lot of empathy for the clients that you see in your treatment centers. My question is specific to, you had made a comment that you weren't sure how many people went to rehab, but do you know how many people have been rehabbed from going to these treatment centers?
Insight had a database of over 10,000 individual users. Now, that doesn't mean that they were using on a daily basis. That just means the total number of people who had signed up over time. A very, very large number of people had accessed that service. Out of the people that came there regularly, I do not have a number or a percentage, except to say that we operated, our recovery facilities operated at constant full capacity. So at a certain point, our capacity for treatment tends to ceiling out, doesn't it? But the avenue that creates the desire for treatment and the willingness to access treatment, that never stopped being I will call it a tidal wave of requests for treatment. So I don't have a percentage of people who are, i.e., cured by using Insight, but I can simply say that it creates the circumstances where people can work towards their own well-being in whatever route they need to take there. And the more that people are humanized and given care and access to care and options, the better we as human beings do. So simply providing that access to treatment, some people may never decide to take that, but the people that do, you need that there, and you need that in a space where they can feel comfortable about going through it.
Thank you for that answer. And just another question, because I'm not familiar with these centers at all and their locations, but if an individual went into the center and participated in their drug addiction there versus out on the street, there would be a difference in how the law would treat one versus the other. Is that fair to say?
Absolutely fair to say. The differences between using outdoors in the streets and in a supervised consumption center are profound. Now, they're profound legally because we have an exemption to allow the use of illicit substances inside insight. That protection does not obtain once you leave the site. More to the point, when you are using in public, you are at risk for overdose fatality, disease transmission, soft tissue infections. There are rigs left around. There's all kinds of liabilities, both for the community and for the individual who's using. So that simple act of moving people indoors into the light of healthcare, into a space where there is running water, nursing care, bandages, compassion, what have you, that movement is profound, not just legally, but in terms of healthcare, humanity, everything.
Thank you for your testimony. Thank you, Mr. Chair.
Thank you.
Thank you so much. Representative Martinez.
I wanted to ask if you have seen any data or have seen cases of things like hepatitis, domestic violence, sexual assaults. Have you seen the rates of those decrease with these facilities?
Well, I believe I cannot quote chapter and verse here. As I say, Insight was probably the most rigorously studied healthcare initiative in Canadian history, so that information is available. And I could get back to you with some of the particulars around that. I cannot speak to domestic violence, but I know in terms of, I would guess that in terms of hepatitis reduction, well, better hygiene, running water, all of those first world compliments, safer injection education, those things are huge in terms of preventing bloodborne disease transmission, whether that is hepatitis or HIV. So supervised consumption sites and harm reduction in general are very effective venues to reducing bloodborne disease transmission.
Okay. Yeah, I was wondering if you were gathering that information from patients' histories. And I just wanted to say, I think it's wonderful how impactful that ounce of compassion can be. I worked in the ER for many years, and I know that we have people coming in and they feel like they're the frequent flyers. They're not looked at even as people. So
Yes.
I think that compassion and being there in the right moment could definitely be the turning point. So thank you for all the work you're doing.
Thank you.
Thank you. Representative Reddington Hughes.
Thank you. I wanted to ask, would it be fair to say, I'm trying to follow the logic of everything here, that allowing the addicts the ability to inject drugs in the facility itself is seen as part of their treatment?
That's a very good thing to say. Yes, it's not often seen as the first step towards treatment, but introducing people into a situation where there is again hygiene, where there is fellowship and non-judgment, and where there is genuine interest in people, not just as pariahs or as objects or as apparitions, but as real human beings, that is profoundly impactful, and that is the first step towards wellness. And I don't push that on anybody. We don't coerce people at Insight. We simply create an environment, and they ask for what they need, and they need what we need. They need community. They need care. They need to see hope. They need to see where they can go. I found that the peer employment project that was a part of Insight that employed drug users was also a part of drug treatment and healthcare, because the structure that we get from work, the identity that we get from having a job and being employed, these were profoundly impactful to people in terms of their sense of themselves. We denigrate drug users. We treat them like pariahs in general. So to create a space where we actually focus on the human rather than on the drug use ends up becoming very impactful.
Well, thank you for your empathy and work. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we wanted to thank you, Mr. Fisher. And thank you for waiting for us for a long time today. So I wanted to just make another quick little announcement, as people in this room physically can see that the sound is still not perfect to the mark that we want it to be. So we are going to move from this room to room 1E. That is to my left. And so that's where we'll move. The people who are in the virtual space, just stay with us. We are just moving to the room. So we will be in recess for 5 minutes to make sure everybody moves there. Thank you. And if you get logged off, same link to log on. Check one.
Check, check.
We will reconvene the meeting again. Thank you so much, everyone, for your patience. And we will move to our listed speaker number one, Mr. Scott Burris. Mr. Burris, you're on.
Thank you, Senator. And thank you, senators and representatives, for inviting me to participate in this important meeting. I am a professor of law and public health at Temple University in Philadelphia, and I've worked in this area of law for more than 30 years. You're certainly going to hear today a lot about the evidence and experience showing that overdose prevention centers can save lives, can help restore civility to communities where they open and where drug scenes have flourished, and that they don't encourage new drug use. So I'm not going to say anything more about that. My brief as a lawyer is to say a few things about the legal issues, because there's a lot sometimes concern about whether this is a legal intervention. It's helpful to break that basic question of legality into two parts. First one being, does the legislature have the authority to authorize OPCs? And if so, probably the more important one to you, would that put the state in conflict with federal law? Well, I don't need to tell you that the answer to the first question is absolutely and resoundingly yes. The police power of the state of Connecticut, reserved to Connecticut in our national constitution, gives the legislature plenary authority to enact all manner of legislation for the health and welfare of the people. Given the purpose of an OPC and given the evidence of how they work, there really can be no reasonable question that they are a bona fide health intervention that the state legislature has the power to enact and to fund and otherwise support. That takes us to question two, the harder question of whether this conflicts with federal law. The specific law that has been raised as a barrier is Section 856 of the Controlled Substances Act. This so-called crack house statute makes it a crime to maintain a premises for the purpose of using illegal drugs. I've submitted a long article about this in the record, but in short, there are perfectly good legal arguments to make that Section 856 does not apply to public health programs whose purpose is to prevent harm and death. Two courts have looked at the issue so far in the Philadelphia Safe House case, and the two courts disagreed. Importantly, however, Safe House was a project started by a private group with no state or local authorization. State authorization, as we also see in Rhode Island, changes the legal analysis dramatically, because in considering whether or not a state law conflicts with Section 856, courts are instructed by the Controlled Substances Act itself to interpret the federal and the state statutes to be compatible unless there is a positive conflict between the laws so that the two cannot consistently stand together. All an open-minded court has to do here is look at what the crack house statute was worried about, which was rave parties and drug dens, and the purpose and evidence behind an OPC, to see that they are comparing absolutely apples to oranges, and that the two can certainly sit comfortably and companionably in the same legal fruit basket. One final word about the law. Politics. Experience has shown repeatedly that authorizing a program is only half the job. The other is to implement the law in a manner that does not induce new legal challenges from the community and political backlash. And that means working with the communities where OPCs will be cited to truly hear, understand, and meaningfully address their concerns. I'm happy to answer any questions, and thank you for this opportunity to say a few words about this life-saving possible legislation.
Thank you so much, Mr. Burris. And you are a law professor. I just wanted to highlight a few things. You're a law professor. You're not just saying that because it's your opinion. It's based on understanding of that law and spending 30 years from a public health law understanding. Is that fair?
That's correct.
And you're very gracious. During the fall of 2024, you were able to be part of a conversation. We had an informational hearing that the Public Health Committee had hosted. And you were one of the speakers, and you made a statement, and I want to just dig a little deeper into that statement. And you said that the argument that OPCs are illegal is insincere. What does that mean?
Well, I think that they're an attempt to apply a law that was intended to cover something completely different to a new situation. The idea that somebody in a health department or a legislature can look at the evidence, recognize a need, a medical public health need for the community, and take action to fill it by creating a space where people can do a dangerous thing more safely, and then say, oh well, yeah, that's just drug trafficking, that's just illegal drug use. There's nothing to that. That's that the sort of accusation that somehow people who are trying to save lives, like the witness you just heard, are in the business of promoting drug use. It's just insincere and lacks. I think a certain kind of a willingness to look honestly at a difficult situation and support people who are trying to deal with it.
And so if there's a public health official listening to this in the state of Connecticut, and you just said that the state has every right, like Rhode Island and other states have already pursued this. You said that the state has every right to be able to make this law and pass a law to allow OPCs. Did I hear you correctly on that?
That's right. We're in a federal system, and the states have the primary responsibility for the health, safety, and well-being of their citizens. And that's right in the Constitution. And that has to be considered when a state tries something new. For somebody in the federal government to say, oh yeah, we don't like that. We do Connecticut health differently. I think they're crossing the line of what a federal system should look like.
So, and one of the sloppy arguments that I hear from some people is that, well, the federal law is not allowing us, so why are we even having a conversation? And to me, it's not political. It's just not diving deep enough to look at this. Because this is going to be a critical question that will keep coming up for individuals who will find a reason to say no. Could you explain how this is played out in across the country and in some places, and also the Second Circuit? How will
of course
it'll play out in the Second Circuit?
Well, this is really not a new story, because remember, we had the same kinds of problems with needle exchanges. In those days, it was more of a local state fight, with local governments wanting to needle exchange and state governments saying that they couldn't. And by and large, the "of course we can" argument prevailed there. Then we saw it even more forcefully in terms of federal-state conflict with medical marijuana, where states increasingly wanted to make that available to their citizens, and the federal government kept pounding the Controlled Substances Act. And as you can see, the view that the states have the authority to make the decision about medical marijuana has gradually prevailed. They've prevailed mostly through politics and through the accumulation of time and because of public opinion, but their legal position was always pretty strong. And we're now going to see the same thing starting to see the same thing with safe consumption sites. You are now going to be the second state, in the region to take this on. Both the First and Second Circuits have, not had inattentive to public health concerns. And the courts in Connecticut in the past have deferred to the legislature on these matters. So you may recall that there was some litigation around the needle exchange and needle access interventions years ago, where some police in Bridgeport continued to arrest people for possessing needles, even though they'd gotten them from the needle exchange. And the federal court stepped in and said, no, the legislature has decided that people have a right to have these tools in order to avoid getting infected or passing on an infection of HIV. And so the courts backed what the Connecticut legislature had decided to do.
And Connecticut was amongst the first states that worked on the needle exchange, and we were actually the pioneer in the US and probably the world on that aspect. How did we just go 40 years behind now and 20 years from North America, 40 years from Europe to do what we were so good at in harm reduction and saving lives? What went wrong?
Well, if we think back to what the previous witness talked about, he talked about essentially successful solutions for large-scale drug problems need a lot of love. They need a lot of care. They need a lot of patience. They need a lot of services. If you provide those things, the history tells us, if we look at experience in other places, you can usually work your way out of a big drug epidemic. But it's hard to do that when you feel that when we deal with the stigma of drug use, when people are reflexively saying that anybody who uses drugs has made a really bad decision and they have to pay for that decision, or the only way that they will ever get better is if they hit some kind of rock bottom, that punishment and exclusion and isolation and incarceration are the only way to get people off of drugs. As long as those are sort of accepted prevailing attitude, it is really hard to do the more effective, kinder, gentler things, including providing people a place where they can inject safely and get access to services rather than die alone on the street.
So help me understand. So if let's say a public health official in the state of Connecticut says, oh, it's an illegal thing, and at the same time, another public health official in Rhode Island says, hey, we need to save our citizens. And another one in New York says, oh my God, we have to save our citizens like yesterday, save as many people as you can. And we will deal with the confusion if anybody else about the federal law. Is it an opinion issue? How do you navigate that?
Well, all of us lawyers interpret the law. That's our job. And basically, our interpretations are opinions until a judge who has the final word tells us. The judge gives you the actual legal fact. The lawyers offer legal opinions. However, it can often take a long time for a question ever to be presented to judges, and oftentimes it's never presented to judges. In my home state here of Pennsylvania, we have 2 needle exchanges operating in our biggest cities based on the cities having decided that they had the authority to do it. Some people have said over those years that they didn't have the authority to do it, but it's never gone before a judge. So legal opinion is enough for sure to allow people to proceed with what they're going to do, as long as it's a well thought out legal opinion and people are willing to stand behind it. In this particular situation, a huge issue politically is going to be whether prosecutors in the federal government in Rhode Island or here in Connecticut decide that they're going to do what the prosecutor did in Pennsylvania, and that is bring an action against the operation of a safe injection site. In the ideal world, that's avoided by political negotiation and consensus and convincing people that this is the right thing to do. I do think, however, that if push comes to shove, the fact that states are authorizing this makes the case much more powerful than it was in the Philadelphia litigation, and that states should proceed with confidence that they have a right under the Constitution and under the Controlled Substances Act to institute a life-saving measure that does not conflict with the purpose or intent of Section 856 or any part of the Controlled Substances Act. If anything, the Controlled Substances Act is supposed to be helping us not have a huge problem of rampant substance use disorder. And since we know that safe injection sites are going to reduce the harm of drug use, and since we're hearing that one of the things they can do is actually help people get out of substance use, they're fully consistent with the purpose of the Controlled Substances Act. So you should proceed, I think, with, this is just a lawyer's opinion, with considerable legal confidence into this action. And so should any health official in Connecticut who ultimately takes part in this intervention.
And another question, there are 1,100 people who died in our state last year. What rights do they have or their families have to say that you have something that could have prevented their deaths and you guys did not do anything, what obligation rights would they have, or their families have, or the future individuals who may be affected?
Well, they have the kind of rights that I think matter in a legislature in a way that they don't count in a court. They have a moral right. They have a right as human beings. Our Constitution provides limits on what government can do. It's fairly parsimonious about giving us positive rights. And it doesn't, or it hasn't so far been interpreted to give us a right to health or a right to government services. But you and I know that that right is there in the heart of our system, that we made this country so that we could build a commonwealth where we could all thrive. And that it's the responsibility of the stewards of that system, you all in the legislature, to use your authority and use your resources in a way that builds the greatest possible level of well-being for the people of our states.
Thank you so much. And I have one of my colleagues, Senator Summers. He's a ranking member. She has a question or comment. Thank you, Senator Summers.
Thank you. I don't want to take up all of your time. I think that we need to spread the questions around. I know that Senator Anwar is very passionate about moving this forward. My question is, I would like to see the actual data, which I have not been able to get my hands on, that the safe injection sites, yes, they reduce death, but do they actually work with people getting rehab and getting off of opiates? That data has not been able to be shown to me, number one. And what do you say when we are confronted here in Connecticut, if states have rights to do, whatever they choose, as you have said, on some level, our commissioners of our Department of Mental Health and Addiction Services have made it clear to us that they are very concerned and not supportive because of the potential lack of federal funding or the in exchange. And I know you've gone through that whole legalese on, well, you got to file a lawsuit, this, that, and the other thing, which I'm not sure that the state wants to, or the commissioner wants to entertain. Does that mean that the state of Connecticut could then say, you can come in and we will safely inject you with heroin that we know is actually heroin, if that is also for the public good? Do we have that authority under what you have just described? And where can I find the data, or where can my other colleagues find the data that shows, yes, we may save somebody from overdosing, but what is the long-term effect? Are they coming in continually to use the facility? Been able to find any good statistics? The statistics that I've had found showed that it did not improve the outcomes as far as being able to get off of opiates. So that's the information that I'm looking for. I don't know if you could direct us to that particular area, or if you have resources that you could be able to share with us. There's a lot of conflicting information. Yes, we may save somebody from overdosing and dying, but are we actually preventing them and helping them get into rehab where they will be off of opiates for good? We hear repeatedly from our experts at our Commissioner of Mental Health and Addiction Services, somebody has to be ready in order to want to move forward with rehab. So what is the true data? Where can I find it? That would be really helpful. And I have to run to another meeting. So if you have a chance to answer that, if great. If you want to just direct us in the right location, that would also be terrific.
Well, I think I would defer that to some of the later witnesses who are following that science more, and focus my answer on two things you asked about. One thing I think it's important to recognize in a time when there's a fair amount of frustration and backlash in many places with harm reduction programs is the misconception that they are ultimately meant to be a sort of complete or even significantly therapeutic solution to problems of substance use disorder. They are meant to save lives so that people are in a position to go to rehab later. That's how you have to, at least that's how I judge them. There may be some sign that certainly we've seen this in needle exchange, that they improve rate, or that people do go, they do prove to be a gateway, but I don't think that's their purpose. We need a lot more than
really
just
important.
these.
That's very important that you say that, because that has been not really specified as you have just mentioned. And that's how I see it. I see it as a intervention to save a life. It is not necessarily an intervention to get you into rehab and get you clean. It is strictly to save your life at that moment in time. And can you speak to if states have rights and you have somebody bringing in some kind of illicit drug off of the street where you don't know if it has fentanyl, you're not sure what it is. Yes, you can have somebody there ready with Narcan ready to go. So you're going to save that life. But if the states have the right to allow that to happen, even though it's federally illegal, do the states have the right to have heroin on site that they could inject that they know is not laced with fentanyl? How does that work?
I think this issue of safe supply is more complicated, actually, than the issue of whether you can have the facility. And that's in part because there's a lot more. There are all sorts of mechanisms for scientific research and for drug treatment, and there's FDA issues involved in using those pharmaceutical products for this purpose. I think it makes eminent sense to give somebody a safe supply of a drug rather than testing their whatever they found on the street, finding out how poisonous it is, having them inject it, and then saving their lives with Narcan. So I would say that goes on the list of things that we should be talking a lot more seriously about because they can save lives too. We also have seen in places like Switzerland and the Netherlands where they beat back pretty ugly drug epidemics in the past. One of the things they used was heroin maintenance because there were certain people for whom methadone just didn't work. So a controlled supply allowed them to return to something like a normal life and not die on the street. So I think it's a really important thing to think about, but I think that's probably for another day.
Okay, thank you for those answers.
Thank you. Any questions? Yes, Representative Mara.
Thank you so much for your testimony today. I am just curious, have you had the opportunity to litigate any of these facilities?
I personally was not involved in the Safe House litigation, which was the only litigation that we've seen.
Okay, and from the Safe House litigation, my understanding that it was not a positive outcome for these centers. Is that correct?
It was not. Although it bears saying that there are two very long, careful opinions written by first the district court judge who tried the case initially, and then by the Court of Appeals judge who reversed the district court. And they offer really sort of perfect arguments from a particular position. So I happen to think that the district court, who wrote a long and very careful opinion about the purposes of the Controlled Substances Act, the general interpretation of criminal law, and the role and purpose of safe injection sites, had the better argument. But you really see the two sides encapsulated there. And that's why I think that the difference in a state doing this versus just a private party doing it is going to be really important, because the state brings its authority and you might say right as a state to make health measures to bear. But right now I think it comes down to if I'm a lawyer talking about this, it comes down to whether you get a judge who is sort of a not very reflective drug war, get tough on drugs kind of thinker, versus a judge who's willing to take an open look at the facts and the law. And that's sort of what happened in the Third Circuit.
Okay, so to your knowledge, has there been any litigation around the two sites open in New York and the site in Rhode Island? And I'm specifically looking at, and you can correct me if I'm wrong, about the safe injection portion of these sites. No, I don't believe that there has been any litigation. There's no litigation that I'm aware of in either of those situations that's getting in the way of operation in any event. Okay, so thank you very much for that. I certainly appreciate it. Well, I actually do really like the idea of safe injection sites, But I find it really hard to understand how we can sit here and say that legally this should be allowed and legally this is okay when we have one lawsuit that went through for Safe House that said, no, it's not okay. And we haven't had anything from either New York or Rhode Island. So I guess I'm a little confused as to how you feel so confident in your statements that we are within our rights here in Connecticut.
Well, let's say that I feel very confident that you have the authority to enact health measures, genuine health measures, and I think this is one. When it comes to the question of what courts will do if it's challenged as being in conflict with the Controlled Substances Act, well, I have to say I'm more optimistic than confident. Let's put it that way. I mean, it will be a judge who decides. I am certain that there will be able lawyers on both sides, and I'm certain that some very serious legal arguments will be made on both sides. And I can say that the Second Circuit is not the Fifth Circuit. There are more judges who may be open to looking at this case on the merits and not in a context of whether or not you're tough on drugs or not. So that's why I'm optimistic. But there's no question that there's always a risk of litigation, and that's why I emphasize the politics. The best way to win a court case over any piece of legislation is not to have the issue go to court in the first place. If you can build consensus around the idea, not just among your colleagues and not just in your bureaucracy, in your health and mental health services agencies, in your health departments, but also among law enforcement, as we heard in Canada, and both federal and state law enforcement in Connecticut, the more you can be optimistic that your interpretation that it's legal will be the interpretation that prevails.
Okay, thank you so much.
Thank you. Any other questions or comments? Seeing none, thank you so much, Mr. Burris, for your testimony and the work that you do every day. Thank you.
Thank you all for your attention, and good luck with this decision.
Thank you. The next person on our list is Ruth Kenovi. She's not here right now, so we'll move to number 4, Courtney Dollar. Welcome. Oh, please don't clap. Otherwise, if you have two sides of the conversation, it gets a little out of control, if you could. But you can do the, yes, without the sound. Turn the, but yes, mic on. You see press the button there.
There we go.
You got it.
Okay. Good afternoon. So senators, representatives, and members of this committee, thank you for the opportunity to speak in support of Senate Bill 1285.
Closer to the mic a little bit.
Better?
Yes.
Okay. My name's Courtney Dollar. I still do not like public speaking, and yet I'm here again 2 years later to talk to you about this is something that's very important to me and my community. I am the Homeless Outreach Manager with Liberation Programs, and I'm a resident of Norwalk. Overdose prevention centers save lives and benefit communities. How do I know this? I'm from Canada. I've worked at an overdose prevention site. I've also worked in a low barrier emergency shelter program for people who use substances and a managed alcohol program back in Ottawa, Ontario, before I moved to Connecticut in 2018. Overdose prevention centers have existed for decades in Canada and other countries. They provide compassion, dignity, and care to our communities. They offer a range of harm reduction services, including drug checking, access to treatment services, and linkages to important health and social services. More importantly, they're a source of safety and connection and belonging within the community. Bad laws kill people. People are dying in their homes, in public bathrooms, in homeless shelters, and in the streets. They're not dying in overdose prevention centers. What we're doing here, despite our best efforts, is not working. We continue to be in a public health crisis, and we're tired. We're exhausted. Okay, I don't know how many people I've had to say goodbye to. We are tired of our friends. We're tired of losing our friends, our coworkers, our participants. Our drug supply is toxic. Okay, it's not about taking too much of a drug. It's not about an overdose. It's the fact that we don't know what's in our drug supply most of the time. Okay. We have the opportunity to try something new to us here in Connecticut that existed for years in other countries, something that research shows improves health outcomes, lowers death rates and reduces infections. This is especially important as xylazine in our drug supply is causing horrific wounds, and we continue to see the addition of other adulterants in response to the terrible idea that we can just criminalize this problem away. And for this to succeed, it's not about supporting OPCs. It's about ensuring that we are properly devoting funding and resources to support the wraparound services that OPCs provide. It means looking to other models of harm reduction. I love the fact that we've been talking about safe supply already. Other programs that are working in other communities, including safe supply programs, managed alcohol and managed opioid programs, and low barrier shelter options for people who use substances. Too many of our participants are being discharged from emergency shelters because of their substance use. These are supposed to be places for people to stay safely. Right now, we're in a cold weather activation, and we have a ton of people that we know that are unable to access emergency shelter because they're unwelcome or banned due to their substance use. One thing I want to emphasize is that people who use drugs have been our first responders throughout this epidemic. They were responding to overdoses and caring for their communities when professional services went remote only during COVID. They are experts. They need to be involved in all aspects of this conversation and the actions to create OPCs in Connecticut. There are going to be a lot of folks here talking who are in long-term recovery, and I love them for coming out and supporting us, but what's missing from this table are people who are actively using, especially as fentanyl has so significantly changed the drug supply.
Yes, you can. Thank you. Thank you for your testimony. Would you be able to help us go through a story of one individual who survived and went through rehab and how you were able to help out and also reducing the risk of infection, the skin infections that we're seeing, and how changing the medical part as well as the other component of substance use related part in individuals?
So I think that we're really focused on people going to rehab, and I have a different view of what recovery looks like for folks. It's not about their drug use, it's about what's going on in their lives, and that can look very different for different people, right? It might mean we help them do a housing application and they move into an apartment. They might reconnect with employment or families. They might finally see a medical provider, right? They may choose to start on methadone or Suboxone. But I think if we very narrowly look at what recovery or rehab is, then we're really losing an essential part of the conversation. People use drugs for a reason. And I also want to point out that there's a spectrum of drug users, right? There are folks that use drugs that doesn't significantly impact their lives in ways like we tend to see the folks that are most visible, the folks that do not have anywhere to go to use, they're using public spaces, and that has shaped our image of what a drug user is. Okay. Sorry, I don't know if that answered it.
This is very helpful. Yes. And I have two people with questions. We'll go with Representative Claire Distitra and then Senator Marks.
Thank you, Mr. Chair. Thank you for being here today, and you did a great job as a public speaker. It's just keep up the good work because I think that's very important to get your message across. One of the couple questions I have is, and I know people are curious with this, we like data up here. We're big data people. So we're getting people off the street from injecting their drugs, and we're having them do it in these safe injection sites, which is good. The data that would be helpful is once someone's in one of these safe injection spaces, what's the data for them then getting the wraparound services that they need, going into rehab? Because obviously we want them off the streets, getting them inside, and then hopefully getting the help that they need. So the ultimate goal is, one, not to die, and two, to become drug-free and get back into society. So I think those are some of the questions that people are curious, because I think that will help this whole conversation to make people understand the importance of these facilities.
So I'm not a super big data person, but I'm sure it exists. I know On Point in New York put out their results for the last 2 years, I think it was. So there are sites that do track this data. We can get that for you. But again, these are not intended to be this is intended to save lives. This is really what it matters. I don't know why we're so driven on once we save their lives, now we're going to get them off the drugs. What's happening is people are dying, and this is the intervention that we need.
Right. But we also want to use those wraparound services to help them with whatever issues that they're having. What got them to start using these drugs, because we just don't want someone to be using drugs for the rest of their life. That's not the goal of anybody that's using drugs, right? They start it for a reason. They don't want to be on it for the rest of their lives. We
Not
want them to move forward and continue on with their lives. I can't imagine anybody would want that. And I think that's what we want, everybody to be healthy and not continue using the drugs.
I do want people to be healthy, but I will point out that Connecticut recently legalized marijuana, right? And we have understandings of what drug use is, why people use drugs, right? We're looking at psilocybin being used in microdosing for mental health. We have ketamine being used for, again, to treat mental health. That my goal is not to get people off drugs. My goal is for people to be healthy and happy. And if that for them, that means to be abstinent from drugs, fantastic. I will support them. But if they want to continue to use and it's not significantly impacting their lives in negative ways, I don't, sorry.
Okay, well, thank you very much. Thank you, Mr. Chair.
Senator Marks.
Thank you so much for coming for your testimony. Because you worked in one of these sites in Canada, like I kind of picture what it's like in my mind, and what does it look like? And when a person goes in, how long do they stay? And just give me a little bit, like, because I want to make sure that when I'm visualizing it, that I'm thinking what it really looks like.
So the site that I worked for was actually a grassroots response to the fact that it was taking the city so long to open actual overdose prevention center. It was a group of social service workers, of peers, of people that use drugs that got together and decided that we needed to do something right away. And so we set up basically pop-up tents every night. And that site was open for a little over 2.5 months. And every evening volunteers would come out and set the tents up. I know there was a question before about like how communities feel about these things. We had members of the community cooking us meals and bringing pots of food and, you know, clothing donations. So for us, like the site that I worked at is very different from what we're proposing here. But folks would come check in with us. Like a lot of it was that social connection, just having someone care about them. Some folks would stay the entire evening that we were open. Some folks would come and use once and then go about their day. It really differed, but we weren't open 24/7.
Okay, thank you so much.
Representative Martinez, followed by Representative Zapkus.
Hello, you've done a wonderful job public speaking, and I'm so glad you're here with us today. I wanted to make a comment and just ask a couple questions. I do think that this bill is tough, even with the best intentions, because we know opioids are killing people, right? And it's such a big problem that it's really hard to find somebody that hasn't had a family member, friend, somebody close to them impacted. So even as a nurse, right, I've had people close to me impacted. And you think, you know, when you first see this bill, my heart and my head go a little separate, right? My heart goes, it's the last thing we'd want to do. You don't want to put them in with that. You want them away from that, right? But as a nurse, I mean, I know that I would like all my diabetic patients not to have diabetes. I would like all my cancer patients to not have cancer. And, you know, there's a chronic disease and treatment that needs to take place. So my questions for you is, what do you think is the most impactful part of this program? Do you think it's the compassion, or what is it that you think gives people the better chance at that turning point? And do you think that there have been successful models of proper education about this program as you've seen it?
I'm sorry, can you just, the last part, just repeat that? Sorry.
Yeah, I believe the education for a program like this is going to be imperative. So I'm just wondering, with any experience you've had, you said you worked with another program, right? If you saw that they had a good education program about it, if that was when the program started, if you thought like we can learn anything from the education process.
So again, it was a grassroots pop-up. It wasn't an organization that was running it. It was literally just a bunch of people that I knew. And I think a lot of the education happened in one-on-one conversations with community members. We can sort of rattle statistics all day long, but I think it really boils down to humanizing folks and humanizing people that use drugs. Everyone here, I think in this room, has been impacted by this crisis.
And the second part of that question was just, what part of the program do you feel has the biggest impact on patients?
The
What
fact that
component?
people aren't dying. I'm bluntly, it's literally the fact that we don't have anyone who has died at an overdose prevention center.
Thank you, Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming, and I apologize, I missed the whole thing. But when I did come in, I thought I heard you answering a question, and so I just want to drill on that for a second. So I'm not trying to put words in your mouth, so please correct me if this is not what you said. I thought I heard you say that you're not there to get people off drugs. You don't care if they do drugs. You just want them to be happy. Is that
and healthy and alive? I mean,
and
I'm a bit of a
healthy and alive?
radical here, and I know that.
I'm sorry. No,
I said I'm a bit of a radical here. I understand that that's not everyone's drive. But my goal as a harm reductionist is not to tell people what to do with their lives. It's to support them in, you know, whatever they need. And for a lot of the folks that I work with, they do engage in, there's a lot going on in their lives. I'm sorry, I lost track.
That's okay, because most
Yeah.
times if somebody, I know, like close people that have overdosed. I know people that have died. I know people that have been on drugs and finally got off. And I'm just asking because that's what you said. When you say that, to me, I think the goal should be to get people off drugs and not let their live their life, because I know people on heroin that can go to work and you think they're okay and they're really not. And so they're really not being productive or helping their life in any way. And so for me, it's about if somebody has a drug addiction, helping them through that, but then getting them off of drugs, because eventually drugs will kill you. It's just a fact. And if we have lots of people that are just, I mean, I represent a city, I see it. And so, not that I don't have compassion, because I do, for people, and I want to help them, and we should help them, but we should help them have a better life to get off of drugs.
So people use drugs for a number of different reasons, right? And I've worked with folks where, and this was a gentleman that drank a lot of alcohol. He was at the shelter every day, very intoxicated, and we got him into housing. And stopping drinking was not something that we talked about when we talked about housing stability for him. But we identified goals that he wanted to work on. And a couple months after he got housed, I came for a home visit, and he said, "Hey, Courtney, do you notice anything different?" I said, "No." And he's like, "Well, I don't have hard liquor here anymore. I just have beer that I drink." And a couple months later, there was no beer in that household at all, right? And that wasn't something that we talked about. Like, he didn't identify wanting to stop drinking, but what happened is things in his life changed so that he didn't feel the need to drink anymore. And that's sort of more of my perspective, is you can send someone to detox, you can send someone to a 90-day program, but if they were homeless sleeping in a tent on the side of the tracks before they went into program, and they come back out and they return to that exact same situation, they're probably going to use again.
And I know someone very close to me that's homeless and does the drugs and the whole thing, and it's horrible to watch. And I think people, this person has had all the opportunities given to them, and they've just chose not to use them. And so, anyway, I'm not going to debate that with you. I did have one other question. So, do you work, and if you've already answered this, I'm sorry, do you work at one of these sites?
No. So I did work for like basically a peer-led one. It was a pop-up tent site in response to the city taking a while to open. There were a few places in Canada that started these pop-up sites in response to the fact that people were dying, and it could be preventable. And so it's a little bit of a different experience than the sites that we're proposing.
So you
here.
live in Canada, not here.
In Canada.
Okay. Okay, because I don't think that, I guess my question was, did people come in and inject and use drugs in the places where you were?
Yep. So we picked a patch of grass that people were using to set up our site. We actually had a model where people could smoke their drugs as well as inject them.
And are those drugs illegal in Canada?
Mhm.
And you were still able to do that with it being illegal?
Yeah.
Hmm.
The police knew. The police came by. They would bring people to us.
Thank you.
Representative Dauphine.
Thank you, Mr. Chair, and thank you for being here today. You said you were talking about marijuana in the state and that we made it legal, and I just wanted to clarify that we say we made it legal, but we really didn't make it legal. If there were federal agents that were walking down the street and somebody were using marijuana, they could be arrested because federally it's illegal. And I can't help but think that that will transcend with many of the drugs that they will be using in these centers. They're illegal. So I don't know if you want to comment on that, but we really don't have legal marijuana here because it's federally illegal. And the same with the other drugs.
I haven't
Yeah.
heard of the feds walking down the street and arresting anyone for
No, no, I
I
agree.
understand.
I'm
There's
just
this-
saying that, technically they're not legal, and it just brings concern. But thank you for all the work you do.
Representative Reddington Hughes.
Thank you. I certainly understand the challenges, okay, that you have with a very compromised population, and understand that the love and and outreach that you do certainly makes a difference in their lives. With that being said, I think that the harm reduction centers, as we are learning, are really not, their purpose is not therapeutic. It is really to create more of a functional addict who optimally may be able to hold down a job and perhaps find a way to some sort of recovery. Am I correct?
I mean, I don't use the term addict. It's a person with a substance use disorder or a person who uses drugs. I think we need to be careful of the language that dehumanizes the people that we're talking about.
Okay, I'm sorry. I
Sorry.
thought we were talking about addiction services.
Um,
But,
These sites really, like, their number one goal is to stop people from dying.
Mhm.
Okay. And then the second thing is to treat them as human beings, to treat them with compassion, and to give them a chance to live. Right. And
my question is, having been in a position of being immersed in, populations where you see what does make a difference and you see what does not make a difference. Would you have any recommendations for states going forward with this in ways in which they could create programs that perhaps would encourage the participants in a very gentle and loving way to get therapy?
so again, what defines therapy? Right. It could be someone, yes, going to methadone. It could be someone going into a detox or treatment facility. It could be someone getting a mental health provider. It could be someone addressing their physical health conditions. Right. So it's hard to say because that definition is so broad and it's so individualistic. But I think really ensuring if this is what Connecticut is doing, ensuring that the funding is there to be able to provide all of those different services and not just look at it as one track to this one service that we're going to provide.
Thank you.
Thank you. Seeing no other questions or comments, I wanted to thank you, and you did very, very good. Thank you so much. Thank you.
Thank you. No clapping.
No, no clapping. Thank you. All right, the next person is Gina Sullivan. I hope I pronounced it right. If I did not, I'm sorry. And you can correct me, so, and I thank you.
Hi,
Hi.
co-chairs, ranking members, and members of the Public Health Committee. My name is Kalajna Sullivan. I'm a graduate student at the UConn School of Social Work, concentrating in public policy. and I am submitting my testimony today in strong support of Senate Bill 1285. I come to you today not just as a graduate student, but also as a family member of several people who use drugs. The Connecticut Alcohol and Drug Policy Council found that between 2012 and 2018, overdose deaths in Connecticut increased by over 290%. And I've heard some confusion here today about what overdose prevention centers really are. And I want to emphasize that these are places where people who use drugs can go and use drugs that they've already obtained elsewhere. They are not getting drugs in the center. They cannot share drugs among others. They solely can use what they bring into these places. They also have access to sterile equipment here and testing strips for their drugs as well to make sure that we're limiting the harms that these drugs are causing. Staff is on site, as you've heard, to answer client questions and provide social services on site as well. And this is a harm reduction approach. Harm reduction approaches acknowledge that substance use does exist, while also respecting the autonomy of these people and focusing on reducing the harms and increasing treatment rates. Obviously, our goal is to deter people away from these substances, but part of working with these people is meeting them where they are. 90% of people who use drugs have stated that if they didn't have access to an overdose prevention center, they would otherwise be using in a public space. These centers are a tried and true intervention throughout the world, and of the 40 global overdose prevention centers, not one has experienced a fatal overdose. Canada has reported less public drug use and decreased numbers of discarded syringes in surrounding neighborhoods, creating a better public health for the community. They noted a 26% reduction in overdose deaths. Portugal, who's been operating overdose prevention centers since the 1990s, reported cutting drug-related deaths by 80% and cutting HIV and AIDS rates by 50%. And in Australia, these clients were 38% more likely to enter treatment compared to only 21% of non-overdose prevention center clients. And I know that cost is also always a big concern. I know we've talked today about funding, federal funding. We've seen other centers getting these funds from private donations. And one study that I looked at found that the healthcare system actually spends about $41 million a year on overdose, or on opioid overdoses. And the study found that if 1 to 4 overdose prevention centers were implemented, between $800,000 and $2.9 million would be saved in costs. And they would also save between 19 and 37 people from dying. In my experience, I've noticed that people who use drugs will not remain in recovery or treatment unless they choose to do so. And it's crucial that they have the ability to choose when they seek treatment, not only to promote their individual autonomy, but because they're the expert of their experiences. And as I close, I ask you to consider the public health benefits, not just for people who use drugs, but for the public communities surrounding them and their families and loved ones. I urge you to ask yourself, what if my loved one was suffering from addiction? Thank you for your time and consideration.
Claudina, thank you so much. In 3 minutes with so much information, you put in empathy, you put in kindness, you put in human touch, and you put in data. So many of my colleagues, we've had an informational session. We talked about the data and I still hear, where's the data? So can you repeat some of the data that you had and come closer to the mic so that people hear it? And
Absolutely.
And you have a written testimony so that we can actually send that data to the people, individual email, so that there's no confusion whatsoever?
Yes, I
Thank
do
you.
have printed copies as well with me if you'd
No,
rather.
if you can just send it and upload the testimony, that would be good where everybody reads.
Perfect. Yes, so one of the studies I looked at was evaluating a overdose prevention center in Rhode Island, and 90% of the people using that center stated that if they didn't have access to it, they would otherwise be using in a public space like a public park, in the street, other areas in the community. Canada reported a 26% reduction in overdose deaths, and Portugal reported almost an 80% reduction in deaths, also by cutting AIDS and HIV rates by 50%.
Can I just intervene in between? So when you say reduction of deaths, there were no deaths happening in the OPC, but the deaths were in the larger community. And the larger community had a decrease because the people who were using it were not using in street corners. They were using it at the OPC and the entire death rate decreased. Fair?
Yes.
Okay.
Yeah, and in Australia, I know that we've talked a lot about treatment rates today. Australia clients were 38% more likely to enter treatment compared to non-clients who were only 20% likely. So even though that might not seem like a big gap between the two, that is a huge amount of people that are getting access to treatment. And, you know, as I've said, forcing someone into treatment doesn't mean that when they leave, they're going to continue treatment. That is where the harm reduction approach really takes a step further by acknowledging that this is your choice and it's up to you to be able to stick through it. And if you don't want to, then we're here to help you minimize the harm that it's going to cause to you.
Thank you so much. We look forward to your testimony in written form and share with others. Representative Upkis.
Thank you, Mr. Chair. Thank you for coming today. Are you from here, Connecticut?
Yes.
Great. Okay. I have some questions on the bill, but are you familiar with the bill? Have you read the bill?
1285?
Yes.
Yes.
Okay. So part of it is a big discussion we have in this committee is the CON process, Certificate of Need process. And in this bill, it excludes safe injection sites from the CON process. And so I was curious about your thoughts on that.
Personally, I do not know much about the certificate of need process, so I don't think I'm the most qualified to
that's
answer
fine.
that question.
That's fine. I was just curious. That's why I had asked about the bill. So one thing you can help me with, and it's my last question, can you walk me through the process of a day? So I come in, I'm a user. What happens?
I personally have never been at an overdose prevention center, but from my research, based on what I know, these people can come in and they may not be even using drugs to go there. They may be going there to access treatment or get help with housing applications. They may be going there just to shower and have access to a clean bathroom. You know, I think that there's so many different aspects of these centers that can help people, even if they're not using drugs. I think it's a really great way to build the public safety of the community and something that's really necessary in Connecticut.
I would agree with you. I find it interesting that you're a proponent of this bill, I would assume, and never visited one. So I would suggest you go visit one. And I am glad to hear that it's for shower. It's like a homeless shelter because they do the same thing. They provide a bed, showers, those kinds of things. I was really interested in when someone comes in and uses, do they just go sit in a room and are high for 8 hours or whatever it is? Can they stay there for out? Like that's kind of what, but if you've never been there, I could ask someone else.
So they have usually a consumption room where people use, and then there's other areas of the center where people can remain in the center if they want, or sometimes people just leave after they use. But the consumption area itself is separate from everything else in the facility. I do know that.
And is there an age, do you know, and maybe you don't, is there an age limit on like, can a 10-year-old go in? Can a 18-year-old go in? Can a 80-year, is there a?
I would assume
anyone just comes
no.
in?
I would assume that whatever the state law is for using substances such as that, I would say probably 18 or 21.
Well, for heroin, it's illegal, no matter
Yeah.
how old you are. So if
Yes.
somebody wants to go in and smoke pot at 21, they could do that. But, okay, thank you.
You're welcome.
Thank you.
Thank you. Senator Marks.
Thank you, and good luck in your studies. I just want to tell you that I too am a proponent of this bill, and I have never visited a site. So maybe you and I can go together. Okay.
Maybe.
Representative Martinez.
I just want to thank you for your testimony and being so well read on this subject matter. This was a new subject for me, but it's really great to see some few looking at community approaches. Again, as a nurse, I've seen so many patients that start out with pain, with prescribed medications that they were given in their communities, by their treatment providers. So to completely discount treating this as a community issue, I think that this is a great light that you're putting on this. And I just really thank you for looking at other approaches, because obviously what we're doing and what we're saying isn't working.
Thank you.
Well, Gina, seeing no other comments or questions, I just wanted to make a comment quickly. If all the social work students are as good as you are, we are in good hands going forward. So thank you.
Thank you.
Thank
I
you.
really appreciate it.
Thank you. Next person on our list is Catherine Anderson. She's remote. Miss Henderson, you are on.
All right. Can you hear me okay?
It's very, very well. Thank you.
Lovely. Thank you so much. And thank you for the opportunity to speak today to this committee. Thank you so much for your commitment to considering newborn screening for Duchenne muscular dystrophy again this year. So my name is Catherine Anderson, and I'm the Community Research Manager at Parent Project Muscular Dystrophy. And I'm here to strongly advocate for the addition of Duchenne to Connecticut's newborn screening panel through the passage of HB 5710. Duchenne is progressive and systemic, and it gradually takes away a child's ability to run, hug their loved ones, and even breathe independently. There's no cure yet, but Duchenne is treatable. Early interventions make a critical difference, and we now have 8 FDA-approved therapies that, when introduced early, can help children maintain their mobility, protect their heart and lungs, and live longer, healthier lives. Right now, families often notice delays in their child's development around age 2, but the average age of diagnosis has remained close to 5 years old for decades, despite efforts to change that. And many people are diagnosed later than that. And in Duchenne, changes to the muscles start in utero. So this type of delay can lead to irreversible damage to their muscles. And for families, the diagnostic delay is agonizing. I hear from parents regularly who say, I knew something was wrong, I pushed for answers, but we lost years for our child. And these families do everything right, yet they're still forced through a maze of unnecessary tests, misdiagnoses, and costly visits before they ever receive the answers they need. And Duchenne can affect any family. It is a genetic condition, but about 1/3 of cases arise from a completely random genetic mutation, meaning any newborn can be affected from any family. And the only way to ensure that all families have an equal chance at early intervention is through newborn screening. Without it, too many children will continue to be diagnosed too late, missing that window where treatments have the greatest impact. And the power to change this reality is in your hands. By adding Duchenne to Connecticut's newborn screening panel, we can bridge decades of medical advancements with this early detection, ensuring that no child's left behind in their care. Connecticut does already have the tools to do this. The laboratory equipment needed for Duchenne screening is already being used in your lab for another condition. Connecticut has multiple clinics with special certification for care in muscular dystrophy and Duchenne. The resources are ready. Newborn screening gives families the clarity and time they need to make fully informed treatment decisions when it matters most. And I urge this committee to renew your support for Duchenne newborn screening by passing HB 5710. Help ensure that every child born in Connecticut has the best possible start in life. Thank you for your time and consideration.
Thank you so much for your testimony. Thank you. Can I ask you, why has CDC dropped the ball on this one? Have you been able to understand that?
You mean in terms of Duchenne being added to the National Recommended Uniform Screening Panel?
Yes.
So we are working through that process. The nomination is with that committee. Federal decisions are very, very long time coming in general. And this is a committee that is particularly challenging to move through in an efficient way. Right now, the biggest ball dropped is that the most recent committee meeting was supposed to take place earlier this month, and it has been indefinitely delayed. We don't know when this committee is going to be able to meet again, when they'll be able to make these decisions. So it is we love that the states have these opportunities to implement conditions through their own mechanisms because that federal process is so challenging.
I tend to agree because this Public Health Committee recently, a couple of years ago, we have approved CMV screening as well.
So vital, yeah.
Yeah, and the CDC has not done that yet. And then we feel that CDC is so behind in some of these areas, and a lot of our young children are getting harmed because of these delays. So your testimony helps reaffirm the importance of this one. Representative Mara has a question or comment.
Thank you so much for coming forward and testifying to us today. I have seen the effects of this in a child that lives in my community, and I'm hoping that his mom is going to be able to come and testify today. And she contacted me a couple of years ago on this, and I am wholeheartedly supporting this and wanting to see this through. I just wanted to let you know, and I would like to have you comment on it. DPH did submit testimony. I don't know if you had a chance to see it, and I don't know if they're going to actually speak today, but I just would like to read to you what this testimony says and get your comment on it. It says DPH currently estimates that adding Duchenne's to the newborn screening program would cost at least $660,000 total over 2 years, and this cost is not included in the governor's proposed budget. Therefore, we cannot support the bill at this time. Can you please give me your thoughts on what you think $660,000 over 2 years means to you?
Financial resources for this type of screening are absolutely important. I think that thoughtfully thinking through what those numbers are is critical. And I can't directly say, here's what Connecticut has, here's what they need to buy. I imagine that that incorporates some degree of like manpower as well as technical power. However, what I can say is that I actually just met this week with the team that runs the laboratory that developed the FDA-approved kit for this screening. This screening looks at a biomarker called CKMM, which is released when muscle is damaged. And what I learned is that it costs about, confirm from my notes, $1.25 per sample run on an individual to purchase those kits and run them. The machine that is used in your laboratory is called a GSP machine, a genetic screening processor. It's already being used for congenital hypothyroidism. And based on the numbers that come through Connecticut, the GSP machine is made by the same laboratory as well. So I asked them about that. Sort of they expected that another machine would need to be purchased. Those can be expensive. I can't, quote that this is absolute plain truth, but they expected that based on the numbers, how many children are born, that you likely wouldn't need another machine. So I think those are the questions I'd really want to boil down how that 600 plus is divided across the resources needed for screening.
Oh, thank you so much. I appreciate your comments on that. And I guess, I sit in the Energy Committee right now, and I see how much we spend here and there on our electric bill. And I think when I see that DPH is not going to support this because such a small amount as $660,000, that wouldn't be a line item that we would even think about talking about in the Energy Committee. So I think that that was a shocking comment to me, and I appreciate you coming today. Thank you.
Thank you. Seeing no other questions or comments, we appreciate your testimony. This will help us quite a bit.
So much.
And we move to the next person on our list, which is Carol Jones. Welcome, Ms. Jones. Thank you for your patience with us. You're on.
Thank you. Good afternoon, Co-Chair Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Carol Jones, and I thank you for this opportunity to testify on behalf of Alliance for Living and myself in full support of the Senate House Bill 1285, an act of establishing an overdose prevention center pilot program. You've already heard from others about the cost effectiveness of an overdose prevention center, as well as the health impacts and community impacts. I'm here to talk a little bit about the personal impact and the potential this bill has for assisting individuals with support and non-stigmatizing care that in itself can be the blueprint for lives filled and lived with promise and less trauma and shame. I injected drugs for 22 years. And during those 22 years, I lost touch with my family, my children, my friends, and all of the interactions with community beyond the people that I used with and the daily details of surviving. I was filled with shame and guilt, but in the throes of this medical condition that was bigger than just wanting or being able to stop. My life became a revolving door of prison, the streets, sleeping in hotels some nights and on back porches other nights. There was nowhere to get support or camaraderie or acceptance. The shame was the impetus to use more and to stay numb. I lost so many friends to AIDS, hepatitis C, and drug-related infections that would have and could have been addressed by OPCs via access to sterile supplies and medical care on site. I am lucky that the drugs that I used 30 plus years ago were not the same as what people are using today and carry the same odds of overdose and dying. I am also lucky that 35 years ago, while I was in prison, I met a woman who volunteered in a prison writing program, and she treated me like a human being. She didn't just treat me like an addict that she wanted to change and she wanted to talk about my drug use. She was interested in me. She talked to me about life. She had discussions with me about the world. She never once had a discussion with me about why wasn't I going to stop using drugs. She just talked to me like any other person. And the interaction made me feel like I mattered. And that one relationship changed something in me. I started to change slowly, but incrementally. This is what these centers do. This is the very, very subtle kind of thing that happens that when people are talking about, can you tell me how many people go to treatment? Can you tell me what happens? It's the connection. It's the connection that occurs when people feel that they matter, that they're seen, that they have some worth, that they can start opening up and discuss the reality of their lives with another individual. It's when the magic sometimes occurs. I am who I am today because of this. And when we keep people alive, it is possible that they will start to feel that they matter as well. Today, I'm the director of harm reduction in an agency, and I work with people that come to us for services, come to our drop-in center, and I'm serving myself. I'm serving the person I once was. And
Excuse me, Ms. Jones, but your time, you've reached your 3 minutes. Thank you.
Oh, okay. Well, I hope that you can hear the importance of, I'm carrying naloxone with me every day. Everywhere I go, I hope that I'm able to find someone if they're overdosing. But this is one other way that people will feel safe and supported in their daily life and their community. Thank you. I can't hear you.
Can you hear me now?
Yes.
You do?
Yes.
Okay, good. So the question I wanted to ask you was that this whole concept of meeting people where they are and accepting where they are and who they are, how does that change the perspective of a person, and how does that make a difference? Walk us through that because this is something that our society needs to understand, and I know a lot of people are listening to this.
Well, I think for me, and I can only speak about me and also about what I see where I work, is that when you're filled with shame and guilt, and when you're also already not feeling good about yourself, and the world has stigmatized you, and someone else spoke about this, and you're treated differently, and when you go for help somewhere, all anybody talks about is, oh, you're a drug addict, or all you care about is drugs, that you internalize that shame. And so when a person is interested in You, who are you? Tell me about Carol. Oh, has a joke with you. Oh, cares if you eat, cares if you have some rest, cares if you can come in and just sit down and have a cup of coffee. People feel that there's a connection. As Mark Jenkins said earlier in the day, connection is the antidote to addiction. And connection works. It's the way that we can reach each other, and it's the way conversations happen, and it's the way relationships happen that lead us to believe in ourselves. That's what happened for me. Incrementally, I felt like, oh, I matter to someone. And I started to think about possibilities that I might have in my life.
Thank you so much. Senator Marks has a question or comment, followed by another.
Hi, Carol. Can you hear me?
Yes, I can, Martha. Hi.
Hi, Carol. I have the privilege to call Carol a dear friend. So, history repeats itself. When we first started the needle exchange program in the great city of New London, it was on the front page of the paper. Everybody, the community thought it was going to have such a hazardous effect, and we didn't get a lot of it. The program, certainly had to prove itself in order for it to be accepted. Now you don't hear people talking about the needle exchange program. It happens, and it stops people from getting HIV/AIDS. And so do you foresee, you and I know our community very well. I think you've been doing this for a few years now.
Yeah.
So do you foresee the community having the same response if we were to open an overdose prevention center in our city?
Absolutely. We now are one of the harm reduction centers in Connecticut. We're one of the 3 chosen sites. Our harm reduction center works right along adjacent to our syringe services program. The city is very supportive. Individuals come here, they get respite, they get rest. We have mental health care on site. We have primary care on site. We have food. We have access to sterile supplies, and we have navigators that can work with people. And if they desire treatment, they're right there to get them into treatment on demand. So there is no reason not to support us. We have the support of the city, and I can say that even people that work for the city have called to access our services for family members.
Thank you, Carol. So proud of everything that Alliance for Living does.
Thanks, Martha.
Thank you, Representative Morin Bello.
Thank you, Senator. Carol, can you hear me?
Yes.
Okay, good. Thank you for sharing your personal story with us and helping to humanize addiction. My question is in line with what Senator Marks was saying about the needle exchange. Do you feel that being able to have test strips to test the drugs that people are bringing in will also help in reduction of deaths and illness?
That it's one more tool in our box. I think that, there are people, Courtney spoke to this before, there are different people use at different levels. We have people that are chronic users and people that use occasionally. And for people that really use occasionally and are not aware of the drug supply, it's really important, that a lot of people have used cocaine not knowing there may be fentanyl in it. They come in, they want to use the test strips. And I think that's one tool in a huge toolbox of which OPCs are part to address the needs of individuals who inject drugs.
Thank you. With the uptick in fentanyl in drugs, seems like it would be an additional good tool to have.
Yes. And we have xylazine test strips as well. As you heard, the influx of xylazine in the test supply has a real impact on wounds and the need for wound care with individuals. So these are all really important pieces of prevention.
Thank you. I appreciate your time.
Thank you, Rep. Mara.
Thank you, Senator. Thank you so much for speaking today. I'm just, as we're looking at this bill, I think we've obviously we've passed a lot of the issues around this bill in the past with the harm reduction units. The one extra that this one adds in is the safe injection site. So I appreciate that your community has supported the harm reduction unit. Have you had any outreach with the community or your local police officers around safe injection sites?
Our police officers support our police department supports the SSP, and it supports our harm reduction center, since overdose prevention centers have not been enacted here yet. We haven't had that discussion with them. However, that they've been, really in favor of our harm reduction based programming here, and work closely with our mental health navigators and our substance use navigators as well. They know the work we do, and they're very supportive to us. Obviously, if the state backs us, if this passes, then that would be a discussion we would have.
Okay, and a lot of acronyms around here, and I think I know them all, but SSP, you have me confused.
I'm sorry, Syringe Services Program. It's
Okay.
It's the needle exchange program.
Okay, so yes, so they're supportive of that, and they're supportive of the test strips, and they're supportive of your harm reduction unit, but you've not
Yes.
yet had a conversation with your police or your local community about safe injection sites. That's correct?
We have not.
Okay. I think that would be some information that I would like to understand as we move forward, because it looks like we, if we pass this bill, that there'll be, is it up to 4 or is it 5 that would, 5? 4. 4 that would be allowed for safe injection sites. And I think it's really important. We do know that there are communities that really do support this, and that there's been outreach. And I think if we move forward, I think that's got to be a conversation where the whole community needs to be involved in that decision. Thank you so much.
I can say that I think, based on the number of overdoses that occur and the number of times that people have been called to overdoses that are, that are unattended, that folks aren't there, that it's a really a big impetus to push for this. And also, I don't see, with as supportive as our city has been around this, that they would be any differently inclined. But, again, we haven't had the conversation.
Thank you. I appreciate that comment. And I do think the conversation does need to be had. Thank you.
Thank you. Seeing no other questions or comments, thank you for your testimony. Appreciate all the work you do. The next person on our list is Mark Jenkins. Welcome.
Good afternoon, members of the committee, Senator Anwar. With all due respect, I have to start out and say I'd be remiss if, and I believe Courtney alluded to it, but some of the language from this forum is offensive. When you refer to people as the addicts and talk about the drugs, it insinuates a you versus us, and it's offensive. It's degrading. And this is part of as a harm reductionist and as the founder of this organization, it is also my obligation to educate you on how to address things that are effective, things that are not. We talk about this work right here, and you've heard Carol and others, and I'm really trying to temper my anxiety right now, because this is an emotional, this is like, I've been in this work now for over 30 years, and having seen all of this come from afar, from the HIV epidemic through, the crack epidemic, and to see this now, and to see, how this didn't become an epidemic until white kids started dying. So long as it was in the Black community, all was well. So until people started dying in Hyannis and in Avon and Simsbury and folk that look like yourselves started knocking on your doors, these weren't issues. So this right here, and you have experts that look like you, that sound like you, that are reputable. This is, we're not reinventing the wheel. What we're seeking to do is find the language that makes this palatable for you all to make a decision to save lives, because everyone seeing here who hears you hears that this is an offensive subject to some of you. So how do we impart language? How do we make this digestible for you to accept, to allow a pilot? Not we're doing this forever. We're saying this Senate Bill 1285, which we support wholeheartedly, is a pilot. It's saying, let's give you the data that you seek right here in Connecticut. We can give you data. We have with SSPs traditionally given everyone the data to see where we've had cost effective. We have the efficacy, we have the evidence, we have everything to show that these public health initiatives work, but they're still not embraced. Why? Because they're offensive to our morals. In most cases, they're offensive to our morals. That's where the battle comes in. Listen, my organization, and we have the state's first drop-in center. In its first year, saw 18,000 people, 18,000 visits, excuse me. And I see my time is up.
Yes.
Actually, could you tell me a little bit about your center and what happened?
18,000 visits, 675 unique individuals. Treatment referrals every single day. We're on first name basis with most of the treatment centers around the state. We also have and operate a mobile medication assisted treatment vehicle. We're putting in, our space at 557 is the only thing necessary now is for you all to say, hey, and we're here in Hartford. So I invite you, come out, have a visit. You don't have to go to Rhode Island. You don't have to go to New York. We are not a supervised facility, but everything else is in place but that. We have distributed over 70,000 doses of naloxone since it's become available. The highest, we dispense more naloxone than anyone else in the state. We support over 50 organizations in reaching individuals at this level and making sure they have the supplies, resources, and things, and the education necessary to, as I say, we love everybody. That's what separates us. We love everybody. Some we love to see come, others we love to see go, but we love everybody, and I can give you, numbers where, we as an organization, we had last year 5,684 unique individuals cross the pedestals of our offices for over 40,000 transactions. Now that's not counting the folk that just come in to get food, the folks who just come in to get something to wear, the folks who come in and possibly need access to shelter. That's just the physical transactions of us making a syringe exchange, which we did over 1 million. We distributed over 1,100,000 syringes as an organization and made sure that over 900,000 were retrieved so that they're not out there in the streets. So we have 2 forensic tools to test drugs that's available not just to the populations we serve, but also if law enforcement, as long as it's not punitive, needs access. The naloxone over 70,000. And when I talk about that, that's, not counting what we've given directly to locales and to law enforcement organizations. So, we exist to be a helpmeet, not just for the people we serve, but the community and other organizations at large, as well as to this circle here.
Thank you so much. I have some of my colleagues who have some questions. I'll start with Representative Claire DeSteter.
Thank you, Mr. Chair. Thank you for being here today. It's nice to see you. We all, I can probably speak for everybody, we appreciate everything you do and the fact that all of you, whether you're here just for support or to testify, that's very important to us because we're here to learn from all of you. What's important to you, what lessons you've learned. If you want to do something in this state, you're coming to teach us, to plead your case as to why you want us to vote for this. I think it's important to hear it because there's amazing stories that we're hearing every time someone stands up. The fact that you said it's offensive to your morals, to me, is insulting because it's not, I don't think it's our morals. People don't know about it. Maybe a little ignorant, but not offensive to morals. That's your job. You're teaching us what we need to know so we can make an informed decision. So again, thank you for being here today. I appreciate everybody being here and talk more. Like I said before, we like information. That's why we're asking these questions because we don't know about it. And if we get the answers, it helps us make a better, more informed decision to help the residents of the state of Connecticut. Thank you for being here. Thank you, Mr. Chair.
Thank you.
Thank you. Do you want to respond or it was more of a comment? Right.
Yes.
Yeah.
And when I say it was a very general term, when I say the public at large, a lot of these initiatives, the public health responses that are most effective, it turns out they rub people. They're not seen. They're not seen as something that they're warm to. So whether it be and that's where it comes. It's not just education, but even being able to disseminate it so that that information can be received. Because a lot of times, again, there's already a wall that goes up. There are barriers. So how do we reduce those barriers so that people can receive the information that might be offensive, might just not have the proper education on the terms?
Thank you. I think Rep. Zamara has a question or comment as well. Rep. Mara.
Thank you, Mr. Chair. I'm questioning whether I need to say anything or not. I'm obviously a big advocate in this space. You and I have talked before on the phone. I'm not sure that we've necessarily spent a lot of time face to face. So I do want to respectfully say that pulling the race card on an illness that sees no race, that sees no income gap, that sees no gender differentiation, I think is unfortunate here. That this is not about race. This is about doing what's right for everyone. So I think that kind of upset me when you put that out towards us, especially those of us that have been in this space and working hard to make sure that this has been seen. And I know that my colleagues are very sympathetic to this issue. So if someone slips up every once in a while and says addict instead of person dealing with addiction, it's not out of, they're not trying to be mean. They're not trying to be insensitive. Maybe they don't know, but I think maybe trying hard not to be offended, try hard not to offend, try even harder not to be offended. And I think we can all work together. Thank you.
Yes, ma'am.
Thank you. Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming today. I remember when you came last year, I think this bill was before us. And I said at that same time, thank you for doing what you do. It's not easy work, I'm sure, but it is needed work and you're very good at it. And I want to thank you for doing that. We sit in these positions to ask hard questions, all kinds of questions. we have to think of it as a big picture, a whole, how it affects individuals, people that are for it, against it in all different ways. So when we ask questions, it's not personal. It's not pointed at certain, well, it could be pointed at certain things to get answers that we need to make decisions. And in the end, we all hopefully could agree to disagree if we don't agree. Because I do see everybody as a human, whether I'm black or white. I know you said people don't look like me and all this. Well, when I was a young girl, which was many years ago, I sat on the phone all night with somebody on drugs very close to me that was going to commit suicide. So I've been there. I'm not a therapist. I don't know how to handle it. I just loved them. And thank God they pulled through. So as far as not looking like somebody, we're all bleed red blood. We all have compassion and empathy, hopefully all of us. My kids don't look like me. If you saw my kids sitting next to me, you would never know they're mine. So it doesn't matter. We're all God's children, and He made us all, and it doesn't matter what anybody looks like. I want everybody to be healthy and as successful, meaning not just wealth in any way, for a happy life. So I just had to say that because it did bother me. I think you're right, addicts, whatever the words are, but it all works, right? So I think we all have to have empathy with each other, and understanding that it's our job to ask hard questions. That's what we're here for, and to make the best decisions that we think we can make for everybody. I do have a question for you after all that being said. When you, well, I guess these aren't, do you try to, in your work with people, get them off drugs?
I'm a person in long-term recovery. I'm a person that didn't get it the first time. I have 17 inpatient treatment centers under my belt, jail in 6 different states and 5 psychiatric hospital stays. I've not found it necessary to use a mood or mind-altering drug since April 6th of 1997. So I believe I eat, sleep, and drink this. I'm a harm reductionist. I am a harm reductionist. It is my job to assist people in staying alive and to allow them to be okay with themselves until they're ready for what's next. If that is medication-assisted treatment, methadone, Suboxone, if that's inpatient, I'll lie, cheat, and steal to find a bed to place them in. That's part of what's been the history of what makes the myth of Mark and the streets. Is that if you want a bed, go see Mark. Mark will get you a bed.
I'm sure you will.
And my staff will tell you, I'm in their ask constantly. Are you asking those questions? Are you we have a treatment on demand model. We have 6 mobile vans that ride around with their flags, and people can wave them down just like they would ice cream trucks. But instead of ice cream, they're going to get crack pipes and syringes and access to whatever we have, sandwiches, treatment, and we're going to transport them to treatment.
Right, but you don't, and it's just a question. So you don't encourage or give out materials or something to help maybe steer them to get off of drugs?
We have all types of printed material, and it's all about the person being healthy. See, harm reduction says you can try for abstinence or not, but let us help you keep your life and the lives of those around you safer until you're ready for that point. And when you're ready, that's when we're ready. That's when we try and have as many hours public facing, and that's 17 hours a day, more hours than anyone else in the state that's on the street and trying to keep our doors open. We have harm reduction centers in Hartford and in New Haven. We have, we're part of homeless outreach. We want to make sure that when folks say they're ready for treatment, that we have the ability, if we can't make that placement, then can I call a shelter and say, listen, will you hold this person until we can get them a bed in the morning? That's me.
Right.
That's what the mission of my organization is, to make sure that we can help people when they're ready to find whatever it is that they need.
Great. Thank you.
Thank you so much. Thank you for the comments and thank you for the exchange. I just want to make a quick little comment and then I'll have others speak. I was just thinking that meeting people where they are works all directions. And this is what I learned from harm reduction myself, that as I was going through my personal journey and learning about various things, I was not meeting people where they are, whether they were in my family or community. And I'm passionate, so I see people and try to make a difference. And the harm reduction taught me how to meet people where they are. And in my journey, it's made me a little better. I'm still striving to continue that. But I also recognize that when I'm not in agreement with somebody on the political front, I meet them where they are, because it's a journey, because everybody comes with a clear heart to make a difference, because nobody would do it otherwise. Everybody comes here to make a difference. And that's the beauty of interacting with all my colleagues in this building. I know Representative Martinez has a question or comment. And then Representative Gilchrist after that. Yes.
First of all, I just wanted to say thank you. Thank you for your testimony. Thank you for all that you're doing in the community. And I do agree with you 100% that this is a moral issue. You said in a much more eloquent way what I was saying earlier when I said, people think about this in one way and they think, I don't want to see heroin. I don't want to associate heroin. Heroin's wrong. Versus what are we doing now? What are the community approaches? And you just put that in such a better way. And it's ironic that obviously our treatment centers do not have 100% recovery rate, but this approach is getting scrutinized like every person has to meet a recovered rate. So thank you so much for all you're doing. There are plenty of statistics that show that anybody with substance abuse issues that looks like you versus somebody that looks like me, that I have access to more resources. And that is very clear. So thank you. Please keep doing what you're doing, and consider politics and consider running, because we could use more of you up here.
Representative Gilchrist.
Thank you, Mr. Chair, and thank you, Mr. Jenkins, for being here and for the work you do. And I would love to take you up on your offer to come for a tour. I just, felt compelled to share that it was this very committee that created a commission on racial equity in public health and declared racism a public health crisis. And so you addressing very documented research about how there are structural and systemic racism in access to prevention and harm reduction and treatment is incredibly important. And as we're discussing language going forward and what is offensive, I would just ask colleagues to look at the history of the term race card and might not use that going forward. Thank you.
Ooh. Representative Kristen McCarthy-Vahey.
Thank you, Mr. Jenkins, for being here. And I'm grateful to be here with my colleagues and that we're able to have this conversation, difficult as it is, because you are right. You named that the emotions are high. And why is that? Is because lives are on the line. That's why, because this is a life and death discussion. And I appreciate that, as I think Senator Anwar said, meeting each other where we are, and we're all in different places in terms of our education, experience, background, knowledge. And you come to this with a kind of background and knowledge that very few people do. I want to share a statistic and then ask you a question, because I do think conversations around class and race are very difficult to have, but they're very central to the conversation in order for us to be able to adequately protect and provide for the needs of our residents. I represent Fairfield and Bridgeport, and between 2015 and 24, Fairfield, which is a town of about 65,000 at this point, had 59 overdose deaths. We are 84% white in Fairfield. Bridgeport, next door, with a population of about 150,000 and about 35% white, at 679 overdose deaths. So there is a significant difference with that. And I think, that said, I think it's hard to have those conversations sometimes in ways where, you know, people feel that they are being told that they don't have concern and compassion about it. But I also just want to acknowledge we all do come to these issues differently. And just in my work in local prevention, harm reduction is a difficult concept for many, many people. Some of you know, I have a candy addiction. And while people may laugh at it, I would like to eat less candy. I can't imagine eating no candy. And I don't make light of the addiction that others have faced, but some of the people up here know about me and my candy, but I think about that in that tiny little way. So my question for you is, and this is not something you need to share with us today, but perhaps you could share with us some of your demographics in terms of the populations you're serving and the differences in if you are collecting those demographics in not just race, but income, so that we can have an understanding too, because I do think that those are very real issues that we're facing, and it would be helpful for us to understand that from you.
So collectively, when we combine our African American and Hispanic populations together, it generally runs between 51 and 52%, versus, you know, if we did it singularly, we are the most people we serve are white. The age ranges again from 65 to adolescent, you know, around 17. And I do have all, trust me, statistics, data is something that we have. Everything we have is documented. And again, I'll make sure each of you have my business card really quick and can reach out to me or just shoot me a text, and I'll make sure Misha Lay, she's in here somewhere, will make sure that you have any data that you need. But yes, it goes first white, Hispanic, and then Black. However, disproportionately, again, the Black population is most affected now in terms of overdose or fatalities.
I thank you very much for that, and I look forward also to visiting. I'm long overdue, so thank you, Mr. Chair.
Thank you. Don't go away yet. Don't go away yet. Quick comment. So I was fortunate enough to go and visit your site, and I took some pictures with you. Actually, you can put the cards on the side and we can pick it up later when we leave. So I had the opportunity to visit your harm reduction center in Hartford, and I put my pictures with you in there. And so these medical students reached out to me and say, well, we didn't know that you knew Dr. Jenkins, and we want to go visit Dr. Jenkins. So I sent them your way. I said, you got to meet Dr. Jenkins. Thank you for taking care of them. Thank you. Seeing no other questions or comments, Dr. Jenkins?
If I can, just real quick, you know, because the statement has been made several times about harm reduction being about meeting people where they are, and that is true, but it's also about not leaving them there. It's about helping them get to the next place.
Thank you. Thank you. With that, our next speaker is going to join us online, which is Anna Jane Yolkin. And AJ, thank you. Thank you for your patience. Welcome.
Yes, absolutely. Can you all hear me?
Very well.
Okay, perfect. Thank you, Chair and members of the committee. I'm here to testify in support of SB 1285. So my name is Anna Jane Yulkin. You can call me AJ, and I'm coming here via Zoom from your neighborhood state of Rhode Island. So I'm here wearing two different hats. One is I was a legislative lobbyist that helped pass our bill in 2021 to authorize the use of overdose prevention centers in the state of Rhode Island. And then after I worked on that bill, I switched and I moved to a nonprofit organization called Project Weber Renew. And we are actually the organization that is operating the Overdose Prevention Center in Rhode Island. And so I really do want to touch on both of these experiences. I heard a lot of committee members asking, what does an overdose prevention center look like? Like what, how are you navigating all these issues? And so I'd love to talk and really frankly answer questions that you all may have about what this looks like, really not only in the US context, but in the New England context as well. So in doing work as a lobbyist, I spoke with over 100 different policymakers, and I really heard a lot of things that I'm hearing in this committee. People knew that too many of their neighbors, their loved ones, their friends, and their constituents were dying, and that there was something that needed to change, and that we really needed to take new approaches. I also heard, and I really think that this especially is a moment, that this is an opportunity for states, and especially smaller, more public health minded states, to take a lead and really take leadership and use what is in their state authority and through city and state health departments to take legislative action to change lives. So in our law, in Rhode Island, not only does it authorize the use of overdose prevention centers, it also provides important liability protections of overdose prevention centers, and it has the Department of Health create a regulatory framework. So we are actually now, as an overdose prevention center, licensed and regulated by our state Department of Health. So it's really through a partnership with the state that we're able to run this center. So now sort of talking a bit more about what it looks like on the implementation side. We've been open for about a month, so we are very, very new. However, at this point, we've seen almost 200 visits. I just checked a few minutes ago, we're at 198. We've had 14 overdose interventions and 50 people who have used our on-site medical and behavioral health services. Once you walk into the Overdose Prevention Center, it's really a comprehensive range of services in one location. On the first floor is our drop-in center where people can receive clothing, food, showers, laundry, really just get out of the cold. On our first floor is also our medical suite where we have a full-time nurse, behavioral health clinician, and a part-time doctor who will see clients without an appointment, no insurance necessary, really to have as low barrier care as possible. And then once you go to the second floor is our consumption space, or really what this bill would authorize the state of Connecticut to do, where people can consume substances. The space is large, it feels very comfortable, and it's all peer run, meaning that the people who are working in the space are people who have experience with drug use and also have that really important trust and rapport with our clientele. People go to that space, they can consume substances in different ways. Again, that space is regulated and licensed by our state Department of Health. And then once they are done with that, they can be referred to our drop-in center and also to those medical services. We are funded by opioid settlement dollars that our state attorney general negotiated with all the pharmaceutical companies that caused a lot of harm. And having state authorization allowed us to access that funding that allowed us to open. So that's another really important benefit of having state law.
Excuse me, Ms. Yulkin, but you reached your 3 minutes.
Thank you so much, and I'm happy to take any questions.
Sorry, AJ. Thank you so much for your testimony. And thank you for your hosting us. I was able to visit the site with Livia Cox and look at it firsthand as well. And you guys are also doing some amazing work there. Could you tell me a little bit about the people who are coming in and how that's affecting them and the community?
Absolutely. So I just want to extend the invitation. Once you take up Mark Jenkins on his invitation to visit the site in Connecticut, you all are more than welcome to come into Rhode Island. So of the people who are coming in to use the Overdose Prevention Center, about 92% of them say that they would, if they were not at the Overdose Prevention Center, would be using in a public place. And 75% of them said that if they were not in the Overdose Prevention Center, they would be using alone. Almost everyone we're serving is experiencing homelessness. So that is the clientele we're serving. It's about 60% people of color who we're currently serving and 99% very low income. What we are seeing is that people who are coming in are really being shown that love and compassion that you've heard so many people talk about that's so important. People are coming in knowing that they will be safe, that they will be loved, that they will be able to get the services that they need, and that they don't have to have shame and stigma for their drug use. Again, because it is a peer-based staff, really there is that trust there that I think helps enable people to feel comfortable, and that trust that also, people are able to, our peers are able to live by example. So if someone is, wants treatment, wants other services, they sort of say, I've done this myself. So those are some of the things. I'm happy to answer more specific questions as well.
And AJ, in this journey that you had to do from the passing the law, how were you able to educate the state agencies who are sometimes a little concerned to make sure that they are not stepping on any areas that they should not?
Yeah, absolutely. So I think in Rhode Island, the way education of state agencies worked was really through people who understood that that a public health approach was necessary. Like it sounds like Connecticut has, we have a longstanding history in supporting harm reduction measures such as needle exchange, and a really long history of taking a public health approach to overdose as well. So there was that foundation. It was really through one-on-one conversations and showing the evidence, and also a coalition of people coming together, both from the recovery community and the harm reduction community, who said, we are sick of people, people in our community dying, and that happening. Again, because Rhode Island is a bit of a small state, it's really through those one-on-one connections and communities that we're able to do that. We have also done really extensive community outreach in the specific neighborhood where we are located, and we do have a lot of both municipal support and neighborhood support as well.
Thank you. And I want to ask you more questions, because what Rhode Island has done is amazing, and you're already saving lives. So, we are now a few years behind. We were probably going to be ahead of you, but we are behind now, and we don't want to be more behind than we already are. But can you help us understand, how were you able to convince the governor and the public health and the DEMAS equivalent bodies over there?
Yeah, absolutely. So it was really through relational organizing, through one-on-one conversations with key stakeholders at places like our Department of Health, our Executive Office of Health and Human Services, Governor's Office, and obviously the legislature. We had lobbyists at the State House basically every day, myself included, who were having conversations one-on-one with lawmakers. And what we found is that many lawmakers, as you all probably have as well, had personal connections, knew people who had died of overdose, and really knew that we needed to take a different approach. We also are really grateful here in Rhode Island to have leading research experts at Brown University who study overdose prevention centers. And so we were able to bring in their expertise as well to not only talk about the evidence base, which is very, very robust for overdose prevention centers, but also to, offer, and now they have funding to do so, to evaluate our program as well. So it was through those conversations, and I think it was also through being in the middle of COVID, when we took drastic measures for public health, right? And so, knowing that we could do this for an infection such as COVID, also seeing that we could take bold action for things like overdose as well.
I think your last sentence is also very powerful, because everybody got together with a single-minded agenda, and we were able to fight COVID and survive, and despite all the difficulties and challenges we have had, and we have not put that kind of a focus on this issue. and then perhaps that's what is needed. Can you just talk a little bit about the law enforcement agencies? Because over here, the ones who have been involved in the community, the law enforcement is very much on board. The ones who have not been directly involved, they have some concerns and hesitancies. How were you able to overcome some of those difficulties?
Yeah, absolutely. So we've had positive relationships with our local police department in Providence. That's where the center is located. They really see this as a resource, and we really see ourselves as a way to take some of the work that is often placed on police departments off of them. Same with EMS. We are taking some of that work off of them. So we've had really positive relationships. Again, they have been very community minded and very public health focused. And so that has enabled us to really have a positive working relationship. And same with our state attorney general. We don't have district attorneys in Rhode Island. We just have one state prosecutor, understanding that this is authorized by our state legislator, and that we have their support, and so also their support when they negotiated the opioid settlement dollars, which ultimately some of that funding went to us. So it's really, again, through those conversations, through understanding that we're all on the same page. We want our community to be healthier. We want our community to be safer, and that this is another tool that municipalities and states can use to do that, and that we're here as a resource for them as well.
And did you have, help me understand, because the opioid settlement fund, your attorney general was also involved. What kind of process did you have? Because there are some difficulties people understanding the use of the opioid settlement funds for this kind of purpose. How did you overcome some of those hurdles?
Absolutely. So our attorney general, the way it works in Rhode Island, I don't know how it works in Connecticut, is our attorney general negotiated lawsuits with several different entities. Those funds are mostly put into our state's Executive Office of Health and Human Services, and they distribute the funds through competitive bidding processes. So, and there is a committee that provides oversight and guidance as to how those funds should be used. So that's sort of the overview of how that works. Because we had state authorization at the time that the opioid settlement dollars were negotiated and that funding was released, the committee that oversees decided to make it a priority area to fund overdose prevention centers, specifically knowing that we had state authorization to do that. So they put out a formal bid the way they would for any state funding. And then we at Project Weber Renew, along with our clinical partners, VICTA, who provide the nurse, behavioral health clinician, and doctor, applied for those funding and received that funding as well. So that funding is through one state agency, and then we're licensed and regulated through our Department of Health, which is another state agency.
Thank you. And AJ, you have been so helpful. We may seek your help to perhaps some of the sister agencies in your state reach out to our agencies to have a conversation about that. We would, if that was an opportunity, we would love something like that.
Absolutely. And again, I do want to emphasize this has been a really amazing partnership between Project Weber Renew, a nonprofit, the state agencies, and our municipality in the city of Providence as well.
Good. I also, one of the things, I've looked at your bill and the regulations, and I think the way you have structured the bill was that you made the law very simple, but you actually had a lot of regulations, and you created a body to make the regulations, and the regulations are quite in depth, which keeps the protections and everything in mind, but it did not bog down the entire law in the process, and those regulations are now publicly available too.
That is correct. And I think that's important because that leaves a lot of the nitty gritty to the regulators, and those can also change over time as necessary if and as the program needs to change.
Thank you so much. Seeing no other questions or comments, I so much appreciate your help in helping us visit the site, listen and look at the whole process, and also following up on a number of issues. So thank you.
Awesome. Thank you so much.
Moving to the next person on the list is Jim Williams with American Heart Association.
Yes, hello, my name is Jim Williams. I'm the Government Relations Director for the American Heart Association, and I'd like to thank the leadership and members of the Public Health Committee for providing me with the opportunity to provide brief comments today in strong support of House Bill 6974, the use of funds in a tobacco settlement fund, which would require funding of tobacco control programs at the current CDC recommended amount of $32 million a year to prevent and reduce tobacco use. As many of you are aware, Connecticut spent $0 on tobacco control between 2016 and 2021. Then in 2022, and again in 2023, with your support, Connecticut invested $12 million. This funding was then paused in 2024, and the governor's most recent proposed budget that is being heard currently restores the $12 million in annual funding. For that, we are very grateful. However, as many of you know, the CDC recommends, as I mentioned, that Connecticut spend $32 million annually on tobacco control, which is what I am advocating for today. Please keep in mind that Connecticut receives every single year more than $400 million from the multi-state master settlement and from tobacco product sales revenue. So $32 million is a small portion of that we're asking goes to tobacco control. Why should this funding be considered smart funding? A couple of statistics for you. States that offer comprehensive smoking cessation therapy to their employees in the public health programs or in the tobacco control programs can save $1.10 to $1.40 in healthcare expenditures and productivity for every dollar spent. It has been proven that cost savings are the result from established state tobacco prevention and cessation programs. A fairly recent American Journal of Public Health study found that for every dollar spent by Washington State's tobacco prevention and control program between 2000 and 2009, more than $5 were saved by reducing hospitalizations for heart disease, stroke, respiratory disease, and cancer caused by tobacco use. A study of Arizona's tobacco prevention program found that the cumulative effect of the program was savings of $2.3 billion between 1996 and 2004, which amounted to about 10 times the cost of the program over the same period of time. We know that tobacco control efforts save lives and saves money. Please support funding it at the current CDC recommended amount for Connecticut as this bill proposes.
Thank you so much, Jim, for your advocacy and the work that your organization does.
You're
Are there
welcome.
best case models that you have seen in various other states that have had the highest ROI from these settlement funds?
Well, in my written testimony, I outlined some of the success stories. One that I did not mention is a 2003 studied or published in PLOS 1 found that between 1989 and 2008, California's tobacco control program reduced health care costs by $134 billion, which is far more than the $2.4 billion spent on the program. Researchers attribute these savings to reductions in smoking rates and cigarette consumption per smoker, generating significant savings in healthcare expenditures. So almost all models that we have available to us to view, you do get a higher return on investment than what you put into the program.
Thank you so much. Thank you. Seeing no other questions or comments, we'll move to the next person on our list, which is Catherine Hill. Catherine, welcome. Thank you for being here.
Thank you. Co-Chair Senator Anwar, Representative Carthy McVahey, and distinguished members of the Public Health Committee. My name is Katie Hill. I'm here to testify in strong support of Bill 1285, an act establishing an overdose prevention center. I'm a PhD candidate in epidemiology at Yale School of Public Health, and the main focus of my research is on substance use, harm reduction, and novel substances in the unregulated drug supply here in Connecticut. And through my research, I've had the opportunity to work with many of the great harm reduction organizations in this room and around the state, including Alliance for Living, Liberation Program, CTHRA, and more. And I've also had the opportunity to work with them through our shared action in the statewide harm reduction partnership, or SHARP. The first time I visited and toured an overdose prevention center was in 2022 in the downtown east side of Vancouver, Canada, a place called Insight, which you heard a little bit about today, which has been open for over 2 decades and was the first legal OPC in North America. When you first walk in, clients can receive harm reduction supplies, much like people can in our state of Connecticut. So things like our syringe service programs or SSPs. However, if you keep walking to the back of the building, there's a private room with booths where clients can use their pre-obtained substances. Afterwards, I sat with folks in their chill out lounge, and there's a coffee bar operated by peers. There's a TV on, and folks can just relax, stay warm. Mind you, it was in the middle of a Canada winter when I was there, and they were just making sure everyone's okay after they're using. In some ways, it was so incredibly simple, but also so revolutionary for me. And after 20 years and almost 3 million visits to this OPC, Insight has decreased overdose deaths, reversing 12,000 overdose with 0 overdose deaths, reduced HIV risk behaviors, demonstrating it prevents 80 HIV infections annually, estimating annual savings of $13.7 million in HIV-related medical care, provides referrals to much needed services. In fact, they provided 70,000 referrals to needs like housing, treatment for substance use disorder, and primary care in the last 20 years. And after seeing this amazing work in this location and was doing for people in the community in the downtown east side, I became inspired by that work and was really hopeful that we could someday have an OPC like that here in Connecticut. I saw in my research that what was happening in Insight in Vancouver's downtown east side was happening over and over again, reliably all over the world. And we're seeing the same stories pop up just down the road in New York City on Point, and also in Rhode Island over the past few weeks. And honestly, OPCs are evidence-based solutions that saves lives. It's really just that simple. And since visiting this OPC, I co-wrote the AMERSA, which is the Association for Multidisciplinary Education and Research in Substance Use and Addiction position statement in support of overdose prevention centers, which I'm happy to provide. In this statement, we describe how OPCs can help reduce transmission of infectious diseases, increase access to healthcare services, and improve social connections, and of course, reduce deaths related to overdose. Thank you so much for your time today. Thankful for y'all's time. And then interest in this important issue, and happy to answer any questions you might have.
Thank you so much for your testimony. What's your PhD thesis on?
So I'm working right now on the topic of xylazine, which has come up a few times today. It's an animal tranquilizer that is in most of the unregulated fentanyl supply here in Connecticut.
Do you know it's not controlled substance in Connecticut?
Yeah, so I think, it's come up a few times today, and I think it's a very interesting topic, kind of how it relates to OPCs even. It's in mainly the unregulated opioid supply, fentanyl supply, as we've talked about, and a lot of folks don't actually know that it's in their fentanyl supply. I've actually done interviews with folks that use drugs all across the state in collaboration with many of the folks that are in this room, interviewing folks that use drugs all over the state. And because it's in the supply and a lot of folks don't know about it, because it is a horse tranquilizer, an animal tranquilizer used for mainly horses and large game, it has really strong sedative impacts. And so what happens is it essentially knocks you out. It's a very strong sedative. And then, so if you can imagine, if people are bringing their pre-obtained substances into a space like an overdose prevention center, they are now able to use their drugs at a safe place, a warm space. And so now if they were, in a space where they're warm, comfortable, they're safe, right? And if instead they were using their substance that had xylazine in it and they were somewhere unsafe, let's say out on the streets and they're homeless, they could have their belongings taken. They could, I've spoken to women who have used xylazine and are incredibly worried about the potential of being sexually assaulted, have their belongings taken while they're heavily sedated due to xylazine. So these are all potential things that we have talked about that I think an overdose prevention center would be potentially very impactful for people that are using drugs.
Can you talk a little bit about what happens with crime in the communities where there are OPCs?
Yeah. So I think for one, I know I handed them out earlier, but I think there's a fact sheet that I handed out. I think specifically the one on community impacts from opcinfo.com is a really great resource that I would suggest for folks to look at. And it's free for the public. But it goes over a lot of the main things that are kind of what we would consider for crime. I think the first thing to consider is what I just talked about, right? I think when people think about crime in OPCs, they often don't consider what would happen for folks that are using drugs themselves. These are also people that are part of our community, right? And so the reduction in crime for people that are using drugs themselves is also very important. They now have a safe place to consume their drugs, and while they're consuming their drugs, they will also have a reduction in crime for themselves, right? So they have a safe place to put their belongings. There's often lockers at the OPCs. We mentioned, AJ had mentioned in her testimony just right before me that you know, a lot of the folks that are using these OPCs are currently unhoused, homeless. So they may have a locker to put their belongings. This could be the difference in them not having their stuff stolen, right? They might be able to, you know, instead of being out in public while they're under the influence of drugs, they're now safely in the OPC. So now they don't have the risk of having a public intoxication nuisance call, right? So these are all these potential crimes that are not, you know, they are not at risk for. So those are some potential things that we're going to be looking at. So the main thing that I think we can consider here that is also on the fact sheet is reductions in public drug use. I think that's really the major one. Folks are obviously going to be, instead of using out in public, you know, in a park, on a park bench, in an alleyway, on the stairwell of a church, they're now going to be using safely inside of an OPC. We're also going to be, because they're now using inside and they've been able to obtain their syringes, their pipes, whatever they might need, they also will be able to dispose of those materials. Some folks might refer to those as drug paraphernalia, dispose of those safely inside of the OPC. And so we've also observed through numerous studies globally that there's been reduction in litter, drug-related litter, which just makes sense, right? Instead of being able to just dispose of them, folks certainly try, you know, maybe they're using in a Dunkin' bathroom, instead of throwing it away in the Dunkin' bathroom, they're able to dispose of them right at the OPC. So we see also reductions in drug litter, which is really great. Some people, you know, might think, is drug use itself a crime? You know, I think we could certainly have a whole conversation today. I think we've maybe have some gone back and forth on that. I think, you know, we have precedent to say that in the moment of an overdose, we have the Good Samaritan law that sets a precedent for, in the moment of an overdose, the health of a person takes precedent, right? For the health is the more important than the actual drug use. And in that moment, the person's health is more important than the act of the drug use in that moment. And so I like to think of the Overdose Prevention Center as the Good Samaritan law with just 4 walls around it. And so I think when we think about whether or not it's increasing crime in that sense, I don't think so. And so I think in that sense, we can also say that it does not increase crime. And so I would say definitely point to the community impacts. I think we could also look just right down the road at On Point, New York City. If we want to look just right at America, JAMA Open Network, November 2023, put a great pre-post study up, found no significant increases in recorded violent or property crimes, law enforcement arrest reports, criminal court summons, 311 calls, so nuisance calls, or 911 emergency calls in surrounding areas. And I think most of that has to do with the services provided at the places. So we're thinking about things like access to housing, access to care, access to mental health treatment, and those types of things, right? So folks are getting all those wraparound services, so decreasing crime.
Thank you so much. This is I've never had anybody explain the Good Samaritan way of explaining this. If a Good Samaritan is legal, but if you're organized Good Samaritan, it becomes illegal for some people. It's fascinating. Okay, so this is very helpful. Would you be able to attach these to your testimony, the different documents and things that that would help us out? Many of our calls, we read through all of these details, and it's rather than going to a website, might as well read their testimony and look at it. And when is your thesis due?
Yeah, a little bit.
Okay. Well, thank you. Good luck with that. It's Dr. Heimer is looking at it?
Yes. Yeah, Robert's
work.
my advisor. Yeah.
All right. Thank you so much.
Yeah, for sure.
Thank you for your
Thank you.
testimony. And with that, next person is Taylor Edelman.
Hello, can you hear me okay?
Very well. Thank you so
All
much
right.
for your patience.
Excellent. Yeah, thank you. So, dear members of the Public Health Committee, my name is Taylor Edelman. I live in Brookfield. I'm not only a lifelong Connecticut resident, I'm a father, I'm a husband, but I also work for one of the oldest harm reduction organizations in the country, the National Harm Reduction Coalition. I'm writing to you today to express my support for SB 1285. So in my professional role, my job is to train social service providers, really anybody that'll listen to me, about harm reduction and how they can be more effective in doing what they do. I wish I had time to do our whole Foundations of Harm Reduction training or one on stigma or one of the other ones, but obviously that's not the case. I think it's been well stated that in Connecticut, overdose deaths have steadily increased over the past several years, right? The numbers remained alarmingly high at over 1,000. So this clearly indicates that we're in dire need of different interventions, ones that have been proven successful for multiple decades. OPCs are not new. And as someone said here earlier, what we're doing is not working. And the answer is not going to be found in one intervention, but a combo of those interventions like syringe service programs, naloxone distribution, medications for opioid use disorder, and more. And one thing I want to point out too, because I think there's this misconception that people using these facilities are automatically being labeled as having a substance use disorder or having chaotic or problematic use. But what we know from Nora Volkow's work with NIDA is that only about 10% of people who use drugs actually go on to develop problematic or chaotic use, or what some people would call addiction, right? So there are also over 200 OPCs in about 14 countries at this point. 2 of them are located less than 70 miles from my doorstep in New York City. Obviously, we heard the one that opened in Rhode Island. Minnesota had passed legislation, Vermont as well. They're in the process of implementing their own. Dozens more operate just north of us in Canada. I think last time I checked, there are 39. And as we heard here today, OPCs do a lot more than provide safer injecting supplies. In fact, that's really a small part, I think, of what they do. And we know that research is showing us, even the CDC will tell you if you go on their website, one of the pages that's actually still up, that new users of syringe service programs are 5 times more likely to enter drug treatment and about 3 times as likely to stop using drugs than those who don't actually use the programs. And when we're looking at On Point, about 20% of participants were actually referred to services like housing, detox programs, treatment, and primary care, right? And when we look at Canada, we see a 30% increase in detox services within a year of opening Insight. 42% of people who weren't in treatment at baseline were enrolled into treatment within 2 years of utilizing one of the supervised injection sites, right? And I've had the opportunity to visit one, and I can share more on that, but I know I'm probably also at my time. So thank you.
Thank you so much. So you're in support, I guess.
I am in support, yes.
Just wanted to hear that again.
Yes, I know. I saw my little clock. I was telling myself, I'm like, I talk too much, but I'm happy to answer any questions. I have been to the ones in New York City because the program I run is out of New York City. So I'm happy to, talk about my experience being there, what that was like, since I know, people are interested in that.
Sure. Yeah, we have a question from Representative Kristen McCarthy.
Yes, of course.
Hi, thank you, Mr. Edelman. I appreciate your testimony today. And I think a big part of the conversation that we have about this is the difference between abstinence and harm reduction. If you were listening earlier.
Yeah.
My own little example of candy, but since you do training in literally 30 seconds, can you kind of sum up how you would best describe the difference between harm reduction and abstinence?
Of course. All right, 30 seconds. I can do it. So what I always tell is that abstinence is actually folded into harm reduction. So whenever I do trainings, there's like this division that like there's recovery and harm reduction. We're at odds. That's not the case. What we realize is that people can abstain from one drug, all the drugs, whatever drugs they're taking, but still practice harm reduction. So it's not like abstinence is outside of the purview of harm reduction. We are just pragmatists, honestly. So we know that people have always used drugs. They're currently using drugs. They will continue to use drugs. It's our job to keep people alive and well and with us and as healthy as possible, right? So that's my short, kind of a trick answer, right? But it's folded in.
You'd be really great on this side of the table too. That was very well done. Thank you.
Thank you.
Chair.
Perhaps in 30 seconds, if you can tell us the difference between the Canadian project and the one in New York.
Oh gosh. Well, so I haven't been to Canada. I wish. I hope one day. But what I will say about New York is that I think, again, there's this misconception. You walk in, boom, you're hit with like people injecting everywhere. It's not the case. You walk in, there's an intake desk. If you haven't been there before, they ask you what services you need. There's a drop-in center to the side, and all the way in the back are the drug consumption rooms, which also nobody's talked about this, but there's been a huge increase in people smoking their drugs. So there are specific rooms, well-ventilated spaces where participants are not allowed to use them for more than 15 minutes at a time to smoke meth, crack, fentanyl, whatever it is. And again, they're well ventilated. These areas are also very well lit. They're very sterile. They're like a medical facility. They have oxygen tanks on the wall because the bulk of the time they're actually reversing overdoses with oxygen instead of naloxone. They do use naloxone, but their first kind of response is using that oxygen because it's a little bit more humane and it doesn't force somebody into withdrawal. So there's also an acupuncture room, there's mental health services, there's referrals, you can get buprenorphine, so access to medications for opioid use disorder. You can do your laundry, shower. So it's really a holistic center. And such a small part of it, I think, is people actually consuming the substances.
Thank you so much. We appreciate your testimony. We're not seeing any more questions or comments. Thank you so much for joining us today.
Thank you.
And next person on our list is Monica Nugent. Ms. Nugent, welcome. Thank you for being here.
Good afternoon, Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Monica Nugent. I'm a Public Policy and Advocacy Associate at the Connecticut Nonprofit Alliance, or also known as the Alliance. The Alliance is the statewide association of community nonprofits. Community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year, and we improve the life of communities in the state. The Alliance urges you to support Senate Bill 1285, an act establishing an overdose prevention center pilot program. Connecticut continues to face an opioid epidemic. Piloting an overdose prevention center similar to those in other countries in our neighboring state of New York is a step forward in curbing fatal overdoses. As we have seen with the expanded use of naloxone, fatal overdoses can be stopped. However, with an increase in substances such as fentanyl and xylazine, fatal overdoses will continue and further steps are needed to stop the loss of life. We know that best practice in substance use disorder treatment is to meet patients where they are. There is no forcing someone into recovery, but offering options to contemplate recovery and having those services readily available for a patient to utilize. OPCs offer all of these services with the addition of having trained staff overseeing patients with substances in a safe and clean environment, but most importantly, preventing fatal overdoses with clinical supervision. There are 2 overdose prevention centers, as we've talked about today, in New York City. At these centers, over 1,700 overdoses were reversed, leading to no deaths. The centers have also saved the state of New York over $7 million in direct health care costs that result from injection-related illnesses and injuries. These centers have increased the access to social services and access to referrals for substance use treatment programs. As was just mentioned, we know that people use substances, will continue to use substances into the future, but if there's a way to make it safer, Connecticut should consider those options. The only way someone can find a road to recovery from substance use is that they're alive to get there. We know that OPCs are a proven public health intervention to prevent overdose deaths, and we urge this committee to support 1285. Thank you.
Thank you so much. Thank you for your testimony, and we appreciate you being here. Seeing no questions, we'll move to the next person on our list, which is Benjamin Grippo. Welcome. Thank you for your patience with us. Turn the mic on. Press the button, right? Perfect, yeah.
There we go. Check, check.
Hello, everyone. My name is Benjamin Grippo, and I am the Deputy Director of Operations for the Connecticut Harm Reduction Alliance. Even though I hold a highly visible position at the agency, 18 years ago, I was a participant. I was an intravenous heroin user from 1998 to 2005. In 2001, at the age of 21, I overdosed. Obviously, I did not die because I am sitting here before you today. I am one of the lucky ones. I cannot say that for the roughly 20 friends I've lost to the disease of addiction. I was in my bedroom at my parents' house. I injected and woke up 6 hours later with a pounding headache, nausea, and the syringe still in my arm. Imagine if I had died, what that would have done to my family. Imagine finding your child dead in his bedroom. They would have been affected for the rest of their lives, and I would not have the wonderful, supportive family I have today. Overdose prevention centers provide a safe space for people to use under the supervision of trained staff without fear of arrest. They provide access to sterile supplies and overdose reversal medication, as well as connections to critical health and social services. OPCs complement existing prevention, harm reduction, and treatment interventions. They are proven to save lives and improve health and safety. OPCs are a vital part of building a healthy approach to drugs that embraces the dignity and well-being of people who use drugs, families, and the community. At an overdose prevention site, you would be supplied with a sterilized syringe for every time you inject. In my time of use, I was not afforded this luxury. When I finally sought treatment at the Liberation House, my arms, hands, and feet were riddled with track marks. Sometimes I would go for a week using the same syringe. This practice ensures the betterment of the participant's health and reduces possibility of spreading diseases to other participants that share syringes. The United States is in the midst of an unprecedented overdose crisis. Drug overdose is the leading cause of accidental death. Over 1 million overdose deaths have occurred since the onset of the fentanyl epidemic. In 2021, there were over 107,000 deaths and nearly a 15% surge from the record numbers of 2020. The increased presence of fentanyl in our polluted drug supply is driving most of these preventable deaths. Now, with the presence of xylazine, nitazene, and other harmful additives, drug users are experiencing wounds that will not close, in some cases leading to sepsis and the amputation of limbs. Profound racial disparities mark this crisis. People of all races and ethnicities use drugs at a similar rate, yet Black and Native people experience the highest rate of overdose. Using drugs in a monitored, safe space can help prevent these overdose deaths and save lives.
Within 3 minutes and beautifully said. Thank you so much. We are so blessed that you're here. We are thankful that you're here.
Thank you.
And we're sorry about your friends.
I know you guys were talking about you like the data, and while I was sitting over there listening, I was jotting down a couple of things that I think you'd like to hear. I know that documentaries aren't the best source of data, but it is really good to watch one to get a grip on what's happening. Love in the Time of Fentanyl, Tuesday, and Injecting Hope are 3 great documentaries you can watch. If you're looking for really good raw data that's peer reviewed and just not Googleable, you can look in the National Library of Medicine and the National Institute of Health. Opioid abuse and misuse, as well as the risk for infection, disease, and overdose that comes with injecting drugs, have become a public health crisis costing the U.S. $78.5 billion annually, including healthcare cost, lost productivity, addiction treatment, and criminal justice involvement.
Thank you. My co-chair has a question.
Sure.
Thank you. I have to get the third one from Senator Anwar because we were all writing them down. Yes, we do appreciate data and we need it, but your story was impactful and thinking about you know, home in your own home in bed. And I think this is also the importance of sharing those human stories with one another. It's that sense, as Mr. Jenkins talks about, and I do all the time too, connection.
Yeah.
So that's what's so important. So thank you for spending time with us here today.
And going back to Mr. Jenkins, Dr. Jenkins, I think he was so passionate about what he said because, you know, even though he's 40, Black males between the ages of 40 and 55 are the people that are dying right now. If you look at any graph with ages and races, Black men between 40 and 55 are dying right now across the country, in Hartford, and other states.
Thank you. Can I ask you a question about, you guys are testing for xylazine too?
Yes, we do.
How good is the test qualitatively? There's mixed data that's out there.
The tests vary. The tester could give you some more information on that. I think she's coming up shortly, but it's new. You know, it's very new, and the data and the information is coming in slowly, but you know, there's a rise. And you know, when there's no more heroin, it turned to fentanyl. When there's no more fentanyl, it's going to turn to carfentanil, and the drug supply is going to be constantly polluted.
Yeah. Thank you so much for your testimony. We appreciate you being here.
Thank you.
Thank you. Next person on our list is Jennifer Hand. I don't see her there. And then next one is Livia Cox. Welcome.
Thank you, everyone. It's a privilege to be here. Co-chairs, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Livia Cox. I'm a resident of New Haven. I'm a graduate student at the Yale School of Public Health. I'm honored to be a policy fellow for Senator Anwar. And I'm an EMT and the co-director of the Middletown Harm Reduction Initiative, which I've led for the past 6 years. I'm testifying today in strong support of Senate Bill 1285 because more than 2,000 people in our state have died of preventable deaths due to overdose since the last time that we were standing in this room discussing the same overdose prevention bill under a different name and with some different components. So I'd like to invite you to picture this. You step into a building, the air is fresh and clean, and everything feels organized and calm. Around you, staff members, be they nurses, counselors, greet patients with a smile, they check them in, and they direct members to their first destination. For some, that's the consumption room, a space lined with sterile equipment, testing strips where trained medical professionals closely monitor participants with naloxone at the ready. For others, the first stop is a shower or the dining room for the first hot meal in a week. Others might go to an in-house clinic for hepatitis and HIV testing, or to the drop-in center for peer counseling, psychiatry, social services. There is a palpable sense of humanity in this place. And it is not a figment of my imagination. It's an amalgamation of real overdose prevention centers that I had the privilege of working at in northern Portugal. These are places where dignity is preserved, where medical professionals monitor people with compassion, and where lives are saved. The arguments against overdose prevention centers are often insincere and they are unkind. They echo the same harmful attitudes that fueled the war on drugs, despite decades of research and lived experience that tell us otherwise firmly. We've heard the claims that these centers increase crime, enable drug use, discourage treatment, and undermine the safety of our communities. But evidence from over 150 overdose prevention centers worldwide tells an entirely different story. And I've seen this crisis up close as an EMT in rural Connecticut, where I manage overdoses in settings where the nearest hospital is on average 30 minutes away. Oftentimes we get there and it's too late. Overdoses can escalate fast. I've watched for 6 years emergency rooms in Connecticut overflow, ambulances become overwhelmed with cases that should have been preventable, often at the expense of other urgent emergencies like strokes and heart attacks that also can't wait. When an overdose happens outside of a safe, supervised site, over 40% of those cases require ambulance transport and emergency department visits. Inside overdose prevention centers, that number drops to less than 1%. As AJ said, OPCs will help take off some of the load off of first responders, and I am one of those people. I've also seen as a recovery coach that relapse is just about a part of everyone's recovery. 70% of people who enter treatment will relapse, and I hope no one here today would say that those people don't deserve to live. Overdose prevention centers can make that possible. Half of those who use those centers enter treatment within 2 years. I've also seen the devastating human toll through my work in harm reduction, and yes, it is disproportionately and unfairly endured by people of color. Almost every Saturday for the past 6 years, I have heard the same news. Somebody's friend, someone's support person, someone's loved one is gone. And several times a year, I attend vigils for those who don't make it. I sit with communities that are hollowed by grief and by anger, and many of those people are folks that I've grown to know and love too. And I've also seen what happens when a country chooses compassion over punishment.
Excuse me, Ms. Cox, but you've reached your 3 minutes. Thank you.
Thank you. So we can continue to debate outdated fears, or we can choose to act on the overwhelming evidence before us. It is in your power to make such a difference. Thank you very much.
Thank you. Thank you so much. Livia, first, thank you for the work that you do. We can't thank you enough for your commitment and the hard work that you've done in the last many months that I've gotten to know you. In Portugal, how did the country and the community evolve to a collective action? Can you help me understand that? Because what can we learn from them?
Yeah, and I think the honest answer is that it was hard at first, as it might be in Connecticut too. Until we have these conversations, it's hard for us to understand where other people are standing. I think what was successful in Portugal is what I hope will be successful here and is proving to be successful elsewhere, which is as opponents start to see the numbers rolling in and the data and the ways that this is impacting not only their community, but their tax dollars, they change their minds. And there was a really wide group of people, largely in the Catholic community in northern Portugal, who were deeply distressed by this. And after spending time in these sites, many of them completely turned themselves around. In fact, one of them currently works at the site.
Do you think visiting some of the sites, obviously 2 years ago when we were working on a bill, I hadn't been to one. Actually, no, by the time I had already gone. Yeah, so before that. But it was more of an imagination. And then you walked us through that imagination, which is so true because that's real. I've been to these. Do you think there's an opportunity for more and more people to visit the sites, to see it and demystify what happens? Do you think that would be one way to try and help? Because nobody anywhere wants people hurt. Nobody likes to see our society being harmed. Nobody likes the enormous amount of dollars that are lost without getting the benefits. But there's this stigma that the individuals deal with, but a society deals with. And overcoming that stigma would require interaction or connection. Do you think that should be one of the policies that we say, you know what, people have to go visit or look at these sites? You know how people go visit healthcare facilities to understand things? Just thinking aloud, what do you think? Is that
Absolutely, absolutely. And AJ and Mark Jenkins are very friendly and willing and kind to open their doors for us to see how things operate. Everyone's welcome to come see how our distributions work as well. But I do think it is often in seeing how these environments are, seeing the humanity and the love that comes out of them. It's kind of hard to disagree once you've spent time in a place like this. I also think it's important from the educational perspective because it's quite common. I mean, unfortunately, the law that we're working with is the federal statute is called the Crack House statute, which is a very stigmatizing name that I myself take issue with. But the reason that I took the time to describe what these centers look like is because a lot of what our work is going to be doing, and Portugal didn't have to deal with this because they didn't have a law called the Crack House statute. In the United States, a lot of our role is dispelling that myth entirely, not only in what a crack house is or isn't and the problems with that word, but also in what these centers are and aren't and the way that they differ from that.
Do you want to reflect on the fact that overdose prevention, the OSAC, you don't have an OSAC over there, but they probably do. The opioid settlement fund is being used in Rhode Island, and then we are using state as well as city money in New York. But in Connecticut, we're not even passing a law yet.
Exactly, yeah.
So can you speak to that? How can we overcome some of these hurdles, even when this bill is not even asking for money?
Right. I mean, it's challenging, and this is the question I'm asking myself today. We've presented the fiscal data, we've presented the crime data, we've presented the data on treatment interventions, we've told the stories. I guess maybe my question is, what more is needed? The first thing that comes to mind is to do something about stigma, because with all of those things we've presented, I can't understand why else we haven't passed this yet.
Yes, I think that's the collective challenge we will have to overcome. And I I'm very hopeful that we will be able to. I'm very confident that my colleagues will listen to the testimonies like yours and others and listen to the stories, and they will humanize it as much as is necessary to be able to get to this point and address this.
Absolutely. And if I may say it, Senator Anwar, as well, this bill is written and designed in such a way that experts are the ones intervening and making a choice. With all due respect to legislators, it's not necessarily your role to decide whether something should or shouldn't be sanctioned the way that a medical society might be, qualified to do. In our bill, we have medical societies, law enforcement officers, people with lived experience, the AG's office, among many other people who will be contributing to the regulations. So this is not something has no walls and no safeguards to it. Municipalities and their collaboration will also be essential to this.
Thank you so much for your
Thank you very
testimony.
much.
Seeing no other questions or comments, we will move to the next person. Thank you. Next person is remotely Aisha Midya. Ms. Midya, you're on. Thank you.
Hi, so dear Senator Anwar, Representative McCarthy-Vahey, and other esteemed members of the Public Health Committee. My name is Aisha Midya, and I'm currently a graduate student at the Yale School of Public Health. So thank you for the opportunity to testify in support of Senate Bill 1285, an act of establishing overdose prevention centers. The life-saving measures outlined in the bill would protect many vulnerable people who struggle with addiction, and I see these measures as imperative to preventing further deaths. Today, through my testimony, I'd like to honor and commemorate my dear friend who I lost to an opioid overdose. Providing education and awareness about opioid antagonists, such as naloxone, is critical for people who are at high risk of overdose. Given how it can reverse the effects of an opioid within minutes, naloxone serves as a powerful tool if a person is unable to access further treatment. OPCs will also help connect people to further treatment services in addition to that. While Connecticut has made strides through distributing over 45,000 Narcan kits over the last 3 years, the lack of proper training of use and education can lead to this highly effective antagonist losing its life-saving potential. With the rise of synthetic drugs, Connecticut residents are losing their lives to opioid overdose at much higher rates. In 2014, fentanyl was involved in 75 overdose deaths in Connecticut. In 2023, fentanyl was present in over 1,100 deaths. Allowing people struggling with addiction to test their substances is the most critical harm reduction technique needed at this time, in my opinion. Such testing would be possible at these OPCs. Another concerning opioid overdose-related trend within Connecticut has been the rise of xylazine. Most commonly used as an animal tranquilizer, xylazine is a non-opioid sedative that is often mixed with fentanyl. What is most concerning, however, is that while opioid antagonists such as naloxone can reverse the effects of fentanyl, it will not reverse xylazine's impact given that it is non-opioid. This is of great concern given that Connecticut has been the state with the second highest rate of xylazine-related overdoses. From 2019 to 2022, the percentage of deaths involving xylazine jumped from 2.9 to 10.9%. Given the safe consumption measures outlined in the bill, people who have consumed xylazine will be able to be monitored for respiratory distress in a controlled environment. This will be done so under the guidance of a medical professional, which is crucial to ensure recovery for the person. The Overdose Prevention Center also has the potential to save Connecticut millions of dollars per year that would have been spent on treating non-fatal overdose. Based on other pilot programs enacted in various cities, the estimated cost offsets to healthcare systems range between around $832,000 to $2.95 million. These are the estimated savings after the implementation of one overdose prevention center. The stigma surrounding OUD is also an important aspect of the crisis to address. From what I have personally witnessed, drug addiction can often be a silent struggle. While the demand for treatment has skyrocketed over the years, there is a gap in corresponding increase in access to treatment. The Overdose Prevention Center bridges the gap between those seeking immediate care and those seeking services to help with long-term recovery, which in turn will save countless lives. Thank you for your time, and I'm happy to answer any of your questions.
Thank you so much for your testimony. Thank you. We appreciate you joining us, and I'm seeing no questions or comments. We'll move to the next person on the line. That is two individuals who'll come together, Campbell Mitchell and Arden Parrish. Do you want to grab one of the chairs and the two of you can sit together? Thank you so much.
Good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. My name is Campbell Mitchell, and for those of you who don't know me, I'm a graduate researcher in public health from Ridgefield. I serve with the Comptroller's Healthcare Cabinet, the Prescription Drug Task Force, and as policy lead for the Connecticut chapter of Insulin for All. It's in this last capacity that I'm submitting testimony in favor of SB 1324, an act authorizing emergency medical services to administer glucagon nasal powder. I'd also like to combine my time with our chapter lead, Arden Parrish, who will help narrate as we demonstrate how glucagon can save lives and the difference between injected glucagon, which is what our regulations are currently based on, and nasal glucagon, which is what this bill is addressing.
Hi, my name is Arden Parrish, and I live in New Haven. I'm a member of the Comptroller's Healthcare Cabinet and the Prescription Drug Task Force, and I'm the leader of the Connecticut Insulin for All chapter.
And for the benefit of anyone listening or reading the transcript, this is Rufus, a brown teddy bear, also from Ridgefield. He has type 1 diabetes, and he'll be assisting in our demonstration.
So Rufus, like most people with type 1 diabetes, was diagnosed in childhood and manages his diabetes with insulin as best he can. But being a busy bear, he occasionally makes a miscalculation, or his routine is disrupted, or he suffers some equipment failure. Consequently, for reasons unexpected and beyond his control, Rufus is experiencing severe hypoglycemia, or low blood sugar. Because the body needs sugar to stay alive, it's important that he gets treatment quickly. For decades, people with diabetes have relied on emergency glucagon, and it has historically looked like this. Anyone with a fear of needles might want to look away for this part. So you'll notice that the glucagon does not come pre-mixed because originally it was not shelf stable. Instead, Campbell has to mix it on the scene. Now, I want you to imagine this playing out with a parent or a teacher, the amount of stress that comes from trying to rescue a dying, unconscious child, or perhaps a coworker, or even a stranger if you're a good Samaritan trying to save a life. Imagine trying to balance following the directions, making sure the mixture is properly executed with the enormous time pressure. You can see it takes a while. Now, for decades, this was the best tool to save our lives. We have laws on the books in Connecticut that allow school nurses to dispense injectable glucagon, and for teachers or school staff who work with children who may need it to be trained in the same. But today, the technology is different. We no longer have to rely on a process that takes as long as this one and has as much room for user error. Instead of this chemistry experiment that you're witnessing, we can deliver a simple nose spray. If Rufus were a real child with type 1 diabetes, his blood sugar would be dangerously low the entire time that Campbell was mixing up that injection. Not ideal. Now, I want you to compare what you just saw to the option that is available to us today. Nasal glucagon is faster, easier, harder to mess up, has no scary needles, and can be administered as easily as Narcan. Like that. SB 1324 is a good step toward getting with the times, allowing emergency responders to take advantage of this life-saving technology. But we can and should go further. We should update the statutes authorizing school nurses and staff to allow nasal glucagon as well as injectable, including adopting the provisions that now exist in other states for undesignated glucagon. That is, for schools that hold glucagon that isn't prescribed to a specific student in case an unexpected emergency arises or a student who needs it can't get a second prescription for school. This is already the standard for epinephrine for anaphylaxis in Connecticut for schools, and we should apply the same here.
Given the ease of administration and the success we've heard about in saving lives with bystander intervention with naloxone, we should also consider applying the same standards for bystander training and dispensing for nasal glucagon. This would allow for safer and more accessible workplaces and communities for people like us, saving lives and preventing emergency admissions.
Excuse me, Mr. Mitchell, but you've reached your 3 minutes. Thank you.
All right, yeah.
Why don't you finish what you're saying, please? Yeah.
Yep. We urge the committee to pass SB 1324 with the strongest possible measures to take full advantage of this breakthrough technology. Thank you for your time.
Thank you so much. And thank you for both of you coming in, and thank you, Rufus, as well, for joining us. This demonstration was much needed, and this is very important. And I just have to acknowledge the Senate Minority Leader, Representative Senator Harding had put this bill about last year as well, and this year and the year prior, and we've not been able to get it passed because there's some hurdles in the process, and there are financial hurdles. We should be able to overcome those, and this should be much more easily accessible. In a moment, as I mentioned to you guys yesterday, I had to use glucagon a few times, and if it's life-saving, it just changes everything in the right setting, and we need to have it easily accessible. And not having it in the ambulances is very interesting. So we'll need to figure out the hurdles around that. So thank you for your testimony. This is very helpful, and your idea about the schools is very valuable as well, because children with diabetes are in schools as well, and hypoglycemia can happen anywhere, anytime. So this becomes very relevant as well. So I appreciate it. I see Representative Jenga would like to make a comment.
Thank you for your very articulate demonstration here. Do EMS personnel currently have this kind of training?
I believe they have training for the injectable glucagon. I think that's what our current regulations are written around. I also wanted to add, and particularly adding on to what Senator Anwar said, our school nurses and school teachers have training around injectable glucagon. This is good. We'd like to keep that on the books. The exact statutes are cited in my written testimony. But we think that they should also be allowed, at the very least, to use nasal glucagon.
Any idea what this training would cost? How intensive is it?
I don't have a figure offhand. I can't imagine, given the comparison you just seen, that it's any more than what we're already paying for injectable glucagon.
Okay, thank you.
Thank you. Representative Claritas Teacher.
Thank you, Mr. Chair. Thank you for your testimony today, and the visual was great to see it. And my other job, I'm an athletic trainer, so I work with athletes. And as you said, during the school day, the nursing staff is able to do the injectable, but after school, nurses are no longer there. So our first line of defense during a sporting event is myself as the athletic trainer. My only option now is to call 911. And this would be another option to safeguard our athletes and our student athletes. So I want to thank you boys for your doing. You do a great job. Thank you, Mr. Chair.
Thank you. I'll just add one of your comments that just use it like Narcan is very powerful as well. Like a few years ago, wouldn't have that example. So moving in the right direction as a state. Thank you so much for your testimony, and thank you for the work that you do. Thank you. All right, moving on to the next person. It's Diane Santos. Thank you, Diane, for being here with us, and thank you for your patience with us.
Co-chairs, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Diane Santos from Norwich, and I thank you for the opportunity to testify today on behalf of my late son in support of Senate Bill 1285, an act establishing an overdose prevention center pilot program. On December 30th, 2023, I lost my 26-year-old son, Mark Andrew Collins, to an acute fentanyl combined toxicity overdose. We had spent his final days trying to find recovery resources for his opioid addiction, even visiting our local emergency room. Despite Mark's admission of fentanyl use and our pleas for help, he received no treatment there. A recovery coach provided an access line number, then convinced us to leave the ER because, in his words, hospitals are not detox facilities. 36 hours later, I found my child cold and unresponsive on his bedroom floor. I had gone in to wake him so that we could recall every agency for a bed at detox. It was too late to save him. An overdose prevention center could have saved his life. Trained staff monitor consumption, intervene in the event of overdose, and offer a direct path to resources and substance use treatment for clients who are ready, as was the case with Mark. OPCs reduce the burden on emergency medical services, reduce infectious disease transmission, reduce public drug use and litter, improve community relations, and do not increase crime. Please understand that my support for this bill does not mean that I am advocating lawlessness. Thanks to the outstanding police work of the Norwich PD and the Connecticut State Police Violent Crimes Task Force, the woman who sold poison to my son was apprehended. Despite being told it was unlikely the state would prosecute, our family persisted, and on January 9th, 2025, she was charged in New London Superior Court with second-degree manslaughter and sale of narcotics for Mark's death. I firmly believe dealers must be held accountable. Having said that, we should avoid criminalizing those who, like my son, are self-medicating due to mental illness or become trapped in addiction through recreational use. Overdose prevention centers facilitate harm reduction by meeting people where they are without judgment. Stigma creates barricades where we need to build bridges, and our loved ones are dying. Passing SB 1285 is the right step forward in this race to save lives. Thank you, and I'm happy to answer any questions on my support of this bill.
Thank you so much for your testimony. And as you mentioned the date, around this time of the year, we were having conversation in 2023 about passing this bill.
Wow.
So I was just, it just struck me that if we had passed this bill,
That may have been an option, which I believe would have saved my
and I'm
son's life.
so sorry. And that's why when people say, why are you so passionate? I don't want to see you, your mother, more mothers, more fathers, more siblings
Yes.
come over here and talk about our collective responsibility. And so I'm so sorry. I'm so sorry.
Thank you, Senator.
Thank you.
Thank you. If I could just say as well, I know a few people mentioned xylazine. Our Connecticut Department of Public Health released reports about xylazine being on the rise, as well as designer benzodiazepines. My son did contain in his toxicology xylazine, as well as bromazolam, which is one of the designer benzodiazepines that are on the rise here in the state of Connecticut. So I just thought that was worth mentioning, being as it was brought up previously.
I just want to say thank you for your courage to be here and for sharing that beautiful picture of your son.
Thank you. That's my boy.
He's beautiful.
Thank you.
Next person on our list is Bright Johnson.
Good afternoon. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network and a resident of West Hartford. We are in strong support of HB 6974, an act concerning the use of funds in the Tobacco Settlement Fund, and have submitted written testimony which details the cost of tobacco use in Connecticut, the disappointing and uneven history of tobacco control funding over the decades, and indisputable evidence in support of the vital role tobacco control plays in helping people quit and preventing kids from ever starting. I'd like to use my time today to publicly thank the governor for including $12 million in funding for each year of the biennium in his budget proposal, which will provide continuity of tobacco control programs and services across the state. While the budget proposal is a strong place to start, we can't stop there. That is why we strongly support increasing tobacco control funding to $32 million annually as called for by the CDC, which HB 6974 would do. Increasing funding for statewide tobacco control programs that meet CDC best practices would better alleviate and reduce the tragic annual toll tobacco use costs Connecticut, both in lives lost and healthcare expenses. Unfortunately, after years of decline, we've seen increases in youth tobacco use nationwide in recent years, largely due to skyrocketing rates of e-cigarette use, as well as new, largely unregulated products that have come on market, such as nicotine pouches. At the same time, progress on previously declining youth use of other tobacco products, including cigarettes and cigars, has slowed. In 2022, the legislature supported the restoration of $12 million annually for tobacco control, the first new appropriation of funds for tobacco control in 7 years. Since then, the Tobacco and Health Trust Fund Board has been reestablished. The first 2 disbursements of $12 million have been approved and allocated following 5 CDC best practice components. They include state and community interventions, mass reach health communication, cessation innovations, surveillance and evaluation, and infrastructure administration and management. This funding includes, by the way, $2 million having already been awarded to the state quitline vendor, National Jewish Health, to maintain services for the next 4 years. ACS-CAN applauds these efforts because despite much progress, the current rate of tobacco use remains unacceptable, and more than 2/3 of people who currently smoke indicate that they would still like to quit. We are not asking for a new funding source or to create new bureaucracy, only to utilize a portion of that which comes to this state every year for this very purpose. We applaud this committee for making a strong public health statement that not only should funding that follows CDC best practices continue, but be increased to $32 million annually, the minimum level recommended by the CDC. Providing $32 million in annual continued long-term funding for proven and effective tobacco control programs aimed at educating parents and kids that reduce tobacco use is critical so that our children can grow up not as next generation addicted to tobacco, but as the first tobacco-free generation. Thank you for your time.
Right. Thank you so much for your testimony. My co-chair has a comment or question.
Thank you, Senator Anwar. Thank you, Bright. And I know you're shocked that I have a couple questions for you. I am so grateful for your work, and you talked about the nicotine pouches. I think everyone's the ZYN. What do you know of in terms of prevention efforts specific to those, or do you know of anything that's kind of been more specifically targeted at that use and that market, which I had someone here in this building say to me yesterday, if you walk around a college campus, you can see the little round tins in people's pockets all over the place.
Well, from our perspective, it's 2006 all over again. 2006 is when e-cigarettes were first introduced to this country, and they remained largely unregulated for about a decade. In fact, Connecticut didn't take its first serious steps to regulate e-cigarette products until 2015. And by then, there were already thousands of products on the market containing all sorts of ingredients, thousands of flavors, and they had been largely unregulated, which is exactly where we are with these right now. And the proponents of these products would love for them to remain unregulated so that they can take hold of customers. And so I'm hopeful that we do not fall under the same trap that we did with e-cigarettes and spend too much time doing nothing and letting this take root and becoming the next addiction.
Thanks for that. And the second question I have is, one of the things we've heard about the Tobacco and Health Trust Fund is it's getting back up and running, and it is going to take some time for the funds to be deployed. So if we did, by probably miracle, I would say, have the full amount that we're advocating for in this bill go forward, do you think that the Tobacco and Health Trust Fund is prepared to deploy those funds?
Well, first of all, if we had the full amount moving forward, I'd be high-fiving strangers because it would be a phenomenal, huge step in progress. I do believe that the expertise contained within the Tobacco and Health Trust Fund Board has the experience and the knowledge to be able to allocate these funds. It's simply a matter of, can DPH and the other agencies involved allocate these funds quickly? And does the legislature and the governor, frankly, have the patience to let it play itself out and reestablish, it takes a lot to get the machine rolling again. And don't forget that for over 7 years, we spent zero on tobacco control. And so to get that going again and to reestablish the continuity is going to take time. And I would urge patience, but at the same time, I think there should be expectations that now that the RFPs are being answered and that the vendors are being awarded, that we should start to see results. But having said that, the reality is that it's going to take a while before we actually see the data to show how successful those efforts are.
Thank you for that. We are here today talking about overdose prevention, and this is kind of the other end of the spectrum is the effort that we're trying to address with nicotine, another very addictive substance. So I thank you so much for you to be here and for all the work that you've done, and look forward to seeing you, and hopefully we can high five sometime in the future.
If I can just make one final statement, and that's just to remind folks that tobacco use is estimated to kill 4,900 people annually in the state, which amounts to about 13 people a day. Through the course of this hearing today, a couple of people, statistically speaking, have already died from tobacco use. It is still an enormous problem that costs the state over $2 billion annually in healthcare costs. And the really frustrating and sad thing is that's entirely preventable.
Amen. Thank you so much
Thank you.
for your testimony, and we'll continue our conversation. We'll move to the next person on our list, which is William Moffett. Welcome. Thank you for being here, and thank you for the work you do.
Good afternoon, going on evening to the remaining members of the Public Health Committee. My name is William Moffett. I work with the Connecticut Harm Reduction Alliance, and I am here strongly in support of Senate Bill 1285, an act establishing an overdose prevention center pilot program. I want to go back to the point my colleague Courtney Dollar made earlier at the beginning of this. How often in these conversations, similar to a lot of public policy, we get so caught up in the services that we forget about the people we're supposed to be serving. The voices of those in active use are constantly left out of these conversations. Maybe at some point today you had someone who spoke who was in active use, maybe not. People, as I've talked to them on the streets, are often afraid. They don't really have the time to come to a room like this to bare their souls. And to be honest, I understand. Imagine you going into a spot where your life is up for debate, where your existence, where the way you're treated is contingent on a certain amount of things. I'm not trying to blame anyone else, but I've heard a lot of things today that were just seeped in ignorance. I speak from my personal experience, and I'll tell you that everybody in the field, every advocate, everyone out there has some level of implicit bias, some level of ignorance that they bring. But ignorance does not need to be malicious for it to be destructive. The fact that we're still having these conversations is really disillusioning. When you first had this conversation a couple years ago, a few of our participants, I'd asked them, hey, would you use Safe Consumption Site Overdose Prevention Center? And so many said they would. One in particular who I want to give tribute to, I won't say his name right now, he said, yeah, of course I would use it. He was always so afraid of either if he got locked up or if he went into a detox program about overdosing and dying. This was a guy who would never go to a warming center. He would find any hole he could to use. Everywhere he went, he was judged, stigmatized. Every no public restroom sign you see is implicitly saying, you're not welcome here. And he said, yeah, I would use it. And I had a really dark thought when I had this conversation with him that he wouldn't be alive to see it. And he's not. And he's one of many. And I really, just because we've all been affected by this doesn't mean we understand the solutions that are there. And honestly, at this point, not to get too political, but based on where we are nationally, we need to, as a state, take reins of this. Stats don't matter unless we view people as human beings. The amount of treatment programs won't matter if we're turning people out and putting them back into society that hates them, that does not see them as a human being, that says your life does not matter unless you can do this. We do not care whether you live or die. And a lot of times we don't say this out loud, but this is what this conversation is saying. So really, we all need to act better and do better, because trust me, it is not going to get easier out there for our people. It is going to get harder. And these centers are therapeutic in and of themselves. To have a spot where someone can walk into and be accepted and loved, that in and of itself is transformative. And you can lay all the stats you want, but that doesn't change the fact that that thing says you were wanted here. We love you and we accept you no matter what.
Excuse me, Mr. Moffett, but you've reached your 3 minutes. Thank you.
Thank you so much. You amaze me every time I talk to you. I feel I get smarter. And I've told you many a times privately that I'm a fan of yours. I'll tell you publicly that I'm a fan of all the work that you do and the things that you say and your poetry and how you recite your poetry and the things that you write. It's like there are not a lot of people like you around here. And I feel blessed that I get to interact with you. And I'm so blessed that you're my friend. How do we overcome the stigma?
It's easier said than done. As you know, last time I spoke to the struggles I had with my own parents, with my father especially. It took me going through hell and back for me to really fully be able to humanize them. And I don't want people to have to go through that kind of trauma. So I don't know. If we haven't really gotten to it now collectively, I fear as a society we're constantly falling into creating a scapegoat, and I get it. Someone in the midst of a substance use disorder, they kind of, when we see them, I think we see what we could be. Anyone out there doing outreach, it's not about sympathy, it's about raw empathy, realizing we're one step away, that we're all part of this collective body. It will take a kind of, not just a policy reawakening, but a broader spiritual reawakening that I fear we might not get to, but that means the work needs to be done. I don't really have a faith necessarily that will change the policies overnight, but we need people out there willing to speak the truth, willing to do the work, to meet people where they are. And I'll be honest with you, if going into the future, if the policies and laws aren't set in place, the people doing the work will find a way to do the work regardless, as they have in the beginning. But it's best for this stuff to be brought to light. Even by having these conversations, you show people there's nothing to be afraid of. But I understand it's hard. It's easier said than done. It takes collective conversations, and it just takes talking to someone in active use and listening to them, really listening to them.
Very powerful testimony, as always.
Thank you.
Thank you so much. My co-chair has a question.
Thank you. And you are a poet. And I wrote down what you said, that ignorance does not need to be malicious to be destructive is an extremely powerful statement. So I sometimes talk to my children about intent versus impact, which is, I think, a different way of saying similar. But what I want to say to you is, I'm sorry for the ignorance that has occurred, but I also know that there is a commitment here to learn and to grow and to understand. I also want to say we very much, I will use I statements, I very much care about whether or not people are able to live. And I want to affirm what you're saying about making that human connection. We will continue to need and use data. Certainly, you heard the tobacco conversation, for example. All those things are important, but ultimately, what it comes down to is that human connection. And we've seen here in this committee the impact of that. So I want to thank you and encourage you. And while some things may be disheartening, I hope you will stick with us and don't give up on us. We're not giving up on you.
Thank you.
Can I get you on the record about lunch? That you're supposed, you promised us we'll have.
Yeah, see you at lunch.
Okay, thank you. Next is Laurie McDougall. Is Laurie here? Going once. Well, we'll move on to Ann Fitzgerald. And we'll move on to Stephen Mills. And we will move on to Kim Adamski.
Just a second.
Welcome, you're on.
Hi, not sure why you all can't see me, but can you hear me?
We can hear you. Thank you.
Okay, well, that's good enough then, I guess. Hi, I'm Kim Adamski. I am here to testify in favor of SB 1285. I'm a Connecticut native and career health educator. I've worked with people who use drugs in varying capacities. I taught HIV prevention in state prisons. I worked on a Hartford syringe exchange van, and I provided HIV testing at a Hartford STI clinic. Each of these jobs involved regular contact with folks who use drugs. I can tell you confidently that each of them was a normal person, like the rest of us, whose circumstances led them to drug use for varying reasons. I can't tell you how many cases I've encountered where a person became addicted to opiates after being prescribed them for a surgery. Another common scenario is when an impressionable young person is pressured by a much older person they're dating. People who aren't able to access further education or gainful employment for whatever reason also may turn to drug use to temporarily alleviate the despair they feel in their situation. What I'm saying is there's a lot of reasons people use drugs. And here's the thing. Some people are going to do drugs. Probably many of the people in this room have used drugs. In fact, I know because some of them said as much. Some may have used them in a way that harmed their health or well-being. Drugs can be extremely dangerous, but we can do things to reduce those risks. For example, syringe exchanges available in cities across Connecticut reduce HIV and hepatitis C transmission among people who inject drugs. Similarly, overdose prevention facilities have been proven to reduce the physical harm experienced by people who use drugs, like overdose and HIV infection. People who use overdose prevention facilities receive educational information and access to resources if they so choose, like drug treatment. Sites like these in New York and Rhode Island have saved taxpayers millions in healthcare and emergency spending, reduced public drug use and improper needle disposal, and increased access to life-saving medical services. In my opinion, though, the most important thing is that they save lives. Studies of existing sites show huge decreases in overdose deaths in the areas that the facilities serve, while causing no increase in crime or drug use in those areas. Of course, the ideal is to get people to a place where they don't need to use drugs. But in the meantime, until and if they are ready to take those steps, we need to give them the resources to be as safe as possible. A person who dies of a drug overdose will never have the opportunity to reduce or stop using drugs. They'll never have the opportunity to address issues that led to problem drug use. Even if you believe that drug addiction is always the result of poor choices, does a person deserve to die because they made what you think are bad choices? No, they deserve for their community to help them survive and hopefully eventually thrive. I urge you to support SB 1285. People who use drugs deserve to live, just like the rest of us. There's no reason to make drug use any more dangerous than it already is. The evidence shows that overdose prevention facilities work to improve public health and safety. Thank you so much, and I'm happy to answer any questions.
Kim, thank you so much for your testimony today. Seeing and hearing no questions or comments, we'll move on to Ryan Schufel. Forgive me if I mispronounce your name. Ryan, are you here with us? No? Okay. Gerald Tracy. Mr. Tracy, welcome.
Is that the one I push?
You're good. That's the one. You
I
already.
push. Thank you for having me here. And I met the co-chairs 2 days before Christmas, and you were kind enough to talk to me about blood clots. And that's what I'd like to talk about today. And that turns into 568. My name is Jerry Tracy, and I'm part of a Connecticut family with a tragic history of blood clot disorders, AKA VTEs. This story starts out grim, but it's now filled with hope and inspiration. Let's begin with the hardest part. 5 of my blood relatives have had serious VTEs over 3 generations. We lost my father at age 54. We lost my brother at age 55. My nephew, most recently at age 36. My niece and I are both blood clot survivors and are stable. The causes of our family's blood clot problems are clearly genetic, but the risk factors were unknown up until about a year ago. Following my nephew's memorial service in 2021, frankly, I had to do something. I had to do something. So I began searching for experts to find the causes of our blood clot problems and learn how to prevent further harm. And here's where the story gets much more positive, because I have run into some great people in this journey, if you will. The first one is Dr. Alfred Lee, the chief of hematology at Yale Smilow, well-respected leader in the field. Dr. Lee tested me using state-of-the-art genetic sequencing, and I won't pretend to know what exactly means. It's called WES. That much I know. And then he tested all of my blood relatives, because the testing revealed that my family carries a rare mutation in the gene that stops clotting. These findings have improved our family healthcare members affected with the gene. Yale's now researching for potential large implications. So that's genetic research that's very exciting. But that research is not going to turn into effective treatment for our family, for anybody, for a year. Pick a number, 10, 20. So we had to do something to immediately improve our VTE health. We then connected with the National Blood Clot Alliance, which is just a tremendous organization full of people facing their own challenges with blood clot disorders and are transforming their suffering into practical and powerful actions. We have written testimony that the NBHA CAA President Leslie Lake did. It's great. I'd encourage to look at it. So I became an advocate. But here's the last piece here, which is, I think, really interesting. I came upon or found an important new Florida law. And the law is called the Emily Adkins Prevention Act. This act was named after Emily Adkins, a college student who unexpectedly died of pulmonary embolism at age 22. Her mother was a former state legislator who channeled her shock and disbelief into a new law to establish a work group to create a plan to improve VTE.
25. Excuse me, Mr. Tracy, but you've reached your 3 minutes. Thank you.
Too bad. Can I
Why don't
just
you
do
finish your thought? Yeah,
a
please.
minute or two? I apologize, because this is the important part. That work group that they created, which is basically exactly what we're proposing here in Connecticut. We're proposing that Connecticut do the Connecticut version of the Emily Adkins Act, put a work group together, task force, whatever you want to call it, do a comprehensive study of what's going on in our state with this particular issue. And here's the punchline: develop recommendations to do something. And there is so much room for improvement and so much that can be done in terms of education, treatment, prevention, and research. I've had positive meetings last fall with key state legislators and health agencies, Senator Christine Cohen and Representative Moreira, Senator Gordon, who I don't think is here today, And most recently, Representative Keat have been great in co-sponsoring this. It's, we believe that the straightforward, bipartisan, no direct cost legislation will establish a strong foundation in our state to reduce blood clot morbidity and mortality and reduce the suffering of many
Thank you.
BPE-afflicted families.
Thank you so much, Mr.
Thank you.
Tracy, for your testimony. You have a written testimony as well.
What's that?
Do you have a written testimony too?
I still can't hear you, Doctor.
Did you submit a written testimony?
Oh, yeah, we submit,
Yeah.
a lot is the
Yes.
answer.
Okay. So we will follow up as well as after this public
Right.
hearing. Thank you.
Welcome. Any other questions?
We're good. Thank you so much. Thank you for your patience with us. Thank you. We'll go back to Ann Fitzgerald. You're on, Ann.
Thank you. Good afternoon, Co-Chair Senator Anwar and Representative McCarthy Vahey and distinguished members of the Public Health Committee. My name is Ann Fitzgerald, and I thank you for the opportunity to testify today in support of Senate Bill 1285, an act establishing an overdose prevention center pilot program in Connecticut. I am a resident of North Canaan, a daughter of the town of Salisbury, a soon-to-be MSW graduate of the UConn School of Social Work, a certified nurse's aide, and an intern with McCall Behavioral Health in Torrington. I work with McCall's CLEAR team, otherwise known as Community and Law Enforcement for Addiction Recovery, one of 2 regional pilot programs in the state. While drug use is common across various demographics, I have spent most of my time doing community outreach and harm reduction activities in places like the Torrington Soup Kitchen, Co-Park, and the Torrington Plaza, in the company of some of Connecticut's most vulnerable citizens, many of whom are unhoused. It was indeed an eye-opener for me when I accepted back my first batch of dirty needles and dispensed out clean ones, or when I handed out my first few smoking kits, fentanyl test strips, and injection drug use kits. While doing this work, my team, which includes a whole network of other outreach workers from various agencies, stays abreast of new overdoses, responding to perceived trends in real time. I have become extremely passionate about the value and the validity of harm reduction, and I truly believe that it is the right thing to do. During my studies at UConn, in Professor Richard Fisher's class entitled Emerging Issues in Mental Health and Substance Use, I learned about some of the facets of the science of addiction. For those who progress from recreational use to full-blown chaotic use, significant changes have taken place in the brain. After my own 24-year-old son, Sipo, died by suicide in 2019, I grew to understand that his brain had been hijacked by an insidious mental illness. While I think it is so important to treat individuals who choose to use drugs with dignity and respect and to support them as authors of their own lives, I also believe that addiction, like mental illness and indeed suicide, is not a choice. There are things I know now that I wish I had known when my son was still alive. I have had to forgive myself for this and to accept that I did everything I could to love and support him with the knowledge I had at the time. This said, I believe it is another matter when one has knowledge that will help save lives and fails to act. Over the course of my son's life, I encountered hurdle after hurdle in trying to get him good care, affordable care, and continuing care. I have come to appreciate that public health integrated care models that meet people where they are, both individually and geographically, hold the most promise for the future. Our government is uniquely positioned to demonstrate leadership and foresight and to take a critical step in saving lives. Thank you for the opportunity to speak.
Thank you so much for your powerful testimony. Thank you for your work, and I'm so sorry for your loss.
Thank you very much. I appreciate it.
Seeing no question or comments, we'll move to the next person on our list, which is Dylan Balter. Welcome.
Dear Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Dylan Balter, and I thank you for the opportunity to testify today in strong support of Senate Bill 1285. I am a resident of New Haven and a medical student at the Yale School of Medicine. For the past 4 years, I've conducted addiction research focused on improving outcomes for individuals with opioid use disorder. I've also had the privilege of visiting 4 overdose prevention centers, 2 in Canada and 2 in New York, where I have observed the life-saving capacity of these facilities. I speak to you today as a medical student engaged in addiction research, as an aspiring addiction medicine physician, and as someone who has personally experienced the loss of a friend to an opioid overdose. Connecticut faces an alarming opioid crisis that requires a proven public health intervention. Overdose prevention centers provide exactly that. While relatively new to the US, overdose prevention centers have existed globally for over 30 years with more than 150 sites across 16 countries. As we've heard today, research shows that OPCs reduce overdose deaths, lower hospitalization and emergency department visits, and improve engagement in addiction treatment. They also reduce public drug use with no increase in neighborhood crime, and they are cost-effective. These sites consistently and unequivocally save lives. In 2020, I visited Insight, Canada's first legal OPC in Vancouver, as well as The Works, Toronto's first OPC. Both facilities resembled medical clinics, reaffirming that addiction is a disease requiring medical intervention. The centers consisted of a check-in area, a consumption room, and a post-consumption room. The consumption room was staffed by trained professionals equipped with oxygen and naloxone, ready to immediately intervene in the event of an overdose. The space provided sterile needles, tourniquets, drug testing strips, gloves. Insight also featured a wound care room as well as HIV and hepatitis C counseling. In the post-consumption room, people connected with friends, listened to music, and also accessed additional services such as affordable housing and addiction treatment referrals. In 2022, I visited both of New York's OPCs. The sense of compassion and humanity at these sites was palpable. Beyond saving lives, these centers offered showers, laundry services, meditation spaces, gardening programs, mental health care, and case management. Since opening, New York's OPCs have served over 5,800 individuals, have had over 170,000 visits, and intervened in 1,696 overdoses. Over 75% of participants have accessed additional harm reduction, social, or medical services. A recent study found that opening 4 OPCs in New York City could save up to 130 lives and $7 million in healthcare costs annually. The evidence is clear. OPCs save lives, reduce harm, and strengthen communities. It is a moral and public health imperative to act, and I strongly urge you to support Senate Bill 1285. Thank you.
Thank you, Dylan. Within 3 minutes, just like exactly the second. I love it, and very powerful message with data, information, and perspective. When you went there to New York, the On Point, what were your first few thoughts when what you had imagined and what you saw?
Yeah, so I think I went after a few years after I'd already visited the sites in Canada. So I had a pretty good understanding of kind of the setup and the additional ancillary resources provided. But I think especially in New York City, it felt like a cornerstone of community. You went in and you immediately felt warmth. People greeted you. Everyone wanted to talk to you. You heard about people gardening, people making honey, people just kind of really like finding social support in the community, in addition to obviously having an evidence-based life-saving intervention. One thing that really struck me was they wanted to open a barbershop, employ people who use drugs, train them to, be barbers, cut hair, and then also have that as a service so that people could get their hair cut in the center as well. So I think it's just a really humane, life-saving, and evidence-based intervention.
It was fascinating to see that there's a daycare right across from it as well, which one would have never expected, but it's a vibrant daycare.
Yes.
And
yes.
then you see this, and then how would you differentiate New York from Canada?
I think that they were all similar. I think Canada felt kind of more like there was an initial waiting room, consumption room, and post-consumption room. New York had the same setup. Plus, I think I learned just more there about all of the ancillary services in terms of social services, referrals, case management, and kind of got to see a lot of additional rooms in the New York sites, kind of just further underscoring that you are providing a life-saving intervention. You are also providing, access to treatment when the person wants to engage in treatment. You're also providing social services, access to housing, all of which can also prevent overdose deaths in the future.
Thank you so much for your testimony. Seeing no other questions or comments, we'll
Thank you.
move to the- Thank you. Next person on our list is Isabel Fiorine. Isabel, welcome.
Good evening, and thank you for the opportunity to speak in favor of Senate Bill 1285. My name is Isabel Farine, and I am the Vice President and co-founder of For Cameron, Inc., a New Haven-based nonprofit organization dedicated to raising awareness about the dangers of fentanyl and fake pills. Our mission is to provide education, resources, and support to individuals and families impacted by the opioid crisis, with a focus on saving lives and reducing stigma. I testified in favor of a similar bill 2 years ago, and I'm here again because we are still losing too many lives that should still be here. And until we start implementing real solutions, I will continue to come back because this crisis is not just going to go away. This bill isn't about enabling drug use. It's about keeping people alive. People are going to use drugs no matter how much we try to ignore or shame that. That's just the reality. And if we know that to be true, we have a choice. We can A, let people continue to die alone, or we can B, offer them a safe place, one where someone is there, ready to step in if something goes wrong. Overdose prevention centers don't encourage drug use. What they do is prevent overdoses. They stop people from dying in public restrooms, on sidewalks, in parks, or alone in their bedrooms where no one will find them in time. They provide dignity, support, and for so many, a path toward recovery when they are ready. I know firsthand what it's like to lose someone to this crisis. My brother Cameron died 7 years ago this March from a fentanyl poisoning. I was the one who found him curled up on his bedroom floor. And in that moment, everything changed. My world went silent. Every single day since then, I've carried the weight of that loss and the very traumatic image of seeing my brother's lifeless body on his bedroom floor, a place he felt was the safest option to use because other options weren't available. I think about all the birthdays he'll never get to see, the milestones he'll never achieve, the moments that should have been his. I'm left to wonder, what if? That pain doesn't fade. It sharpens with time, a reminder of how quickly everything can be taken away. We can't keep turning our backs on solutions that save lives just because of stigma or internal biases. That kind of thinking isolates people. It pushes them into darkness where they feel they don't matter. And that thinking leads to more families left broken and more futures stolen before their time. And here's what I need you all to understand. This can happen to anyone. My brother wasn't just a statistic or a lost cause. He was a person. He was my brother. And the people you're making decisions about today, they're not just numbers. These are real people, human beings with stories, families, dreams. They deserve compassion, not judgment. We don't shame people for calling an Uber after drinking. We encourage it because we know it saves lives. OPCs do the same thing. They give people a fighting chance. They make sure people survive long enough to get the help that they need. They offer people time to choose recovery, time to heal, time to live. We have to stop treating drug use as a moral failure or something that's dirty. It's not. It's a public health crisis. And if we truly care about saving lives here in Connecticut, we need to meet people where they are, not with judgment, not with punishment, but with compassion, dignity, and real solutions. This bill is one of them. Please, I implore you to support this bill. Please choose to save lives. Every moment we wait, more people die, and we're losing them because we refuse to act. So I ask you guys, how many more lives will we lose before you all decide enough is enough? Thank you.
Thank you so much, Isabel. Thank you for your testimony, and thank you for the work you do at For Cameron. I think 2 years ago when you first spoke about this Uber example, I was just like fascinated, and I said, why did others think of this? And it makes it so simple to understand that you're just trying to create a safety for everyone and yourself. And some OPCs are like an Uber that you're getting for that situation. So thank you for that important example. You've been, both you and your mom have been doing some amazing work to try and raise awareness across the state. Have you seen the things change in the state? Are you seeing a pattern where there's more understanding of what is the right thing to do going forward?
Thank you for that question. I think as a whole, from when my brother first passed away in 2018 to now, there is a noticeable difference in that the topic is being talked about. When my brother Cameron first died, it was a lot of misunderstanding, and the stigma was very much so thriving. And while I don't think we're in a place where the stigma is the best, I think it's gotten better. And something that I often like to use as an analogy is alcoholism and substance use disorder go hand in hand. So what is the difference between something like an OPC versus your local bar? It's just the way that we view drug use. A lot of people are focused on wanting individuals to just stop using drugs, or how can we get them to stop? So I ask those same people, what is the difference with alcoholism? How do we get people to just stop? We're not going to close every bar. We're not going to close every liquor store. There's ways to reword the things that we're saying. And I know that harmful language has been touched on a lot today, which I'm really appreciative of that. And that right there reduces the stigma in such a public and huge way. So while I don't think we are where we should be, I hope that my words and everyone else's words really stick with some of the people here that are deciding, and we show that Connecticut can do the right thing, and we show that we are not lost and we're not stuck on this stigmatizing view of drug use.
Thank you. Another analogy. I tell you, every time I talk to you, there's a new analogy. I have to write these down, and I'll probably call you for getting analogies on other topics. So I appreciate your testimony. Seeing no other questions or comments, thank you, Isabel, for your testimony. It gets more and more powerful, and I know one of these days we will just meet as we volunteer for good work, not in these capacities. Thank you.
Thank you.
Next person is Elizabeth Nemirovsky. Welcome. I hope I pronounced your name accurately. Almost there. Welcome.
Thank you. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Elizabeth Zanamorowski. I thank you for the opportunity to testify today in support of Raised Bill 1285, an act establishing an overdose prevention center pilot program. I speak to you today as a nurse practitioner at the Syringe Services Program in New Haven. I also direct our FTIR drug checking program there, and more importantly, a member of the New Haven community. My views and opinions are strictly my own. I don't represent Yale University. When I was drafting this testimony, I realized much of what I had originally written was focused on suffering that overdose has caused my patients and our community. And yes, we have a problem. Rising overdose rates have been paralleled by an increasingly unpredictable drug supply. In 2021, overdoses in Connecticut involved fentanyl, xylazine, and over 30 other substances. Without overdose prevention centers, OPCs, many individuals will continue to use volatile drugs in equally volatile environments. Data from our program alone show that 40% of the time our participants were injecting in public spaces, so the street, a car, parks, public bathrooms. More than 1/3 have reported a non-fatal overdose in the past 6 months, and 2/3 have witnessed a peer overdose. We need change, and so perhaps a reframing is in order, a shift towards a vision of positivity. In OPCs, we have the makings of an evidence-based solution. Overdose prevention centers ensure that people have another day to talk about possibilities, to encourage and to engage with the hopes that we can shepherd folks to their vision of success, be it remission, abstinence, or decreased use. If you were to ask me what the most valuable service that our office provides, I would tell you without hesitation, it's not nursing, it's a slice of humanity. If you sit down with any of my participants and offer them a chocolate milk, which is a fan favorite, you would start to gather beautiful pieces of the person that they are, underneath layers of hard living, substance use, and daily survival. They would tell you their favorite joke, share their dreams for the future, and perhaps say, "Hey sister, you are the only one I have at this moment. Thank you for being a part of my life." Overdose prevention centers do more than provide a safe space for drug use.
They foster community, dignity, trust, and hope for the future. OPCs serve as spaces where people who use drugs are treated holistically as individuals, not as problems to be solved. They provide connections to care, offer a physical and emotional space where people feel seen, heard, and valued. And we know that this sense of belonging is essential to recovery. When individuals feel supported rather than criminalized, they are more likely to engage with healthcare services and take steps towards stability and change.
Excuse me, Elizabeth, but you've reached your 3 minutes. Thank you.
Final thought. Simply put,
Yes.
people cannot heal if they are excluded from the very communities that should be supporting them. Thank you for your consideration.
Thank you so much. It's very powerful. Can you repeat what you just said again? This is too powerful to just hear one time.
Yeah, people cannot heal if they are excluded from the very communities that should support them.
Wow. I should write this down. This is very powerful because I think end of the day, it's about acceptance, love, unconditional acceptance, and that's more therapeutic. And everything else is there's so many layers to this. It's fascinating. Your testimony is very powerful, and the work that you do is very powerful. Thank you so much. Seeing no comments or questions, we'll move to the next person. Thank you.
Thank you.
Neha Shanavas. Neha, are you here? No. Okay. Rachel Voigt. Welcome. Thank you for your patience and thank you for being with us all day.
Thank you. It's Rachel Vote, like in an election.
Vote is right.
Good afternoon or good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. I thank you for the opportunity to provide testimony in full support of Senate Bill 1285, an act establishing an overdose prevention center pilot program. I am humbled at the ability to stand beside respected and experienced individuals in the Connecticut harm reduction community who share support in this vital, life-saving proposal. It is important to me to give voice to the family, friends, clients, coworkers, and loved ones who we have all lost unnecessarily due to the stigma of substance use and the inability to consume drugs in a supervised and medically staffed environment. My name is Rachel Mary Vote. I'm a certified alcohol and drug counselor by the DPH with Liberation Programs, where I provide substance use and mental health group and individual counseling to people in the greater Bridgeport area. I have worked in the field of mental health and addiction in Bridgeport for over 8 years. Currently, I'm finishing my graduate studies at the University of Bridgeport, a mere 2 months away from graduation. I'm going to be earning my degree in clinical mental health counseling. Most importantly, I am a single mother to a 13-year-old daughter who unfortunately lost her father to an unintentional overdose in June of 2022. My own father, at just 56 years old, also lost his life in this same tragic manner in 2011. Then, in December of 2012, my childhood best friend, Kat McCormick, returned to use after several months of sobriety, which resulted in the loss of not only her life, but the life of her 13-month-old son, Caleb, whom she was holding at the time of her OD. All of these deaths were senseless and preventable. As a person with lived experience as an intravenous drugs user, I am reminded every day how incredibly lucky that I am to be a survivor. I say luck because that's what it is. People who use drugs tempt fate every time they use, not because they have a death wish or don't care, but because they're forced to use in places like bus station bathrooms, McDonald's parking lots, behind dumpsters, and other hidden, often unsanitary places. Our clients in Bridgeport and drug users throughout Connecticut have become so accustomed to this, as I was, it sickens me. Regardless of struggles a person faces, our Constitution requires us to promote the general welfare and secure the blessings of liberty to all citizens of our great nation. As we move forward through these next 4 years, what impact do we want to have as one of the wealthiest states in the U.S.? That's the question I ask. OPCs have been established in multiple countries and in several states, and the numbers speak for themselves. No lives have been lost to preventable overdose at any of these centers. Each life saved provides an opportunity for the person using substances to receive connection, care, empathy, and if they are ready, vital treatment. The availability of supplies that users may access to use their drugs safely is critical in reducing the number of communicable diseases such as hepatitis C and HIV/AIDS. ER visits are minimized because drug users have a place that they may be taught how to inject their drugs without causing acute or permanent damage to their extremities or other body parts.
Excuse me, Ms. White, but you've reached your 3 minutes. Thank you.
Okay, to summarize, OPCs will save millions of taxpayer dollars, and I am deeply affected by every fatal overdose in our state. I appreciate your time.
Thank you so much for your testimony. I'm so sorry for your losses. It's can't even say anything. It's so much that you've endured. Thank you. Thank you for sharing your testimony and your pain with us.
Thank you for your time.
Seeing no questions or comments, we'll move to the next person. Thank you. And sorry for mispronouncing your name. I'll remember November. Vote. Next person is Greg Allard. Okay, so we'll move to the next person, Rel Vanderhout. And you can correct me if I do not pronounce it right. Oh, I did. All right. One to go. Welcome.
Thank you, and thank you, honorable members of the Public Health Committee. I'm Ralph Vandenhout. I'm a current graduate student at the Yale School of Public Health, and I'm a former addiction researcher at the Yale School of Medicine. I'm here today in support of Senate Bill 1285. Today, I'd like to share the story of Samantha. I met her in the fall of 2018 at Emory University, where we instantly became best friends. Following graduation, amid the tumult of 2020, we moved to Connecticut to begin the next chapter of our lives. We lived together, but I worked long hours at Yale New Haven Hospital, and she worked from home. Isolated and unable to receive the appropriate care, she turned to substance use. And I will never know exactly what happened or why, but one day I came home to her on our couch, dead from fentanyl poisoning. She died alone. An overdose prevention center would have surrounded her with resources to at least be safe or reach out for help. Sam was a radiant and brilliant woman. She graduated with honors from Emory. She baked like no one else could, and she carried herself with a kindness that's rare. So I urge you today to support people like her, the people who just need a little help to regain control. Thank you.
I'm so sorry.
Thank you.
We have next person. I'm sorry. Adam K. Cameron Breen. Sorry? Oh, sorry. River Rose. Oh. Sorry, River.
Thank you for the opportunities to speak today. I sit before you as a mom, a daughter, partner, friend, master's in public health school student for Johns Hopkins, and a drug checker for Connecticut Harm Reduction Alliance. In these many roles, I have seen the negative impact that stigma towards drug use has had on my loved ones and people I've met through my work. The isolation that people experience because of the judgment and shame is heartbreaking to witness. Feeling less than human because people treated you as flawed. Feeling like you have no social support to turn to. This lack of social support and sense of community is what kills people most. Yes, the illicit drug supply is dangerously unstable, leading to overdose and poisoning deaths. Believe me, I know. But as a state, we need to lean into our compassion and love, even when it scares us, even when we think we know what's best for someone. Overdose prevention centers provide a centralized place to offer the social support, compassion, connection, and care that people who use drugs deserve so that they can improve their well-being and quality of life over time. As you've heard and read in previous testimonies, OPCs have been scientifically proven to have positive impacts in the communities that they serve. They're more than just a place to use drugs, they save lives where someone might otherwise be using alone, exponentially increasing their risk for overdose death. My family has buried enough loved ones to this crisis. Many of us are in chronic states of grief because we have built lasting connections with the communities that we work with, only to have these wonderful souls die, a preventable death. No one deserves to die. Please do the morally right thing and pass Senate Bill 1285 so that we can further prevent the painful grief so many of us experience and start focusing on healing our communities so everyone can thrive. Thank you.
Thank you so much, River, for your testimony. Can I ask you a couple of questions?
Sure.
You're the one who's like testing the drugs.
Mm-hmm.
And how do you tabulate the data, and how are you communicating with the DPH or other agencies to be better prepared for what's out in the streets?
So I have a really close relationship with those that work at DPH and the epidemiologists and things like that. But I actually work with Liz really closely and Cameron. We have like our own little collaborative space where we send out any of our tests that we do through email and through social media so that people can actually see what's in the drugs that are being tested. But I also have like an Excel database where I hold all of the substances that I've tested. And then from there, I can say, hey, these are the trends that we're seeing over time. Like recently, a lot of the drugs that I've been testing have had benzodiazepines in them. And not just any drugs, there are fentanyl samples specifically are the ones that we've been seeing that in. And you can see the various changes over time and how unstable our drug supply is. So they're not, when they're going and saying, I'm going to go get a bag of heroin, it might not be heroin, it might be all cut, or it might be something that's like carfentanil and cut, things like that. And we have been seeing things that, we may not expect to see in our drugs because we have an illicit drug supply.
And I think that's something that we have not highlighted yet, because if there were no harm reduction centers and there were no OPCs, where the OPCs, more people are able to check on their products,
Right.
much more so than a harm reduction one.
They would be able to get it tested right before they use the drug and make the choice to use less of that drug or even get rid of that drug and get something where they can get it tested again and have a better idea of what might be in it, which that right there mitigates some of that risk for overdose because they can then make that empowered choice on what to do.
Right.
It also, I believe, changes on a meso level how they communicate with each other out in the community with the drug supply, which then can alter the
Yeah.
results of what they get in the community.
And the xylazine test strips, can you tell me how reliable you're finding them?
There is a 30%, I want to say it's a false negative, or yeah. So a lot of what we do, if we're giving out xylazine test strips, we have worked really hard to build educational materials for people to say there is a likelihood that it could say it's negative, but there is xylazine in this drug. So here are the list of things that you can do in order to be safe. Here's access to wound care supplies so that if you do choose to use the drug, even though it does have xylazine in it, you have what you need to take care of yourself in the event that you do get wounds.
And are you getting synthetic drugs tested? Are you any luck with that? Because it's pretty crazy. That's what is being changed in
I
there?
mean, are you talking about like synthetic benzodiazepines, like
No,
Bromazlan
fentanyl.
or fentanyl?
Yeah.
Yes, I mean, everything is at this point is synthetic. We've been getting different types of analogs because of the fact that as soon as there is a change in the scheduling of controlled substances, especially with fentanyl, the next step would be and I'm speaking from like the drug dealer perspective, but
Yeah.
how do we overcome that so that we can still make money, right? So that's when we start to see more and more unstable drug supplies a lot of the time. So right now we're also seeing nitazines in some of our drugs, which is a opioid that doesn't have any medical impact.
You know, the data when we were learning in a conversation with On Point was also that the law enforcement was using some of this information, and also the EMS system was getting more prepared how to navigate these difficulties. And then you're seeing patterns, and then you can actually start to map out the source in some respects. And then they're using various apps to be able to identify the high risk areas and where the product was wrong and dangerous, and then what it was laced with, and people had these indirect ways of communication. So this has been helpful if we have mechanisms and those setups in place. Is this bill going to help some of those possibilities too?
I believe so, just because it's a matter of us working together to combat the crisis, not in silos.
Yeah.
So, it's the only way it's going to be successful is if we work with our municipalities as well as with each other at each of our organizations.
Right. And I think right now, because of various reasons, we're working in silos, and we don't even know what we don't know.
Right.
That's the problem in this situation. Yeah. Representative Mara has a question or comment. Yes.
Thank you, Mr. Chair. I'll just make it quick. I know we got a lot of people, but as you mentioned, the 30% false negatives, I'm just curious, do you think that's dose dependent? Concentration dependent?
It's a number of factors, but I think that if you know how to use it correctly and you do use it correctly, it will definitely be more accurate.
Okay.
There's always room for human error, right? And that even goes with the fentanyl test strips. There's room for human error. We just recently put out a public health statement for graba, the tobacco that's used in blunts, to try to combat misinformation that there was fentanyl in the graba, mainly because people were misusing fentanyl test strips and having to kind of re-educate on how to use them correctly so they can get more accurate results.
Okay, I assume that that's false positive, so.
Mhm.
Yeah, okay. And then my next question on that, when people use these strips and they're distributed, are they aware of their limitations? I mean, I would hate for someone to get a strip and think that they have a very safe supply.
I think that is really part of the engagement piece of what we do, right? Without that conversation, you're not, like you guys said, you're not going to know what you're not going to know. So really the central point of our work is that engagement and connection and being able to have open and non-judgmental conversations about the drugs they're using and about those harm reduction strategies that work.
Thank you so much. Appreciate it.
Absolutely.
Thank you. Representative Zepkis.
Thank you, Mr. Chair. Thank you for coming. If someone comes in and they're underage, is there anything you do differently?
So for a very important reason, because I like to honor people's safety and anonymity, I don't ask demographic questions. So they may come in and be 16, 17, but it's not my job to determine what age you are. It's my job to keep you safe and alive. So I will have the same approach to anybody that walks through my door.
So there's no, I mean, I'm just thinking if, I don't even want to say my daughter, but if she went in, I would want to know so I can help her. Right. And so if we don't, as parents or guardian or whomever don't know, we can't help.
I agree. I would say one, there's a couple different approaches. I think that it's important. The fact that the kid is walking in the door to do something like that already shows that they're trying to do the safe and right thing, even if they are going to continue using drugs too. There's something that they're likely suffering from, and that's why they're using those drugs. 3, I also encourage parents to have open and honest conversations with their kids about drug use that's not stigmatizing. Because kids are finding themselves, especially as teenagers. They're exploring, they're trying to figure out who they are, how to process their emotions and regulate their emotions in ways that are healthy. And it's our jobs as parents to be able to offer a safe space for them to have those conversations. I would commend my child if they walked in to go get their drug tested before they used it, because that shows me that they're being responsible with the drugs that they're using, because I'm not naive. I know that at some point my child may experiment and try to use drugs and see what that's like.
Oh, I agree. Open and honesty. And since I use my daughter, I mean, we talk a lot about everything, and I'm very honest with them on
Yeah.
everything, drugs, sex, and rock and roll, I guess. But, I think it's important to have that conversation, but there are times, as you just said, peer pressure may take over, and kids in high school or whatever, and addiction happens. And so I would just, I think if anybody, we would want to reach out, but especially a minor coming in, I think we can't help if we don't know. And
I would say one big caveat to that is HIPAA, though, right? So as soon as they walk in the door, there's that protection.
do you
with
go by HIPAA? Do y'all
I
have
do,
HIPAA?
yeah. That's actually part of the reason why I don't collect demographic data, because then most of my data is de-identified and I can share it more widely. But my hope is that if you have a strong relationship with your child, that if they are in situations like that, that they would come to you.
They always have somebody to talk to. That's
Right.
what I tell my girl. There's always, if it's not me, you can talk to somebody. But I just, the minor piece of it is really concerning, because I think parents, I don't think my kid is perfect, but we're all human and try things and do whatever. And I think as to your point about people being in bad places or things happening, as a parent, we can't help them if we don't know.
Right.
And that could lead to even worse things down the road. So I'm a big believer in communication, and I would have to think about that. Thank you.
Yeah. I will say that the likelihood of minors coming into our facilities are really low. I have not seen many minors that have walked into, it's not often that they engage with our services. If they are, they're usually emancipated or already not with their families and isolated in some other way, shape, or form. So that's that rare piece, right? And I also think that at that point, we would be looking at other connections to care and resources, because it's more than just their drug use at that point. It's, what is it that you need that you're not getting right now?
Thank you, Representative Carpina.
Thank you. My colleagues just sparked a couple of short questions. Do you give, it was the fact that you are intentionally not taking information so that you can have de-identified data at the end is interesting point to me. Do you give your clients the opportunity to provide a contact information in the event of an emergency?
Yes, but that wouldn't necessarily be through me. So I have ways of contacting my participants. I go back on outreach on a regular basis. They come in and they visit me. But I do have a separate piece where I will write down like their phone numbers and things like that. But that's on paper in a locked file cabinet rather than in my data where it has all of the drug use information.
Sure, and I make the offer for anyone who testifies after you, because I'm sure that different organizations may do some things differently. And if you run out of your 3 minutes before you get there, let me know and I'll ask the question. But I'm curious if, no different than an employer who gives somebody the opportunity, not the force, but somebody the opportunity to write down contact information so that there is somebody who can get called in the event of an emergency. And I ask because the minor issue also gives me great concern. I agree with you. Every child should have somebody to talk to, and not every child does. But my concern really is if we have a child, like Connecticut's children are our children, if we have a child who suffers an accidental overdose in one of our facilities, how is that child going to get help after they leave the facility? And that's a real concern of mine.
So I can only speak to the drug checking piece. I'm not running the entire organization, nor am I, going to be running the consumption centers if we do end up having them. Drug checking is my niche. I also do capacity building and training. That's my niche. But when it comes to things like that, we do the best that we can to have that contact information for people. All of our participants that participate in our programs, we do have that information. It's just the drug checking piece that I keep anonymous. So if I know who it is and it's somebody that does participate in our program, I do have the ability to access their contact information. It's just not something I keep personally on me. I agree with you that that is something that's important, but when it comes to drug checking, there's not really that emergency piece. It's that information and educational piece that we offer. On the other side with our participants, whether it's with our SSP program or with our housing program, it's a very different scenario.
Thank you. Thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, thank you so much.
Thank
I'm
you.
glad we didn't go over your bypass you through. Very important information. Next is Cameron Breen. Welcome, Cameron. Long day. It's evening.
Thank you. Thank you for having me. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee, thank you for having me. Thank you for allowing me to testify here today. My name is Cameron Breen, and I am here in full support of Senate House Bill 1285, an act establishing an overdose prevention center pilot. As I said earlier this morning during the press conference, I'm tired of writing eulogies for my friends. I'm tired of watching parents bury their children, and I'm tired of watching children bury their parents. We have proven life-saving, cost-saving interventions that we could be using, but we choose not to because of decades of just say no mentalities surrounding drug use. Culturally, we condone the death of people who use drugs, believing that in order for someone to get well, they must hit rock bottom. But due to our current and toxic drug supply, for many people, their first rock bottom is 6 feet below the ground. As someone who struggled with addiction, I can tell you that I never grew up wishing to be a heroin addict. When I used drugs, I often used alone. I would usually leave my car door slightly open so that if I overdosed, I might fall out or roll out and hopefully be found. I never wanted to die. I couldn't access overdose prevention centers that could have connected me with multiple kinds of supports because they didn't exist within our state. If they had, I would have used them. I know countless families who would still have their loved ones with them today. Did these people deserve to die simply because they use drugs? OPCs are proven logical interventions already in place all around the world. They save lives, they reduce costs, increase access to treatment, lower public drug use, and many other things that you've heard here today. It seems as though we've become culturally resistant to simply just helping one another. People who use drugs are also your constituents. They do not deserve to die simply because they use drugs. And if you vote against SB 1285, you are voting to continue the burden on first responders. You're voting to continue public drug use, and you are voting to accept the ongoing loss of life. I recently experienced two heartbreaking pieces of news that I would like to touch on here today. I have worked as an overdose response technician with the Waterbury Health Department. I have worked as harm reduction coordinator for McCall Behavioral Health, and now currently with Liberation Programs as a street outreach case manager and managing some of the drug checking program. When I worked with the overdose response team, I responded to close to 800 overdoses over the course of 2 years. Most recently, I learned that one of our early cases passed away. I had responded to this man's brother's death. I had responded to this man's partner's death, and as of a few weeks ago, he died as well. This is an entire family that has been completely wiped out. From conversations with them, I know that they would have used OPCs.
Excuse me, Mr. Breen, but your 3 minutes is up. Thank you.
The only thing I can finish with is that while we continue to talk about this topic, people continue to die, and I urge you to vote to save lives and create connection, because I personally know the profound ripple effect that one life saved can have. Thank you.
Thank you, Cam. Cam, you had a second example too. Do you want to share that? There were two stories.
The second example was a recent close friend of mine who had relapsed after 6 years, returned to use after 6 years, and he wanted to enter back into recovery and continue abstinence, and he did. I met with him continuously. I met his young son, and he unfortunately, he passed away in his bathroom, and his son woke up in the early morning to find him. I attended the funeral and watched him whisper into the casket, asking if his dad was still there. We have ways to address this. Morality doesn't matter here. Ideals don't matter here. Recovery doesn't matter here. Life matters.
Thank you. Thank you for what you do, Cam, every day, and the work that you do with Liberation. And I'm so glad that you are well, because you're saving so many lives. Thank you.
Thank you.
Andrew Rivera, welcome.
Thank you, distinguished members of the Public Committee. My name is Andrew Rivera. I am here in support of Senate Bill 1285, an act to establish OPCs. I couldn't think of the right way to start this. Am I going to say this as a concerned citizen? Am I going to say this as a community outreach specialist, or maybe as a former person addicted to drugs? All of these would have been accurate. However, I realize the most important thing I am is a human being. A human being who is given the gift of knowing right from wrong. I'm hoping everyone in this room and watching on Zoom was born with that same gift. And if you were, please apply it to the following sentence. Overdose prevention centers save lives. There was a time when I did not want to get off drugs, and the fact that everyone gave up on me and I had nowhere to go is the exact reason for my troubles with the law, most of my health complications, and most importantly, the trauma throughout my addiction. Not only will these OPCs save lives and provide safety, but they will in fact prevent trauma. My qualifications to speak on this subject lie within my 10+ years of intravenous drug use and 5 overdoses. Statistically, I shouldn't be here right now, let alone being able to put together a speech. I thank God every single day that when I overdosed on 4 of those occasions, that someone happened to be around to see it and do the right thing. I thank God twice every single day that when I overdosed alone in my motel room, I didn't just fall out like all the other times. This time I fell to the floor and felt all my organs shutting down one by one. It was the scariest moment of my life, and I was alone. I thank God 3 times a day for having my daughter at such an early age. If it wasn't for the memories of her dancing like a butterfly, memories of our tea parties, and the smell of her hair that rushed upon me, I wouldn't be here. They gave me the strength to crawl to the motel room door, open it, and scream for help. I thank God 4 times a day for my second chances at life. However, seeing countless friends die all around me often sparks the question, why me? This question has stained my heart with guilt for years. Why me and not them? I'll never get the answer I'm looking for, but I can use these 3 minutes to not only speak for myself, but for those as well. We wish we had somewhere to go when everyone else turned their back. We wish we were accepted as human beings and not looked down upon as criminals. We wish you paid more attention to us and not our addiction. We wish people would stop calling it the war on drugs. Wars eventually end. Drugs aren't going anywhere. Overdose prevention centers will give people a second chance at life in more ways than one. Printed on the face of every single piece of U.S. currency are the words, "In God we trust." The God I believe in would never deny people of a second chance. But yours?
Wow.
Thank you.
Wow. Thank you so much. There's so much. Don't leave yet. There's so much. It's like you hear this and there's emotions that you go through that is so powerful that you don't want the person to go away. You want to hear more. And then you say, well, it's been a long day for everyone. But I'm so glad you're well. And you have a gift of expression, gift of sharing. And it takes stories to change hearts and minds. You humanize this for every one of us.
Thank you. I appreciate that.
And there are about 1,100 plus people last year who were similar to you that would have been sitting in this room. Another 12 to 1,300 that have been sitting in this room if we had passed the bill in 2023. And I have to have lunch with you too now. So
time and place, I'm there.
okay. Seeing no questions, comments, we want to thank you for your comments.
Thank you.
Thank you. Sean Falzarano. Carol Cruz. Catherine Hinojosa. All right. Dita. I think Dita is here. She's probably close by. I'm getting a message. Yeah. Hey, Dita. We had a few people who didn't show up, so welcome. Thank you for being with us all day. Thank you.
I thought I was after my daughter, but I guess mom's first. Thank you for having me here today, honorable members of the Public Health Committee. I'm Dita Bhargava, a board member of Liberation Programs, Shatterproof, and United Way of Connecticut. I'm also a public health student at Yale University and an activist mom. And I'm here to advocate for Senate Bill 1285, an act concerning overdose prevention centers pilot program. In 2022, I passionately testified for House Bill 5044, and again in 2023 with my daughter Arya for Senate Bill 9, urging lawmakers to create overdose prevention centers in Connecticut. Since then, almost 4,000 people have tragically been lost to accidental overdoses, each representing a unique story and a future extinguished far too soon. Despite our state's continued efforts, the stark reality is that overdose rates remain alarmingly high as the disease of addiction continues to spread through our communities. One of the many heartbreaking victims of this crisis was our son, Alec Pelletier. On what should have been his 26th birthday in 2018, Alec lost his life to fentanyl poisoning while in a sober home. He was not just a victim, he was a loving, talented young man with dreams as a AAA hockey player. His journey was complicated by substance use disorder and mild bipolar disease, challenges he navigated with courage and with hope. In the months before his passing, we felt hopeful about his recovery. Alec was determined to live a life free from addiction, surrounded by those who loved him. He often grappled with conflicting voices in his mind, the voice advocating for recovery versus the one tempting him with just one last time. Unfortunately, that last time cost him everything. It cost our family everything. That night, burdened by shame and fear of judgment, he did not reach out for help and succumbed to his addiction alone. Alec's story is a poignant reminder of why overdose prevention centers are crucial. While opponents claim that these centers enable drug use, the evidence tells a different story, as we've heard today. Research shows that harm reduction strategies save lives by ensuring individuals have access to support when they need it the most. The FDA's decision to make naloxone available over the counter reflects a growing recognition of this strategy's effectiveness. The distribution of naloxone has played a pivotal role in decreasing overdose rates, and OPCs can provide similar life-saving interventions. Beyond emergency care, as we've heard, OPCs offer comprehensive resources, including addiction treatment, harm reduction services, and health education. Successful models, as we heard in New York and Rhode Island and all over the world, have saved thousands and thousands of lives. Vermont and Minnesota are moving forward with similar initiatives. Now is the critical moment for Connecticut to join leaders in this essential area. It is our moral imperative to protect the lives of our residents, ensuring that they receive support needed to not only survive, but receive the opportunity to thrive in recovery. By establishing OPCs, we can honor the memories of those we have lost and take decisive action to prevent further tragedies. Thank you for your commitment to this vital cause. Together, I know we can make a transformative difference in our communities all across our state.
Thank you so much, Dita, for your testimony, and thank you for your courage. I apologize to all the parents who come and have to share the stories of their loved ones and then relive the tragedies of their friends and family, just so that you can encourage our conscience to do the right thing. So, and then you do this many a times, and I cannot thank you enough for that. If you were to just look at the financial aspects, I know that in your other life, you're a financial wizard, right? So, well, sort of, right? And you look at economic opportunities and so on. Can you look at it from that lens as well, outside of the tragedy that you have endured?
Senator Anwar, I appreciate the question because I think any policymaker should be evidence-based, and we need to look at the economics and financials around any investment that we're making in our state. I wholeheartedly agree. But the notion that OPCs are a financial drain is simply untrue. OPCs are not only effective in meeting the moral obligation of saving lives, but they also save our taxpayers money. You might recall that Senator Murphy reported in 2016 he had conducted a study that the opioid crisis in Connecticut cost taxpayers over $10 billion a year. So imagine the money saved from ambulance costs, emergency department visits, hospitalizations, as well as opportunity costs of keeping people alive, working, and participating in our communities. Also recently, a study from Cornell University in just last year actually found that OPCs consistently generate greater benefits than costs, and that a single OPC, I think Livia talked about this earlier, can offset between $831,000 and $2.95 million, one OPC annually in healthcare expenses. Insight North America's longest running OPC in Vancouver, which we've heard a lot about today, has demonstrated that for every dollar spent, $5 is saved in healthcare and emergency response costs. So, you know, as we've heard from many stories today, we'd be challenged to find anyone in Connecticut who has not at least heard of someone who has died of an overdose, and our life expectancy is falling. That's a cost because of overdose. The fentanyl scourge has escalated this epidemic. So, I mean, the time is now. That this is not just lives lost, it is economic dollars lost.
Thank you so much. Is it in your testimony, these numbers and details?
I believe it is in my testimony.
Okay.
I
I've not
think so.
read it. Okay, good. So that will be helpful as we look at the financial aspects of it.
Do you mind if I make one more point,
Please,
Senator
please.
Anwar? Earlier today, Senator Summers stated, I think, quote, someone has to be ready for sobriety. I think she was referring to recovery, the recovery process in sobriety, that somehow an OPC would not necessarily successfully lead that person to sobriety. I don't think anyone here who has advocated for an OPC has said that it is a treatment or recovery center. So our son Alec went through multiple relapses, multiple treatment centers, multiple times that he tried, and then he'd be out in the world where society was not set up for him to succeed and start using again. Ashamed every single time. Treatment centers and the effectiveness of treatment centers is a whole entire different conversation. They're not necessarily regulated. There's no standard of care in a lot of them. So we know that addiction disease is insidious and it encompasses relapse. I don't think that referring to an OPC as a place where someone is necessarily going to find sobriety is really the right way to look at it at all. It's a place where we're going to save that person's life so that they can eventually find the type of treatment and the type of community and the type of long-term commitment to sobriety eventually. And I know that our son was on this path. He was doing so well. He made a mistake that night because that's how addiction disease works. If he was here today, he would have been on that path. I wholeheartedly believe that, but he needed his life to be saved first. I have a child with type 1 diabetes. The equivalent, I think, would be that I deprive my child of insulin because his levels are elevated, his glucose levels are elevated. I give him life-saving insulin because his glucose levels are elevated, the same way that we can provide a safe place for someone to stay alive because they're suffering from addiction. So it's a moral obligation, it's an economic obligation, and I plead that this time around, we take that step forward.
That's another very powerful analogy that we are doing the opposite for opioid-related issues. As opposed to this. Thank you. This is very helpful. Lot more food for thought for us. I just want to see if anybody has any other comments or questions for you. Senator Rahman, when
Thank
did
you,
you
Mr.
appear? By God.
Thank you, Mr. Chair. Yes, I just arrived in, but Yabdal, everyone food is ready outside, so this is why I'm here. Thank you all day. While I'm in here, I saw my friend on the list. Thank you. And I know it a long times. Good friend. Like my sister, I see my niece here today. I'm so proud of her. Thank you.
Thank you.
And I know what you are going through still and your family. I was early involved, and also I attend the funeral, your son. Remember that. And not just you and your family, also was hard for me personally. And so many family going through. But someone like you didn't give up. Since then, you start working on with all the legislators and governor office. I saw a number of time national stage. Saw you White House, and you are not someone just leave everything behind. We need people like you, more people. Across the state also, I visited a number of recovery facility, including one Manchester Pathfinder, long before I come this building. I personally involved and raise money for them, and personal donation even from me, from my family. And yeah, this bill, we have so many bills we are working on. This is not just a bill. This is something long due, and this will help and saves lives. I know, I don't know what I call mayor, doctor, senator, Senator Anwar working tirelessly day night with our amazing co-chair. So, I see when 12 o'clock, midnight, I receive phone call. Earlier I was listening when go hospital emergency room, and yes, they said, this is not the place you should be. Instead, helping them and or directed them to go or make the appointment or make phone call. It's a happen oftenly. I got it because hospital don't have the resource doing those stuff. But I think this bill is first stuff, and I want to thanks to the Senator Anwar and bring this bill. It is personal. So thank you, Rita.
Thank you, Senator Rahman. You probably remember I told you the story that our son is really guiding my work, my family's work. And, a few weeks before he passed away, I asked him at that time, how would he want me to talk about his struggles? Because it was his life. And I was running for office at that time, and I was talking a lot about addiction disease. And he answered my question with his own question, which was, would you ask me this if I had cancer? Which immediately I realized that I was stigmatizing just by asking this question. He said, so many of my friends have died and more will. And people think it's our fault. And legislators think about everything else but this disease and helping us. And he passed away 3 weeks later. But I feel very blessed because he left me with that rallying cry. And I won't rest until we start saving lives, until we stop seeing 1,000 people in our state, 100,000 people in our country die every year. And a big reason is because of stigma, because of thinking that if we have a center where we can save a life, somehow that's a moral wrong. It's not. It's our moral obligation. So I appreciate you remembering that awful day in our life when we had to say goodbye, but it shouldn't be in vain. We should save lives in his memory and the memory of so many of our children who have passed. So I appreciate it. Thank you. Thank you for being here.
Thank you.
Thank
No,
you.
thank you. You continue working on this issue, not just in Connecticut, across the nation. I see you traveling. So thank you for your advocacy and continue fighting for this issue. And like said, the teamwork makes the dream work. I think we'll go finish line. We have a great team in here. They will continue fight, and we're going to pass this bill.
Thank
Thank you,
so-
Mr. Chair.
Thank you. Seeing no other comments or questions, appreciate your testimony and the work that you do so
Thank you.
much. Thank you.
Thank you. Thank you all.
The next person on our list is Gabrielle Bogut. Gabrielle, you're on. Thank you for your patience. Welcome.
Thank you. Co-Chair Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Gabrielle Bogut, and I thank you for the opportunity to testify today on behalf of myself and in memory of my late brother, in full support of Senate Bill 1285, an act establishing an overdose prevention center pilot program. For 12 formative years of my life, I had watched my older brother fall victim to his addiction to heroin. As a child of Polish immigrants, I watched my parents struggle to find treatment options for my brother, unsure of how to navigate the vast healthcare system and unable to afford basic treatment for something that was not being treated as an illness it truly was. A substance use disorder ultimately took my brother's life, but an overdose prevention center could have saved it. We have heard from a lot of qualified, passionate people today about the logistics and efficacy of overdose prevention centers. So I would just like to reiterate that the overall purpose of an overdose prevention center is to do just that, to prevent an overdose. However, this goal can be accomplished in more than one way. Along with providing life-saving care in the event of an overdose, overdose prevention centers serve as safe, community and centered places where individuals struggling with addiction can turn to for a vast array of services. These centers provide safe, clean supplies for drug users to prevent fatal infections, such as HIV and HCV, that are often contracted through the use of unclean needles. They provide referrals to treatment centers and recovery programs, helping those who wish to gain treatment, but don't know where to look or how to begin their journey of recovery. They provide housing and employment services for individuals who are struggling to get back on their feet. They provide testing strips for drug samples to ensure that individuals are using clean and safe supplies. All of these services and more serve to help individuals with substance use disorders regain autonomy and reintegrate into the communities in which they are a part of. On the night of May 21st, 2023, my brother passed away alone at home after using drugs for what would be his last time. If he had had access to an overdose prevention center, I strongly believe that his death could have been prevented in at least 3 ways. For one, he could have spoken with a mental health counselor or a treatment coordinator who could have talked to him and just made the inner turmoil he was feeling, potentially persuading him away from using drugs again after being sober for 3 months. Second, he could have tested his drug supply and found that it was contaminated with a lethal dose of fentanyl, something he was unaware of. And finally, he could have used those drugs under the supervision of another person, someone who could have ultimately brought him back to life after he overdosed. My brother Patrick is one of thousands of people whose life could have been saved had they had access to an overdose prevention center. We have the power to prevent further lives from being lost to the fateful disease that is addiction. The establishment of an overdose prevention center pilot program is a critical first step in doing so. Thank you for your time.
Thank you so much, Gabrielle, for the testimony. Thank you. We appreciate you and so sorry for your loss. Seeing no other question or comment, we'll move to the next person on our list, which is Alicia Pedersen. And not seeing Alicia here, Carson Ferreira. Carson, welcome. Thank you for your patience with us and spending the day with us.
Thank you all for allowing me to speak today. My name is Carson Ferrara, and I'm here to voice my strong support for SB 1285. I studied the neurobiology of addiction at Vanderbilt University in undergrad. I'm currently an MPH candidate at Yale's School of Public Health, where I focus on substance use disorders and harm reduction. I lead the Addiction Medicine Collaborative at Yale, and I'm a Leadership and Global Health Fellow with the United Nations Children's Fund, focusing on global substance use disorder prevention. I also work in the emergency department at Yale New Haven Health on clinical trials for opioid and alcohol use disorder, and I want to share a brief story with you all. Last year, while I was working in the ED, I was calling patients to follow up on missed 7-day follow-ups. So we usually have them fill out a survey after they were seen by us in the emergency room, and just see how they're doing, if they've been connected to treatment, how they're tolerating the medication, things like that. I was able to contact one patient's sister, and she said that he had passed away the day after he was enrolled in our study. He had received injectable buprenorphine, which is a medication for opioid use disorder, in the emergency room, was highly receptive to treatment resources, and was connected with an addiction recovery coach. He was given options for inpatient and outpatient care and was on the road to seeking those options out. He did everything right, and yet he still passed away. And I firmly believe that if he had been able to access an overdose prevention center, he'd still be alive today. Something that I want to highlight is that people who are dead cannot access treatment. And OPCs serve as a vital intervention, a vital component of a larger set of strategies to prevent fatal overdoses and connect people to care. So the research is very clear. OPCs do not increase drug use among people who are not already using drugs. They instead facilitate pathways to treatment and harm reduction services when those people are ready to do so. A study on an OPC in Vancouver, Insight, showed a 30% increase in detox services within a year of them opening. Another study on an originally unsanctioned OPC in the United States found that 42% of OPC participants not in treatment at baseline enrolled within 24 months to treatment. So the OPC served as a starting point for them then getting into substance use disorder treatment. If you want to see this data for yourself, I've emailed a 2-pager with relevant data on OPCs to most of you, and please refer or forward it to your colleagues if I missed anyone. And I fully understand the hesitancy towards overdose prevention centers. I understand that it might seem like an avant-garde idea, but the evidence for their effectiveness is clear from other countries, and now also coming out of New York City and Rhode Island. It's blatantly clear. I also would encourage you all to read the testimonies that were submitted by folks online, especially healthcare professionals who are working in substance use disorder treatment and seeing patients every day who go through these struggles. And they acknowledge and support the establishment of overdose prevention centers. These are the people treating these folks.
Excuse me, Cameron, but you've reached your 3 minutes. Thank you.
Yes, so I'll just wrap up by saying you can't claim to want to reduce public drug use and oppose this bill. You can't claim to support treatment access and oppose this bill when the data is clear. You cannot claim to be pro-life and oppose this bill. You can't demand data be presented with it and, again, still oppose this bill. As others have said, this is about saving lives, and I really urge you all to pass SB 1285. Thank you for your time.
Thank you so much, Carson, for your testimony. Carson, I know you've been working and looking at the data as well. In 30 seconds, can you tell us about the data, the strong points, if you have them accessible, that you have in your testimony, I think?
Yeah, absolutely. So obviously there's a component, the health impacts component, in that OPCs reduce overdose deaths across the globe. They also reduce hospital and emergency department visits. As I'm sure many of you know, EDs are very crowded across the country. And I see patients every day that I'm working there who are there for an overdose or accidental overdose. Additionally, the OPCs increase engagement in treatment. We do know that, and I know that's something that y'all have asked for, and I've intentionally sent that to you up front. They're also cost effective. So as others have pointed out, they could save this state millions of dollars. And prior to Rhode Island opening their first OPC, they had people in their Department of Health who did a study estimating that just one could save the state up to $8.9 million annually. And you can read more about like how that works in the data that I sent you all. And then also it works to prevent or to promote long-term saving by preventing new HIV and Hep C cases for people who develop those symptoms or those diseases from injection drug use and things of that nature.
Thank you so much. So, Representative Uptis? No. Seeing no other questions, thank you so much for staying with us and your testimony and the work you're doing. You're going to go back to Catherine. She was having some difficulty logging in. So Catherine Hinojosa, I hope I'm pronouncing your name right. Welcome.
Thank you. Thank you for having me. So good evening, esteemed members of the Public Health Committee. I'm testifying in support of Senate Bill 1285, which authorizes the establishment of an overdose prevention center pilot program. My name is Catherine Hinojosa. I'm a doctor of nursing practice and work as a nurse practitioner at the Community Health Center of New London. At our clinic, we provide life-saving medications to people suffering from substance use disorders, mainly from opioid use disorders. Today, I'm testifying on how the lack of overdose prevention centers is killing my patients, is killing our neighbors and community members. When you work in healthcare day in and day out, you get to know the victories and the losses of those who you care for. You celebrate their recovery and witness firsthand the positive impact of providing evidence-based medicine. But you also see the dreadful consequences of public health protocols that do not prioritize the creation of safe spaces for individuals struggling with addiction. I want to share the story of Daryl. Daryl was a well-regarded member of our community. He was a patient of mine. He had a deep laugh and a smile that could light up any room. He would often check in with our team, ask us how we were doing. When he noticed we were stressed out, he would bring us snacks and make us laugh. He struggled with addiction, and despite of all our efforts, he would feel ashamed about his disease and felt unwelcome in most places. That brought him to use alone, and consequently, he died of an overdose with no one around him. Overdose prevention centers save lives. The evidence is clear. Giving access to harm reduction, not judgmental, safe spaces to people who use drugs is a human right. We have listened to many testimonies today stating so. I ask you to support Senate Bill 1285 so I can continue to provide life-saving medications to alive people. Thank you.
Catherine, thank you so much for your testimony. Gracias por tu testimonio. Buenas noches.
Muchas gracias. Lo quise hacer en español, pero de repente nadie me entendía.
Gracias, mi amiga. All right. Seeing no questions, we'll move to the next person on our list, which is Lauren Pristo. Lauren, are you here? Well, that brings us to Jasmine Cristiano.
Hello.
Welcome.
Thank you for having me. Thank you to Senator Anwar and McCarthy Vahey and all the other committee members that stayed up late tonight. I am here in support of Senate Bill 1285. As you've heard throughout the night, a lot that goes into this is destigmatizing people with addiction and saving lives, providing that life-saving medication like naloxone, Narcan, testing strips. We've heard a lot about fentanyl poisoning tonight. I've seen firsthand from my experience volunteering at homeless outreach centers, like ones in Bristol. And I've lost people both personally close to me and people that I have gotten to know on a firsthand basis while volunteering. People that, thinking of if we had an overdose prevention center, back in 2022, 2023 would still be here today. One that really comes to my mind that became a personal friend. I won't say her name, but those who know her know that she was a wonderful mother. She loved to brag about her daughter and her academic success. And even though she was unhoused, and she would come to our center for services, she would still, if we were short on volunteers, hop on over, help wash dishes, help serve coffee, food, just the sweetest woman that you'd ever know. And due to the shame and stigma that surrounds people with addiction, she used alone. And unfortunately, she did get a bad batch and she died from fentanyl poisoning. And all I wonder is just if we had a center like this one that we're talking about, if her daughter would be graduating this year. And I wonder if she would still be alive to see that. And I'm working in recovery centers, and I've seen people that have made it, people that have been able to like come to the other side of addiction and survive it and thrive in recovery. And these people have survived their overdoses because there was someone there with them, because they had that support. And I am very heartbroken by the fact that there are so many people out there that don't have that, or that are so ashamed and do have that, but they choose to hide it from their loved ones and use privately. And then there's no one there to administer Narcan. There is no one there to call 911. And no one wants to die from their addiction. It is a disease. And unfortunately, it is becoming like cancer, where everyone knows someone who's been impacted by addiction now. And with that, I will answer any questions that you may have for me. Thank you.
Thank you so much, Jasmine. I'm not seeing any questions, but I wanted to just appreciate your testimony and staying with us throughout the day today. Next person is Lauren Pristo.
Hi, good evening. Sorry I couldn't be there in person anymore. But thank you, Co-Chair Senator Anwar and Representative McCarthy-Vahey and distinguished members of the Public Health Committee. My name is Lauren Pristo, and I'm a resident of Bristol, Connecticut. I hold a master's degree in public health from the Yale School of Public Health and now serve as Director of Community Engagement at McCall Behavioral Health Network, which is a behavioral health nonprofit serving Western Connecticut. During my time there over the last 6 years, I have overseen a lot of community-driven solutions and been on the front lines of some really important work in harm reduction in the community. And during that time, I know myself and my colleagues, if you hear the desperation in our voice for this bill, it is because we have experienced a type of grief that just brings you to your knees every single day. The number of lives and people we have known and met and loved in the community who have been lost to a preventable death it just takes your breath away. And so I am here speaking in strong support of the bill. And I want to just make a few comments. I did submit written testimony with a helpful amount of data. I think that would address some of the questions that have come up. But there's a couple of clarifying data points I did want to share. So there was a question about race, of who's impacted by overdoses by race. Non-Hispanic Black populations are higher in the years of 21 through 2024 when compared to 2020. And this is at a time where we're celebrating decreases in overdoses. However, non-Hispanic Black populations are increasing. And the overdose death rate remains much higher than the non-Hispanic white populations. So Black populations are dying from overdose at a rate of 68.4 per 100,000 population versus just 34.5 per 100,000 population of their white counterparts. I also want to mention that overdose rates have gone down amongst men, but have remained stagnant in women. And one thing that OPCs do provide is a safe place to use. I know a couple folks have talked about that prior to this, that people who access that service have expressed a level of safety they feel. Certainly consider that for women as well, because it provides them a space where they can go, use, be safe, and not be at risk of assault. I want to close just by saying, we ended last year with week after week having debriefings for grief for our staff because we just kept losing people. We started the new year with the loss of a friend. On December 31st, he passed away, and at his wake, we're standing around. Several folks in the room were there as well, and we were devastated by the loss and also devastated knowing he didn't have to die. And we watched his little boy go up to the casket and whisper, "Dad." And knowing that did not have to happen and being there for that was probably one of the most heartbreaking experiences of my life. So thank you. And I'm happy to answer any questions.
Thank you so much, Lauren, for your testimony. Lauren, can you just repeat the data that you had talked about? While the total numbers are decreasing, that there are some population it's still increasing. I missed it. I was taking quick notes, but I think I may have missed that. Can you repeat that, please?
Yep. So this is available too, and I'm happy to share it afterwards in some of the DPH reports. So non-Hispanic Black populations, overdose rates are higher during the period of 2021 to 2024 when compared to 2020. The overdose death rate amongst non-Hispanic Black populations remains much higher than non-Hispanic white populations. Non-Hispanic Black populations saw an overdose rate of 68.4 per 100,000 population, and white population saw a rate of 34.5 per 100,000 population. And then the other statistic I shared was that overdose death rates have decreased amongst male populations, but have not significantly changed in female populations.
This is helpful. Would you be able to share this data with us so we can make sure that everybody in our committee does get access to it, please?
Yes, I will be sure to send this after. Thanks.
Good. Thank you. Representative Chris. No. Okay. Can you just reflect in a couple of sentences when some people say that we have already been successful with the opioid epidemic?
Sorry, could you repeat that question?
So you know how some people in public health arena, they say that we have been successful in the opioid epidemic. How would we reflect and then respond to that?
I think we've made some courageous strides to implement things like harm reduction, naloxone access, and different interventions that have made a big difference. But we're not going to be able to save the lives we need to save as long as we have the volatility of the drug supply that we do. And until we have a safe place that people can go and use, especially when we're looking at a whole continuum of care. Let me actually read you a line from my written testimony. Strengthening the public health framework with comprehensive wraparound interventions will help sustain momentum, yet the continuum of care remains incomplete as long as people are left to die alone of an otherwise preventable death. So while we've been building out that public health framework, we're not there yet. And there's aspects of what we're doing now that are important, but this is also an essential piece of that puzzle. And different things like Safe Spot, which I know there was some significant investment in, will support aspects of saving lives, but what needs to be done cannot be done without an OPC.
Thank you. This is very helpful. I appreciate your testimony. Seeing no other questions or comments, we'll move to the next person. Thank you so much.
Thank you.
Peter Ken. Peter, thank you so much for being with us all day. Welcome.
Members of the committee, co-chairs, thank you so much for putting on this remarkable event. My name is Peter Canning. I'm here today to speak in support of SB 1285. I've been a paramedic in Hartford for over 30 years. I've responded to fatal overdoses all over the city, under bridges, behind locked bedroom doors, in cars parked in out-of-the-way places, and in park porta potties within sight of the Capitol Dome. All these deaths were preventable. When an opioid overdose is recognized, and naloxone, an opioid antagonist, is given before a person's heart stops beating from lack of oxygen, the result is life. Back in 1995, when I started working the city streets, paramedics were the only ones who carried naloxone. Today, it is heartwarming to respond to a 911 call and find a friend or family member embracing a resuscitated loved one and see a used vial of naloxone nearby. Public naloxone has brought the death rate down, but naloxone doesn't work when people use alone. Stigma and law drive people to hide their drug use from others, and they die because no one is there for them when their breathing stops. 91% of people who die of fatal overdoses in Connecticut die alone. Lifeless for hours or even days, all I can do is confirm a strip of flatline on my heart monitor and put a sheet over their bodies. In 2022, I spoke on a panel with Sam Rivera, the man who started and runs the New York overdose prevention sites. Centers can help reduce these deaths by offering a place of safety and hope. Sam Rivera described the camaraderie that develops among the people who use drugs there. Instead of doing an extra bag, people talk with each other about the NBA Finals. Women who avoided mirrors when they started coming there now wear makeup. The place is a community where people with substance use disorder feel safe. They no longer see themselves as junkies, the objects of scorn and stigma. People are called by their given names, not by generic slurs. They feel human. These supervised sites are not just a place where people can use drugs safely, but as the harm reduction activist Guy Felicita has said, it's also a place to stop using drugs. Trained staff are there to connect people with social services, and for those who are ready, treatment and recovery. Overdose prevention centers lead to a greater chance of getting users off drugs. They are places of transformation. I once believed that drug use was a character flaw, but thanks to the lessons my patients who use drugs have taught me, I've learned not to judge the roads other people have traveled. Childhood trauma, sexual abuse, injury, and mental health can all set someone down a path they could not have foreseen, and one that is difficult to break free from. Drug use disorder is a disease that must be fought with caring and patience. The medical provider's Hippocratic oath says, "Into whatsoever house I enter, I will enter to help the sick." An overdose prevention center is a house of community that represents the love we are capable of offering some of our most vulnerable citizens. Let us choose life. Thank you.
Thank you so much, Peter. I'm so glad you waited all day to say what you needed to say, and it's very powerful. And we hear you. And thank you for the work that you have done. In the midst of a pandemic, you're seeing another set of challenges, but you're also seeing the second pandemic that we have not yet addressed. And you saw all these deaths one way or the other. So thank you. Your words will help us make better choices. Seeing no questions or comments, we'll move.
If I could just
Yes.
give one brief anecdote here.
Sure.
You've been talking about how these centers might work. In Hartford, sometimes I'm in a paramedic fly car. I park down under the bridge by the train station. And I hear on the radio an overdose go out for 557 Albany Avenue, which is the drop, Mark's place. I respond. When I get there, Alex Ditmore, who's going to be speaking shortly, she's there with the patient. Man went into the bathroom there. After he didn't come out after a couple of minutes, she checked on him, opened the door, which opens out rather than inward, gave him naloxone. By the time I got there, he was resuscitated. And then, you know, we talked to him, would he want to go to the hospital? He didn't really want to go. I was able to leave him there under Alex's watchful eyes. So a life was saved, and ambulance transport was spared. If that place wasn't there, if that bathroom wasn't there, he could have used in the subway down the street, where I've also done overdoses, behind the locked bathroom door, where by the time we get there, it's too late. So it's a really wonderful thing. And the people here behind me, I know many of them are true heroes. They've taught me a lot about harm reduction. And I'm so grateful that you're able to listen to them today. Thank you.
Thank you. Thank you, Peter. Next person on our list is Ada Megan Thiel. Welcome.
Good evening, and thank you for this opportunity to testify. My name is Ada Megan Thiel, and I'm here to voice my support for SB 1285. I'm an undergrad at Yale, speaking as a community member who believes OPCs would benefit us all. Johns Hopkins estimated last May that 48.9 million US adults have a family member or close friend who died of overdose, and tens of millions more know someone who died less closely. I give this statistic to make it abundantly clear that the people here today who are bravely testifying to personal experiences and sharing stories of loved ones lost are sadly not outliers. Rather, they are here representing a far too large share of the affected US population. It's not just a few individuals or isolated tragedies, but a public health crisis that concerns us all, and we have the power to do something about. Overdose prevention centers would save lives. There are loved ones that would still be here if we had centers like these. Knowing that alone should be enough to pass this bill. After Insight opened, the center in Vancouver that's been discussed throughout the day, there was a 30% increase in detoxification service use, increased rates of long-term treatment initiation, and ultimately individuals reduced their personal injecting at the site. Also, as shared in previous testimony, SSP participants are 5 times more likely to enter drug treatment and about 3 times more likely to stop using drugs than those who don't use SSPs. So there is evidence that these services can help lead people to access treatment. But even if not every single person is in treatment, that doesn't mean we should throw in the towel on preventing fatal overdoses and reducing HIV transmission. And that's not to mention all the other benefits, resources, safety, community, and connection that are available at these centers, as people here are testifying and the studies are showing. If all of this isn't enough, then please pass this bill on the grounds that OPCs will actively benefit our communities, even community members that won't directly interact with these sites. We're talking fewer syringes in the streets, less public drug use, reduced HIV risk, and OPCs are also incredibly cost effective. And I hate that I'm going into money because it's far from the most important thing here, but it is a way to illustrate how these centers are for our collective benefit. Insight's estimated annual operating costs are just below $1.7 million, but it has saved so much more money. Each year, it is estimated that Insight saves between $2.85 and $8.55 million by preventing HIV transmission, and another study reported that $17.6 million was saved in lifetime medical expenses for each year Insight operated. This is not just saving money long-term, but also in the moment, as there will be a reduction in ambulance runs, emergency department visits, and inpatient hospital stays. So these centers aren't just an asset for the people using them, they're an asset to our shared public health system. Insight is just one Vancouver building of 1,000 square feet that's saving millions of dollars and, more importantly, priceless lives. We could do the same here in Connecticut, so please don't let this opportunity pass us by. Thank you.
Ada, thank you so much for your testimony here with us today. We appreciate you staying with us and sharing your passion and advocacy.
Absolutely. Thank you.
Hearing no comments, we'll go on to Alex Ditmore.
You said it correctly.
Welcome.
Okay, which mic, first or this?
The first one. You can turn the one on the right off, actually. There you go. Thank you.
Well, at this point, good evening. Good evening, distinguished members of the Public Health Committee. My name is Alex Ditmore. I am a resident of New Haven, Connecticut, and I am here today in full support of our bill for overdose prevention centers. I want to start off by saying that this is a pilot program. So I had the privilege of doing direct care service in this work since I was 20 years old. I've worked in 2 different syringe exchange programs. I helped manage the drop-in center on 557 Albany Avenue, which was the state's first harm reduction drop-in center. I've seen the very real human and fiscal cost to the opioid epidemic. I have to admit, I hate the fact that in order to get people to care about this and to vote on this, folks have to relive their trauma and tell everything about their personal lives. If you would like a sad story to win a heart and mind, I will gladly tell you. I now work for the National Harm Reduction Coalition, where my full-time work is providing trainings and technical assistance to direct service providers. This includes medical doctors, community members who are just regular folks wanting to know what the heck this is all about, as well as peer recovery workers, social workers, and so on. And in this work, I have found one thing to be true, particularly at a national level. What we are doing is not enough. We need more options. We do not just need more funding for services. We need more options. Whether you like the idea of an overdose prevention center or not is irrelevant with the fact that it works. I don't say that condescendingly. I say it as an invitation to be okay with complex feelings. I mean it from the bottom of my heart when I say that I would love to speak with anyone who has a lot of worries about what this might look like. My work, and now what I do, is providing that education, working with people who are very against harm reduction, who are experiencing stigma and so on about those complications. Because the reality is, this is going to be a complicated process. Getting this passed is step one. Implementing it is a whole other ballgame. But while we get stuck in the what about isms, we are saying that our personal feelings on the matter and concerns are more important than the people who would be saved in this. I wish I had more time, because though many people have spoken about how it saves lives, it does a lot more. My direct care experience heavily showed a lot of connection to treatment programs, mental health care, behavioral health care. I helped people get connected back to their family members who they hadn't spoken to in years. And we also have to think about who is not going to access traditional treatment centers. We have these racial health disparities for a reason, and it's imperative that we focus on it. I know I'm running out of time, so I want to be respectful of that, and we've had a long day. So I leave you with this. You don't have to work at an overdose prevention center to pass the law for it to come into existence. I'm not trying to convince everyone to be 100% wholeheartedly behind it like I am. I'm asking for you for the availability and the option to allow everyone who has come here today who does this work and knows how to do it to do that work. We are the experts in this, and we need you to allow us to do this. And again, I will gladly talk to anyone off time about what it is that really holds you up with this, because the evidence is there. You can Google the stats, to be honest, and everyone else already gave you the stats. Truly. Thank you so much for your time. Please allow it to happen. Allow for the people to do it. It is a pilot. When those obstacles come up, we will face them head on and we will pivot, because that is what we do as harm reductionists. Thank you for your time.
Thank you, Alex, for your comments. I have one question for you. You're with your work and you do training, and as we've been having these conversations, and to your comment about implementation, the community involvement does seem to be a piece that many people have talked about.
Yeah.
Helping to bring a more welcoming sense and education with neighbors, with other businesses, with law enforcement. Is that some of the work that you do also, or are you primarily working with the provider community?
I do both. I smile because my favorite part is working with community. I was a harm reduction skeptic when I came into it, to be honest, because of my own lived experiences. And yes, we do work with the community. I had the luxury and the privilege of doing community listening sessions in New Haven on what overdose prevention centers would even look like in Connecticut. Do we like it? What do we not like about it? What does the community care about? Because the reality is, depending on where you service, you don't see this as often. Everyone might be impacted by it, but I say this with love. An experience does not equate to a skill. Just because you have the experience of loss doesn't mean you are skilled to respond to it in this sort of setting. We need different types of settings to exist for different people. Traditional treatment might work for some, NA might work for some, an OPC might work for some. Others won't engage with any of it. But the reality is, the folks who are the hardest to reach tend to go to these overdose prevention centers, and you do not do anything you can't work in harm reduction and not think about community. I could go on for days about all of the ways in which Connecticut Harm Reduction Alliance, for example, serves its community beyond just people who use drugs. So yes, you talk with folks, of course, you want to know where it's going, because the reality is the onus gets put on inner cities. Many of you get to go home and never get to see someone shooting up outside. You don't have to walk your kid to school and walk past a syringe exchange. I used to do 6:45 a.m. street outreach, and I would watch people walk their kids to school. They don't have the privilege of having these conversations in the comfort of their home. They have to have them now because it's in their community. So we also need to include them in that process. So the education is a multiple thing. It's many conversations. It's education about harm reduction, and it's also reciprocal. What does our community need? Because a drop-in center or syringe exchange is not just syringes. Of course, that is part of what we do, and naloxone is great. But basic needs, spiritual community needs, you have to wrap around the entire community or you're not going to be successful. And that's what we've seen with other pilot programs. They're siloed away. They don't want to be seen. We have the NIMBYism, and then they fail because they were set up to fail because they never actually included the people who are going to be impacted by that implementation the most.
I very much appreciate that because that's the social work perspective of including those who will be impacted and letting them have a voice in the process. So I thank you for your work and for your comments, Senator Anwar.
Thank you so much, Madam Co-Chair. Thank you for your testimony. I'll share a little bit of a background. When we had the needle exchange program start, I was a skeptic. And my first hardwired reaction was, what are they doing? Here we have an epidemic, and then they're actually trying to exchange needles so that more people can use it and spread them out. And it takes a little while. You have to have conversations with a lot of people and understand it. Then you start to look at the data, and then you start to, because the society hardwires us to think certain ways, and you have to look at it and then immerse yourself a little bit to understand this. And I think every time there's been something, even at one point, we were having some opposition about use of naloxone and then having it not be prescribed. And then say, what, how can we not, so you go through that process. Now it's not even a question anymore. And we know that it's helping. So I appreciate your willingness to be open to interact with many of the Public Health Committee members, whoever is interested, and that may help us understand this better. So I wanted to thank you for that. And with your testimony and the written testimony, I believe we have your contact information in it.
I will make sure that you get it.
Okay, that'll be helpful because you get this and then you live in this space and you can help us make better choices.
Thank you.
Thank you. Seeing no other questions or comments, we want to move to the next person. Thank you again for your day, spending the day with us.
Thank you.
Thank you. Next person is Aria Pelletier. Aria, welcome, and thank you for your op-ed in CD Mirror.
Fellow legislators, I'm Aria Pelletier, a sophomore in high school. I request your support for Senate Bill 1285, an act establishing an overdose prevention pilot program. I remember visiting my brother Alec at a treatment center in Kent, Connecticut on Father's Day 2018. I was 9 and recall seeing Alec with hope in his eyes, smiling lovingly as he taught me soccer ball rainbows. He looked forward to spending time and moving back home. I recall telling Alec that I was leaving for a trip and couldn't wait to see him again upon my return. That was the last exchange we had. This is us on our last day together. 3 weeks after leaving the treatment center, Alec left this world on July 13th from fentanyl poisoning on his 26th birthday. Losing my brother was profoundly shocking. How could someone on the mend, who had so much to look forward to, be snatched away so suddenly? The answer lies not in Alec's actions, but in the gaps within our societal and public health systems. If Alec had access to a safe place that night, where he could find help in his moment of despair, he would be here today. Alec was a handsome, funny, athletic teddy bear. He played competitive hockey and inspired my brother and me to play. I'm a goalie, like Alec, and proudly wore his jerseys, and often, while on the ice, called on him to guide me from above. Alec's absence is a void that can never be filled, a testament to the failure of our systems to protect the vulnerable. Addiction is a disease, not a choice, just like cancer or diabetes. It is not my brother's fault that he succumbed to this battle. It is the fault of a system that didn't regulate the greed of big pharma that distributed addictive OxyContin, which my brother fell victim to. It is the fault of a public health protocol that doesn't prioritize the creation of safe spaces for individuals struggling with substance use disorder. My parents told me that Alec would often take a while to ask for help when he relapsed. Societal stigma led him to feeling relapse was a moral failure, but Alec wanted nothing more than to be on a permanent path to recovery, and he did not want to die. That last night on his birthday, Alec had carefully placed Narcan by his side, but was afraid to tell his roommates that he was vulnerable and needed help. Public health leaders have made Narcan readily available, but what good is it if no one administers it? If there were a safe, non-judgmental place for Alec to go to that night without shame, where an overdose could be reversed, he would still be with us. Often, I wonder what life would be like today if my brother was still here. I wonder what he would be doing for this epidemic, though I have no doubts that he'd be here testifying today. I was here 2 years ago with my mom pleading you to pass this bill. I plead again. Please pass this bill so families don't have to be deprived of their time with loved ones. This bill is essential to reducing deaths and is essential to providing safety and comfort to a loved one and their family. Thank you.
Thank you so much, Arya. Thank you for your testimony and your courage, and I'm so sorry for your loss. And then it takes a lot of courage to come and speak when you're hurting as well. He would be so proud of you. Anything else you want to add?
No, that's it. Thank you.
Okay. All right. Thank you so much for your testimony. Thank you. Next is Liz Evans.
Co-chairs Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Liz Evans. Thank you for the opportunity to testify. I'm here to support Bill SB 1285, an act to establish an overdose prevention center pilot. Lots has been said already today. Honestly, I'm a little bit exhausted and very sad, and I'm sure many of you are sad as well. There's been a lot of trauma stories today, and I kind of don't want to tell any more of them because you get the point. People have died and continue to die, and it's overwhelming. It's also frustrating because I first became involved in these discussions in the early 90s. I was a nurse. I worked in an emergency department in an inner city hospital. I left to work in a low-income community because I was sick of the revolving door in the ER. People were living on the street and they needed other kinds of programs and supports to keep them out of the hospital. I ended up running a low-income hotel in the middle of a densely populated low-income community where a lot of people started to die in what was at that time the first wave of the opiate epidemic in our community. People that I started working with that I grew to love and care about were dying, and every day I'd hear more stories from people about people they knew who had died, in whole families being wiped out. And in the early 90s, we had about 400 people each year that were being lost just in our immediate community. But what was awful was there was absolutely no public outcry at the time because people who used drugs were actually seen as disposable. The term junkie comes from the verb junk, the noun junk. And they were particularly seen as people who were junk. Their pain, their scars, their open wounds were regarded as marks of a life that was already lost. I remember finding the body of a 22-year-old woman that was literally thrown into a dumpster behind our building. She had overdosed and died, and her body had been thrown away. On bad days, I'd walk to work past people who were lying in doorways. I'd check them for signs of breathing. I'd grab my face mask, and I'd launch into CPR. When Insight opened in 2003, it was because we had lots of conversations like this beforehand. Experts share what they knew. We realized we had no choice. The suffering was just too great, and what was being done was not good enough. The day Insight opened, I sat in the back and I watched. The space was clean and peaceful and welcoming, and the light was soft, and there was calm music playing. And when people came in and used, they did so on clean tabletops in front of large mirrors, with nursing staff there to provide education, with staff to talk to them. And I cried. It was overwhelming because the contrast was so stark. Outside, people were injecting from dirty puddle water, dying in alleys, crouching in doorways, and dying. This space felt sacred. History has shown us that we often believe things to be right and then later recognize they were deeply wrong.
Excuse me, Miss Evans, but you've reached your 3 minutes. Thank you.
I really want to hear the rest of the testimony, please. Thank you. You'll have to press the button again, sorry.
We once believed lobotomies would ease suffering. We took First Nations children from their families because we thought we would civilize them. We believed the world was flat. We believed the war on drugs was a good idea. And we've believed that people who use drugs somehow deserve to go to jail. We've also believed that people who use drugs deserve the suffering they're exposed to. But ultimately, people who use drugs are just people. Overdose prevention centers don't cure cancer, but when people use drugs that are too strong, toxic, or contaminated, and when their tolerance is low or when they're sick and vulnerable, these centers help to keep them alive. They provide actually a place where hope can begin, hope that their drug use does not define their worth or their humanity. In Fairfield County, where I work now, we have a dedicated team of people that reach out every day to folks that have overdosed. We offer support, we offer resources, we link people to treatment, and we offer harm reduction. But we also suffer alongside of them because we see them in isolation and we grieve when they die. We can and we should do more. Overdose prevention sites don't work miracles. They don't erase the pain of addiction, but they can shift the story. They can offer a different message. The message can be you're enough. Your drug use does not define you. You deserve to be loved and you deserve life. And that's really it.
Thank you, Liz. This afternoon, in my conversation earlier, I had said that I don't know any nurse, perhaps even any healthcare worker, who has saved more lives in the current times as you have. So I need to just repeat that because you're the founder of all these overdose prevention centers. It's a blessing that you stayed your entire day over here with us. You're like an entire world, wherever anybody is suffering with these challenges, they look you up and they say, we wish we had a Liz Evans in the community. Really, it's a fact. I mean, she's a rock star in the OPC world because she's the founder of the OPCs, including the On Point, including the Vancouver one, including the others. And so you have single-handedly, through your efforts, saved more lives than any healthcare person that I know of. And so I'm honored to be in your presence, and you speak truth every time we speak and learn. I say that to you every time, that whenever I have a conversation with you late at night, I'm contemplating on what you have said, and it makes me continue to think. So thank you for all that you're saying. I know my colleagues will have some questions. I just have admiration. I don't have questions.
I just really need to say, I have always worked with teams of amazing people. And as you all know, no one person does anything on their own, right? So I have been enormously privileged to surround myself by teams of amazing human beings like the people behind me. People who work every day from their heart to do work that they know and they believe in because it matters. And so just like you all, every day you come and do public service, which is not exactly an easy job. So I am also very grateful for the fact that you make that commitment to Connecticut, and we are deeply grateful to have the opportunity to even speak about such an important issue and let you guys
Thank you.
spend time with us.
Thank you. Representative Mara has a question or a comment.
Thank you so much. I always love hearing you talk. I love following you around. I appreciate the first time I got to meet you when we came to New York and saw your site. It was eye-opening. And I just encourage all of my colleagues up here to come out and visit, and maybe we can plan another site visit. I think that would be really good as we've talked about people that have supported or haven't supported this idea. I think seeing is believing. I was already a believer before I was there. I've always been a supporter. But I wanted to talk to you a little bit about some of the testimony that's come in, particularly Demas has talked about that they don't have funds for this. So that's going to be maybe an issue, but they did mention using the opioid settlement advisory committee money to approve a 3-year period of a hotline called Safe Spot. My understanding of this is it's an overdose hotline. Can you talk about that and maybe how that might compare to injection site? And maybe do you need injection site still if you have something like that? Or where does that fill in this?
Yeah, great question. So overdose prevention hotlines are places where people who, when they're using drugs, can have somebody else on the phone with them, and they can make an emergency plan with them. And so that if the person does lose consciousness on the phone, the person can enact the emergency protocols that they have set up in place with that person who they're talking to, and they're trained to be on the phone. They're amazing, they're essential, and I'm really thrilled Demas is funding Safe Spot. However, people that are going to use Safe Spot, first off, need a phone. They also need to be somewhere where they can use. And they also need to know that it exists as a service. And all of those things are true for lots of people will hopefully have that access, but there is always going to be a significant number of people that won't have access to a place to inject and a place to use a phone. So having a physical space where people can come in is also essential. Both of these things need to happen. Overdose prevention centers really target our highest risk and most vulnerable populations. We've spent a lot of time talking about that today. We need different types of interventions for different groups of people. They work. They're essential places of welcome. They bring dignity up to a population that are on the street and don't have that dignity in their lives. So.
Thank you. I appreciate that. And I'll just do one more question, please. So I am someone that actually, it's touching to hear all these stories, but I didn't need them for, to increase my compassion. What I do like is I like data and I like numbers. So can you please talk to me a little bit? A lot of people ask questions about what exactly we talk about the cost benefits, and are we actually going to get people to stop using, or percentages of that versus how that works in the real world, or where this kind of fits into that plan? I think might be important to see where this kind of center could fit into that whole plan.
A couple of things I like to explain to people because, not everybody has to be an expert on this stuff. And I'm not exactly an expert, but I've been around it for a million years. So I've heard a lot of things. And one of the things that I have heard is research, 2 longitudinal studies that looked at how long does somebody who uses injection drugs stay addicted to their injection drugs. And these are 2 very long studies that were done, one in Germany and one in Canada. Both were very similar in terms of what they found. People stay in their life of addiction around 12 to 14 years on average. That means what are we doing with people in that 12 to 14 years on average. Obviously, some people get out sooner, some people get out later. So first off, we have an obligation, I think, to treat people with respect and dignity and access to care during that 12 to 14-year period, knowing that that's the state of addiction. And roughly on average, that's what happens. So then we can make it so that people suffer and get gangrenous infections and lose limbs or die, or we can have places where people who are actively using can prevent disease and prevent the spread of infection. We also know that just because we have treatment facilities and just because treatment is available, people often go, like Mark said earlier, he went 20 times. People go to treatment all the time. They're in and out. It's a chronic relapsing disorder. And do you know how many people who go to treatment actually stay, quote, non-using, or whatever the term is, abstinent? Like 7% after 1 year. 7%. So how can we now say, oh, so an overdose prevention center is somehow meant to have a statistically higher chance of getting people to abstinence than the average system that we already have in place? Like, I think we put a lot of stock in this notion of abstinence that isn't actually real or reflective of the reality of what's happening with folks that are struggling with substance use. It's a process. It takes a long time. It takes many attempts. It takes a lot of love. It takes a lot of patience. And the whole blame and shame thing has not worked. Punishment doesn't work. Coercion doesn't work. And I think that we're suffering from the fallout of that with so many people just dying. So it's not working. And what we do know is love and compassion do work to keep people alive. And options, meeting people where they're at, all these terms get used all the time, but they're real and they're powerful, and I've seen it. I've seen people's lives transform when they're met with dignity.
Thank you. I really appreciate that, because what it sounds to me like is that you are offering someone a life while they make that journey instead of just letting them dip down.
Right.
I really appreciate that. Thank you.
So can I ask you a question? You've been in these conversations before.
Yeah, once or twice.
Yes. And how do and it's a situation where the society is ready. Society, the people who are impacted, the ones who know somebody who's directly affected, they know that the status quo is not working. You have policymakers who, some of them are getting it, understand this. There's hesitancy for a variety of reasons, because it's hardwired issue, the direct experience is not there, the data is made out, whatever the reasons are. What can we do, or allies do, to save and move to the next level for acceptance in the larger community and beyond? Because you've been in these thresholds. What else can be done?
I think we need to amplify the fact that there's bipartisan support for this kind of intervention. Like the last poll reflected 62% of the American population that were polled supported it. So I think we have to stop being afraid. And I think we need to start talking about it in the affirmative. This is something that needs to come as part of a continuum of comprehensive services for people struggling with drug use, right? It's not a panacea. It's a tiny little thing on a big continuum, and we need all of it. But we're missing that thing right now. So it's a gap. So it's not, you know, they don't cure cancer, but we just need to talk about it in the affirmative and not like run from it as if it's something to be afraid of. It's just an essential piece, kind of like Narcan's an essential piece. Like we need all of these things. Like you wouldn't just say we're only going to have methadone available and no Suboxone, or we're only going to have abstinence-based inpatient treatment. We're not going to do IOP anymore, or no, we're going to separate mental health out from supportive housing. Like we need all of these things. Like to me, it's not complicated. It's part of a package of a system, and we need all of it in place. And we don't have a problem understanding that for other diseases or other issues or other life journeys. We understand people's trajectories. But for some reason with addiction, there's all this baggage, right? Because of the past, the history, the morality, the shame, the criminality, you know, it's complicated. People are afraid of touching people who use drugs because they've been so historically dehumanized. We can't see them as people in their active addiction. We just see them as the drug. We look at a person, we see this drug. We don't see a human, you know? The drug doesn't rob you of your humanity. That's why we can do harm reduction education. We can talk to people about why it's important to use clean syringes and use safely, because they actually care about their health. Anyway, I kind of
Thank you.
answered all over the map there, sorry.
And can you help us about the stigma? What has the larger community been able to do to try and help with the stigma issues?
I mean, you guys tell me, was listening to all of this today helpful? I mean, I feel like listening to everyone's stories and having human beings put a face on their children and talk about their journeys, like, to me, that's addressing stigma, because we are failing to understand the context in which people's lives play out, right? So just having my coworker Cameron talk about the fact that he almost died, and now thank God he didn't, because I get to work with him every day. Like, it matters to me, you know, I'm really glad you didn't die, because you're doing great work every day. Not that he has to be doing great work every day for his life to have like family, but you know, but I'm still glad he's alive. I don't know. For us, even in Canada, getting people to understand why these issues mattered was always about telling stories, and telling stories that explain that people who use drugs are just people. We shouldn't be afraid of them. We don't need to be afraid of these issues. Yeah, big part of it. So these guys behind me are all the heroes telling their stories and sharing their suffering today. I think it made a huge difference.
Yes, thank you. Representative Claire Teacher has a question.
Thank you, Mr. Chair. Thank you for being here today. And to your point, I think it's vitally important for us and everybody, the general population, not just the legislators, to hear the stories, to see the people, to talk and explain and live, you know, through us, tell everybody your story, and don't stop. And I think what's also very important, people to understand, it's another tool in the toolbox. Just because it works for you doesn't mean it works for you, or doesn't. And it's the same thing that we say about college. College isn't for everybody, right? Some people go to trade, some people go right to school, some people go to the military. Everything works in their own way. Everybody has to go down their own path. And I think this is just another path, another option for people to find and hopefully be free in their journey. But thank you again for being here. Thank you, Mr. Chair.
Yep. Thank you very much.
Thank you for being with us throughout the day. Thank you.
Thank you for what you're all
Thank you.
doing.
I have to do this. The next person on the list is Sophia DeLuca. Welcome, Sophia. Thank you for being with us all day as well.
Thank you so much for having me. Co-chairs Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Sophia DeLuca. I'm a New Haven resident, I'm a graduate student at Yale School of Public Health, and I'm a volunteer at the Middletown Harm Reduction Initiative, a harm reduction nonprofit serving people who use drugs in the Middletown community. I am here today to testify in support of SB 1285, an act establishing an overdose prevention center pilot program. Already today, we've heard from legal experts, health experts, and most importantly, from loving family members who have lost the people that they care for the most. As a volunteer at the Middletown Harm Reduction Initiative, I have met countless people who would benefit greatly from an overdose prevention center. Just last week, I met a woman who shared her story with me. Recently, while walking down the street, she encountered a friend experiencing an overdose. She was not carrying Narcan, and her only option to save his life was to call 911. Thankfully, she was able to, and his life was saved. Stories like this happen daily, but many have very different ends. As we have heard today, some people are alone when they overdose. Some people are surrounded by people, but with no Narcan. Some people do not have the tools to test their drugs before they use them. And some people are afraid to tell their friends and their family that they have relapsed. It is clear to me from listening to the members of our community, both at harm reduction distributions where I volunteer and here today at this committee, that an overdose prevention center will save lives in Connecticut. As a public health student, I also know that listening to data is one of the most powerful tools that we have to show impact. And the data firmly supports overdose prevention centers as life-saving and health-improving tools. Studies show that people who go to overdose prevention centers experience a decrease in fatal and non-fatal overdoses, One study showed a 67% decrease in reported overdoses among those who used a center over a year-long period. It is not just overdoses and fatalities that drop at overdose prevention centers, but also risk for diseases like HIV and hepatitis C. These diseases can be transmitted through practices like sharing needles, and overdose prevention centers provide clean, sterile equipment that reduce risky practices like needle sharing. 3 separate studies found that there was a 70% decrease in needle sharing among those who visited centers. Overdose prevention centers also reduce hospital visits and reduce the burden on EMS services. We've heard this several times today, but I'll repeat it again. In New York, data from OnPoint, whose representatives we've heard from today, shows that within 2 months of opening, less than 1% of visits required any EMS services. This, to me, is a clear sign of fewer lives at risk. It's also a sign of cost savings to EMS and emergency room systems. And it's also a sign of EMS services being freed up to address other urgent community health needs. Overdose prevention centers are a necessary step for our communities in Connecticut. We would be far from the first to embrace this strategy. Nearly 150 overdose prevention centers in 92 communities around the world currently operate. I urge you all to vote in favor of SB 1285 and to allow our Connecticut community to join so many others around the world in embracing this life-saving step that protects the dignity and health of our friends, family, and neighbors. Thank you so much.
Thank you, Sophia. Right on target, like right exactly at 3 minutes. I love it.
I do what I can.
You got the data, got the personal experience, all of the things, and very, very helpful. Thank you for sharing and the work that you're doing, and you're doing it at the ground level as well. So that's very powerful that you're seeing this and sharing with us. Seeing no questions or comments, we'll move to the next person. Thank you for being here. Thank you for being with us all day.
Thank you all for listening. I appreciate it.
Susan Vidro. Thank you so much for being with us today. You've been with us for over 8 hours, right? Thank you. Welcome.
Hi. Good evening, everyone. Senator Anwar and the committee and its members in its respectful places. I am Jose A. Vidro, and I speak from the grave in the voice of my fiance, Susan Vidro. I died on August 4th, 2021 of a fentanyl overdose. It was given to me without my knowledge. I love spending time with my family and planning my wedding, and even making people laugh. As you can see, I was the jokester in my family. I enjoyed working every day, but now I am a cold corpse. If all who died from an overdose could speak today, I believe they would ask you to pass Bill BS 1285. I pose this question to everyone in this room. Are we not each other's brothers and sisters keeper? We may not be by blood, but we are all God's children. How many of us, if we walked into a room and saw our children or our parents passed out, will we not rush to call 911 to save their lives? BS 1285 is that 911 call to help save our brothers and sisters. As you have heard all the testimonies of today about data, I believe it's very important to open OPCs that are in need. As I speak for Jose, who does not hold an audible voice in this earth because I am his voice, there are many words that everyone can say, but I say, are we each other's brothers and sisters keeper? Substance abuse does not recognize gender, socioeconomic status, or color. It will at some point reach our doorsteps. Please do not wait to receive that knock at your door that will change your family dynamics forever. Will you help Connecticut be known for loving its brothers and sisters without the stigma of labeling our brothers and sisters as drug addicts or desire to keep them from dying of substance abuse disorder? In closing, I was a living soul. My name was Jose A. Vasquez. Help my living brothers and sisters remain alive and not in a cold grave. Thank you. My name is Susan Vidro of Grass Day, and I am Jose Vasquez's voice. And I also support for Cameron as well. Thank you and God bless you.
Don't go away yet. Wait for a second. Jose's A. Vasquez voice is powerful, it's beautiful, and we hear it loud and clear.
Thank you.
Thank you. Don Hemstock, welcome. Welcome. Thank you for being with us all day.
My pleasure. Good evening, co-chairs and members of the Public Health Committee. Thank you for the opportunity to testify today on behalf of For Cameron in support of Senate Bill 1285 for overdose prevention centers. My name is Dawn Hemstock. I'm a mental health professional with an educational background in community psychology. I have worked in mental health services, especially community-based services and programming, for over 20 years. I'm also here as a person with loved ones who have experienced opioid addiction and the trauma that goes along with it. Time and time again in my career, I've advocated for clients who tried to enter treatment because the precise right time had come for them to attempt the enormous hurdle to break free of the grip of opioid addiction, only to watch them turned away due to a lack of bed, treatment facilities, and then helplessly held them as they cried, saying this simple thing: I want to feel normal again. For years, we've been raising awareness of the need for increased services for this medical epidemic. And now we have a clear opportunity to add a proven, successful intervention. We have heard testimony about the benefits of the treatment intervention of overdose prevention centers, or OPCs. They prevent deaths from overdose. They are cost effective. They decrease crime rates and increase public safety. They decrease the burden on hospitals. And very importantly, and I'd like to highlight this here, they increase the likelihood of people entering detox and then rehab to overcome addiction. These OPCs save lives. They save lives. It is a dereliction of duty that a state agency with the words addiction services in its very name is refusing to address this public health crisis. It's outrageous. It's unconscionable. Connecticut has the ability to provide this intervention. Let's bring Connecticut up to speed as a leader in prioritizing this public health initiative. I urge you to support SB 1285. Let's save people's lives. Thank you.
Thank you so much. Thank you. Thank you for being with us all day, and thank you for your passionate testimony. We hear you loud and clear.
Thank you.
Thank you. Seeing no questions and comments, we move to the next person on our list, which is, I don't think Jenna is there, so I think Dr. Heimer is recovering for surgery. John Lally. John, you're on. You can turn your camera on too, John. Thank you so much.
Can you see me and hear me now?
Very well. Thank
Well,
you.
Thank you. Hello, my name's John Lally. And I want to first thank the committee co-chair, Senator Anwar, and Representative McCarthy Vahey, and other members of the Public Health Committee. But I want to start by taking just a moment of silence and reflection to think about the 3 lives we lost today in Connecticut to overdose. I want you to think about the individuals and their family, the community they left behind, that are all in pain and changed forever. I want to say I'm here to testify in support of Bill number 1285, an act establishing an overdose prevention center pilot program. I'm officially listed in my professional position as executive director Today I Matter, but I'm mostly here as a grieving dad. My son Timothy is dead. He died over 9 years ago from an opiate overdose, alone, lonely, without any immediate help. By the time his housemate came across his unresponsive body and called 911, the Narcan administered by the EMTs was too late to save him. His heart had gone into cardiac arrest, but the CPR was able to get his heart started again so he could be transported to the hospital. At the hospital, though, we were told he had severe cerebral anoxia. In other words, he was brain dead and not coming back. We sat vigil for him for 36 hours as we watched him deteriorate even further. My wife and my other son, Brendan, and I then had to make the hardest decision of our lives, which was to take him off the ventilator and let him go. So the staff disconnected him from the ventilator at our wish. My wife sobbed and she cried out, "I don't want to do this," jumping up and down. My son Brendan held Tim's hand and whispered in his ear. I placed my head on Tim's chest so that I could hear his last heartbeats to let me know when he left this world. That moment sometimes feels like it was just this morning, and it's changed my life forever. But Tim did not need to die. Tim didn't want to die, even though he suffered from opiate use disorder for a few years. He tried treatment a few times, and he did well for a while, but the disease overcame him, and he went back to using. You know, Tim's story is not unique. It's been repeated over and over again in this country almost 300 times a day now. But this is not necessary. You don't need me to repeat all the facts and figures about overdose prevention sites and how successful they are in saving lives and improving the surrounding communities. If you're not already on board, I hope you're now convinced that this is an important life-saving opportunity. But I want you to think about the personal toll. Imagine this was your child, your spouse, your sibling, your parent. Would you not want them to have every possible advantage to stay alive while they struggled? I think that you would. That's what we're talking about here today. Overdose prevention sites save lives. It's been proven over again, as you've heard. I wish my son had that option, but it was not to be. And he's gone. And I have to live with this for the rest of my life. Please consider passing this bill and preventing another parent from this agonizing and heartbreaking outcome. Thank you.
Thank you so much, John. Thank you. I have the blessing of knowing you well, and we have worked on a number of things together. John, can you tell a little bit about your organization, Today I Matter, and how you're fighting the stigma?
Well, thank you. We started Today I Matter. The name, I wanted to use my son in the name, TIM. So we came up with an acronym to Today I Matter. So we'd always have him as part of our mission. Our mission is to reduce the shame and stigma related to both mental health and addiction. We do that through a lot of public speaking. We do that through advocacy and educational opportunities. We've spoken to schools. We speak every year at the first year medical students at UConn. I've done grand rounds at Hartford Hospital. We speak to even Boy Scout troops and Cub Scouts, anybody that will listen to us, to help them understand the dangers of substance use and how it's related to mental illness. You know, my son Tim struggled with severe depression and anxiety to the point that he had panic attacks so bad he had trouble getting out of bed in the morning. And one day someone gave him a Percocet at work, And he told me, Dad, I couldn't believe how much better I felt. I felt calmer, I could get through the day. But those of us who know addiction know how that develops. One pill turns into 2 pills, turns into 10 pills. And next thing you know, his whole life is around getting and using because he's feeling desperate, he's feeling sick, he's feeling hopeless. So that's what we spend our time with on our mission for Today I Matter, as well as our best known thing is we have a poster project of now 640 full-size posters of people who have died from substance use. We've traveled around the country, been in Washington, D.C. twice to put a face to the numbers. You know, we heard facts and figures, and we've heard a lot of personal stories today. But we always got to remember that we're not talking about numbers here. We're talking about people that have families that are now suffering, whether those person is still using now or has passed from it. So we're hoping to do what we can. That's why I'm here today, to try to convince people that we got to save more lives. Every life is precious.
Thank you so much. Thank you. And you have elevated the voice, and we hear you loud and clear. Thank you so much, John. We'll move to the next person on the list. John Hamilton was here, but I think he's no longer physically here, but he's been here all morning and afternoon with us. Move to Kyle Fitzmaurice. Yeah, Kyle, you're online. You were in person earlier, but you're in the welcome. Thank you for being here with us earlier, and then thank you for joining us online. Thank you.
Good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. I have to pause and say thank you guys so much for allowing us to have this space. It is 8:30 on a Friday, and you guys are taking the time to listen to us, and I really do appreciate that. My name is Kyle Fitzmaurice, and I've been a resident of Connecticut my entire life. I recently started my family here as well. I've come here today to share why I am in support of Bill SB 1285. I work in Litchfield County as the harm reduction coordinator for McCall Behavioral Health Network. My direct work is with people who use drugs. In the last few months, myself and other providers have been doing some work and have gathered quotes from our community members, people who would directly benefit from an OPC being in their state. Here are 3 of those quotes. Quote 1, I appreciate you guys more than you know. People don't get it, but we're going to do what we're going to do. You give us a better chance at staying healthy. Quote 2, thank you so much for being here. You all save lives. I leave feeling human again every time I see you. Quote 3, I've been stressed lately and started using again. You're the first person who didn't judge me and just listened. The work is, as I said, outreach. We're in vans, on sidewalks, in houses or shelters. Rain or shine, it doesn't matter. For maybe an hour or two at any given site, we're out there connecting with people who far too often don't feel seen or heard or cared for. Every site has harm reduction supplies, food, warm clothing, access to treatment, and above all others, unconditional love. After our hour is up, we leave and we come back 7 days later. An OPC is a brick and mortar location where that unconditional love is no longer momentary, but present every time the doors are unlocked and the lights are on. If an hour a week from a van can create such a safe space, which is needed for any level of healing, imagine what 8 hours a day could do. Today, you've heard from my colleagues a lot of statistics and evidence-based data telling you how OPCs save taxpayer dollars and, of course, lives, and offer such needed access to treatment and so much more. But from a person who simply cares about their community, however, respectfully, we shouldn't need to say any of it. Our neighbors are dying. Each death is the loss of somebody's someone, and OPCs can help prevent that loss. I'll leave you with a final quote that someone shared with me recently after losing a friend to an overdose. This is a quote that wouldn't have to be spoken if there was an OPC in place already. That's the worst part about this life out here. You never know who you'll wake up without next. Thank you.
Thank you so much, Kyle, for your testimony, and thank you for being with us earlier and your very powerful words. I don't see any questions or comments. We hear you loud and clear, and thank you. The next person on our list is Robert Loftus, Goldbelly. Sorry, with Goldbelly organization.
Hey, how's it going? My name is Rob. I'm a person in long-term recovery. Really grateful that I get a chance to speak on this. I am in full support of having safe injection sites being opened up. And just from my own experience, I didn't have an extensive history of opioid use when I was in active addiction. But the unmanageability and just the utter hopelessness was still there. And granted, like, complete abstinence isn't a method of recovery that everyone can attain. It's one that I practice simply because that's what works for me. But there's so many avenues to recovery, to harm reduction, etc. And this would provide a place where people could not be stigmatized, could not be judged, could not be subjected to the shame and guilt that a lot of addicts and alcoholics experience, because that's the stuff that really keeps us out there and keeps us using. I know for myself, like, my own shame and guilt kept me away from recovery for a very long time. And I can't express enough, like, just how much in support of this I am. And over the years when I was using, of course, I would see the occasional documentary about how their safe injection sites are opening up and all that, and looking up all these alternate methods of recovery. And I always wondered, like, why can't the United States have stuff like this? And it always deeply puzzled me. And to see this, like, starting to gain traction here is really inspiring, and it gives me a lot of hope for the future, and a lot of hope for for the next person that might not make it out of the trenches, that might not wake up to. You know what I mean? I've lost, like many people have shared tonight, I've lost countless friends, loved ones, family members, all to this disease. And that it is a disease. It's categorized in the DSM-5 as a disease. And it's so sad when someone doesn't make it through this, when they could have had a chance at a better life, and just another day, and they're not here to tell their stories. But that is all that I have to say tonight. Thank you again for letting me speak.
Thank you so much, Rob. Thank you for staying with us, and thank you for your testimony. Seeing no questions or comments, we'll move to the next person on our list, which is Fiona Cullinan-Ferrin. Fiona, welcome. Thank you for being with us all day as well. And Isabel was great as always. Thank you for all you guys do.
Thank you. Good evening, co-chairs, ranking members, and distinguished members of the Public Health Committee. My name is Fiona Cullinan-Ferrin. I am the president of Fort Cameron and a mother of 5. My greatest role and blessing in this life, but only 4 of them are here. My son Cameron became addicted to opioids at 13 after being prescribed them for a football injury. He fought bravely for 14 years, working towards recovery and studying to become a social worker in addiction. After a period of progress, anxiety took hold. In a desperate moment, Cameron bought what he thought was an OxyContin, but it was fentanyl. Ashamed, he hid his struggle. That night he waited for us to go to bed, and he took the pill alone. Cameron was smart, he was kind, he was very responsible. What angered him most was the stigma surrounding addiction, the belief that it's a choice, but addiction is not a choice. Cameron's opioids were prescribed by those who profited for them. And for those who experiment, addiction quickly stops becoming a choice. We don't shame other health conditions the way we shame substance use disorder. Yet for those battling addiction, one mistake can be fatal. Overdose prevention centers don't encourage drug use. They save lives. We all want people to recover. We all want people not to use drugs, but they can't recover if they're dead. These centers act as a bridge, keeping people alive long enough to seek help. People are already using drugs in public, not because they want to, but because they fear overdosing alone. Are we comfortable with children becoming desensitized to witnessing drug use in the open because we refuse to designate a safe supervised space. These makeshift space use sites already exist. The question is if we want them supervised or not. As the anniversary of Cameron's death approaches, I ask, how many more lives must be lost before we take meaningful action? This is a public health emergency. Overdose prevention centers won't just save lives, they'll provide real-time data to drive real solutions. Right now, the only data we have reflect those who've already died, not those who are currently struggling. It's time to act. I urge you, please, to support Senate Bill 1285. As I end my testimony, and as we end this evening, I'm going to ask you to join me for just a few seconds. Please, let's hold space for those we've lost, for the advocates here, bravely fighting for change, and for this committee, for your grace and your willingness to listen to all of us tonight and to consider action. By supporting this bill, you will save the lives of Connecticut residents. Thank you. Thank you.
Don't go away yet. Thank you, Fiona, for you have been doing a long time, and I see that your board is getting bigger, your voice is getting stronger, and people are listening. What changes have you seen in the last few years in our society as you go around fighting the stigma and raising awareness and opportunity for protecting our communities?
Thank you.
So what changes have you seen in the last few years? I sense that people are listening. Do you see that?
Thank you. We're honored that we can do what we do. We're trying to educate, we're trying to save lives, we're trying to talk to young people. We've just gotten the New Haven Police Department to carry Narcan. That took us 3 years to bring that forward. We're working on a fatal overdose task force. There's things that we are doing, but we're still losing people every single day, and that's really, really, really hard. So, I welcome the opportunity to be here, but I just hope that we can do more.
And we will. Thank you so much.
Thank you.
Seeing no other questions or comments, thank you for being with us and thank you for raising the voice. Thank you. Catherine Dunham. Welcome, Catherine. Thank you for being here. Thank you for being with us all day.
Thank you. And thank everyone here. I feel very lucky to be here today. I learned a lot today. But I'm Catherine Dunham. I'm here in strong support of Senate Bill 1285, an act establishing an overdose prevention center pilot program. I'm a harm reduction worker turned public health researcher. Currently, I work in Rhode Island and I conduct research at the Brown School of Public Health. Specifically, I work on the country's first federally funded evaluation of overdose prevention centers. I was lucky enough to be at the OPC in Providence just yesterday, and I'll say that when you walk into the space, the actual consumption space, on the biggest wall there's this beautiful mural that says, "Health, safety, and support live here." That's what an OPC is. I've conducted multiple literature reviews on the public health impacts of OPCs, including for opcinfo.org, which are the bluish, purplish sheets that have been floating around today. I've also served as a first author on a position statement in support of overdose prevention centers from MRSA, a national organization for substance use clinicians and researchers. And if I could boil all those pages of research down and all those data points, health, safety, and support, that is an OPC. As I'm sure is completely clear from today, Connecticut is home to some real harm reduction giants. Senator Anwar, I think you said rock stars this morning, and I agree. And I was very lucky to learn from these giants when I was getting my master's of public health here at the Yale School of Public Health. During that time, 2 years ago now, I was able to support the similar bill that was introduced by Senator Anwar. And now more than ever, I believe we need to be bold, compassionate, and evidence-based in our responses to the overdose crisis. I believe that establishing overdose prevention centers in Connecticut is an opportunity to do just that. And not for nothing, every single person who has spoken today about SB 1285 also believes that establishing OPCs in Connecticut is an opportunity to do just that. If I could underscore 3 points in support of an OPC pilot program from today. First, extensive research, including recent findings from the United States and longstanding findings from across the globe, have demonstrated the positive public health impacts of OPCs. These sites reduce overdose-related mortality and are an especially important tool in the toolbox in preventing fatal overdoses involving fentanyl and xylazine. Other benefits of OPCs include reducing the transmission of infectious diseases, providing clients with a space for community and social connection, and linking clients to additional support services, including substance use treatment. During the first year of operation at the 2 OPCs in New York, 100% of participants who were interested in treatment were connected to treatment. Second, extensive research has demonstrated the positive community impacts of OPCs. Research has shown that in the area around the site, OPCs reduce instances of public drug use, reduce drug-related litter, save money, and are not associated with any increases in crime. And third, just to say it again, Connecticut is and always has been home to some giants of harm reduction. This state has a long history of bold and groundbreaking harm reduction initiatives, including syringe service programs, which have had positive public health outcomes far beyond Connecticut. Syringe service programs were once seen as radical. They were once an illegal gray area, but today the public health benefits are undeniable, and I really believe an OPC pilot program would be no different. It will also be in really, really good hands, hands that will ensure that the site is ready to save lives and meet the needs of people who use drugs in Connecticut. Again, thank you so much for your time. I want to be mindful of everyone's time, so I'm happy to answer questions, including some that were brought up earlier by Representative Zupkis. But I will also make a plug, opcinfo.org. That, again, is the bluish-purple fact sheet, but that is a great resource. You can get fact sheets like that, data like that, but you could also submit a question that will be answered by a public health researcher who is an expert in this field in a matter of days. There's also videos of overdose prevention centers, pictures, just to sort of demystify it. So highly encourage that too. Thank you.
Thank you so much for your testimony. Thank you.
Thank you.
From a public health committee perspective, this is like late morning. Our committee meetings, public health, public hearings last much longer. So this is like a late morning for us. That's why you see all of us are so fresh.
I'm pressed, yeah.
Yeah. So we have a few questions, so we just wanted to go over them with you, but I wanted to ask my co-chair to start with the question.
Thank you, Senator Anwar. And thank you very much, Catherine, for being here.
Thank you.
Something you just said, federally funded evaluation.
Yes.
So who's funding that and how? Because I think something you said is very interesting and notable.
Mm-hmm.
That every single person testifying on this issue today has been in support, that doesn't always happen here. There is testimony in the written testimony that raises concerns specifically about the federal law. And I think that's really the nexus that's really the main center of concern here with people, some of the people who are raising red flags. I am not hearing people making the argument that they think overdose prevention centers don't work. That's not what I'm hearing. I am not hearing people say that this is not something that they want to do to save lives. I'm hearing people say that there is a federal law that they're concerned about. And we had testimony from one attorney earlier in the day, as you heard, the attorney from Temple. And we've heard people talk about the change in the administration leading to even more concern related to the federal law. So can you talk to us about how the federal funding of the evaluation works and what that connection is there?
Yeah, it's a great point. It's funded by the National Institute of Health. The study is called SAFER. It is this multi-site study, again, in Rhode Island and New York City, that's looking at many different aspects of OPC implementation, federally funded, like I said, for 5 years. And we'll be looking at things like health incomes, cost effectiveness, community impacts, pretty much everything you could look at, we're going to be looking at.
So a follow-up to that, the status of that NIH grant?
It's
Is it-
ongoing, knock on wood.
Okay, so I mean, I know there's just been a lot of news about a lot of things, so at this point, nothing is changing for you with that.
Exactly.
Okay.
Mhm.
No, I appreciate that. That's actually very helpful information. And
Thank
thank you. Thank you, Senator Elmore.
I understand you're in Rhode Island nowadays,
Yes.
and then you came here and stayed with us all day just so you can tell us about the good work.
I'm happy to.
And you were involved in some of the research, and you've talked about Connecticut being a place of giants for being in harm reduction. How did we get dwarfed by everybody else around us?
I think
And when you give your answer, make sure you give your answer, because I want the agencies to hear this in the state of Connecticut. And at the top level, on every level, because the reality is that we have been a giant, and why are we being dwarfed when people are dying in our communities?
Mhm.
And this is a very critical issue, that the science is there, the giants are there, the giants are going to other states and making them giants.
Yes. Uh-huh.
And but in our own state, we are actually trying to hide behind I don't know what. So help me understand this, and perhaps they will understand too.
I think it's time for change. I think I totally understand the idea of an overdose prevention center pilot program.
Time for change of agencies, or
Say it again.
time for change for what?
I think time for change on the stance of like, let's sit and be happy with the status quo. I think fairly you are giving, and people today have been giving Connecticut a hard time for being so far behind. I think that's fair. I do think one benefit of it, though, is at this point, there are places in the United States and globally that have done this and have made it work. And there is so much to learn from each other in that. I know in Rhode Island, we couldn't have done it without the help and the information from New York. I know cumulatively, we all couldn't have done it without the help and information from Canada and around the globe. It is an amazing thing that if this bill were to be passed, the implementation, which people have said is so crucial, would benefit from everyone else having tried it and having figured it out.
So OPCs are infectious disease that started from Canada and now infecting New York and Rhode Island, and Connecticut will be infected soon.
I think a really good one, yes.
Good. I think you haven't.
No, everybody is ready to go, and then here I am. It's very typical, Kristen McCarthy Vahey. Something I think it was AJ said earlier, which really struck me as a social worker myself, is relational organizing.
Mm-hmm.
And I do think that, and I have during this hearing reached out to the Attorney General's office to ask that they speak to the Attorney General in Rhode Island.
Mm-hmm.
And I would love if you have, connections in the Rhode Island agencies to ask that there be conversations, same at any level
Mm-hmm.
of government, because I do, again, this is why we're a team, we're the yin yang.
Mm-hmm.
I think that we need to find a way to help people get to yes, as I said earlier in the press conference. And how do we do that is hopefully by building those bridges and creating those relationships and giving people the cover for the concerns that they have. Because I think there's a tremendous will here to do this. And I think there are a lot of people who are ready at the grassroots level to make this happen, obviously. So I just thank you for letting me take that extra moment, Mr. Chair, and a tremendous thanks.
Yeah.
To
I'd
every
be happy to
person.
connect.
Just one more,
Yeah.
one more thing.
Sorry.
Sorry. I just want to say a tremendous thanks to every person who did share your trauma, your experience, your loss with us so that we could hear and listen and learn. So thank you.
Yeah, I would be happy to make those connections. Again, I'm coming from the more research evaluation side, would be happy to make those connections. Project Weber Renew and AJ, who spoke today, they are an invaluable resource. The work they are doing is absolutely amazing. And they are really the experts on this, I think. They will be able to, they've gone through the concerns like, what if a minor is in the site? Can a minor be in the site? They have gone through all of that, and they have come up with protocols to deal with concerns like that. It's not a hypothetical for them. They really are a wealth of information, and I'm so glad that you're connected with them.
Very much so. We have looked at the regulations. We have looked at all the process. Even our bill is somewhat following the pattern of Rhode Island.
I
So-
thought so.
Yeah,
Uh-huh.
and it's the idea has been there for 40 years, but how Rhode Island is doing it is very different than how New York has done this. But I think Rhode Island is so close to us that we feel this is closer to our state as well, and understanding, and then perhaps there's an opportunity. We're not built exactly like Rhode Island, but Connecticut has its own areas, and that's why it's modified a little bit, because we have centers, 4 different bigger areas. Rhode Island is just one area because how they are set up geographically and from population perspective. So we have used the examples of all of them to try and do the best thing that we can. We'll have more conversations as we move forward in this journey. I don't see any more questions from our members. Thank you for being here. Thank you for your testimony. And as you leave, I'm just going to make comments, not to you, but to everybody else as well. I think we've had a very meaningful day today in our public hearing. We can't thank each and everyone who has come. The conversations are painful because we are talking about losses. We are talking about our loved ones not being here, but making sure their voices are still heard. We heard about data. We looked at it from a scientific point of view, legal point of view, and in all different aspects. And every time there's a public hearing, no matter if the issue is something that's closer to, at least I'm speaking for myself, me or not, if I agree with it or disagree with the issues, the public hearings change you. We don't know, and to Mark Jenkins' point earlier, that we meet people where they are, but we do not necessarily leave people where they were. We all move in certain directions. So, and I think I feel more moved by all the people who have come and spoken, and I value each and every person. And I also want to acknowledge my colleagues who had to be at multiple meetings, but they're physically here. They could have been in a remote position too, but there were multiple meetings going on, and they're still going on, by the way. And then they're here to listen to you. And I cannot thank you, each and every one of you, for being open-hearted and listening and always being there. It's not like the first time. We may at times appear like we disagree, but we work very well together. This is one committee where in the last year, almost every single bill was a bipartisan bill. And we probably may have a mechanism to show people in our rest of this building that we agree, but we disagree, but we work together and we find the best solutions together. And the people who spoke, you're worth it in every aspect. And the message that you gave was so worth it that we will roll up our sleeves and do what needs to be done. Status quo is unacceptable. So I could speak forever. It's late morning. That's why. But thank you with that. If Madam Chair, you want to have the last word? Okay. Good evening. Go home. Thank you.